Good morning, everyone. Good morning.
Good morning. Good morning, madam.
Good morning.
Good morning.
Good morning,
Good morning,
all.
everyone.
Good morning, good morning, morning. All right, good morning, all. I welcome you all to the third International Conference on Dentistry. Sorry about that. All right, I welcome you all again to the third International Conference in Dentistry and Oral Health organized by BioLeagues Worldwide, Instituto Prime Cursos Brazil, VYWS Dental College, and Hospital Amravati, Maharashtra, India, Maharashtra Institute of Dental Science and Research, and Asia Pacific Association of Dental and Oral Health. Just a little bit about APADENTO. So APADENTO stands for Asia Pacific Association of Dental and Oral Health. Is one of the non-profitable professional associations aimed at serving dentists, academicians, doctors, and practitioners in the field of dentistry. For sharing and exchange global innovations and act as a bridge between researchers and academicians by organizing world conferences, international conferences, workshops, seminars, providing membership and establishing chapters in different universities and colleges worldwide through our globally distributed executive members to reduce the gap between curriculum and their practical implementation among students and research scholars. APADENTO aims to bring together all dental professionals to encourage intellectual development and providing opportunities for networking and collaboration. And a little bit about our organizers. BioLeagues Worldwide is a not-for-profit professional association which prominently promotes research and development. We at BioLeagues have brought a revolution in the field of worldwide conferences. BioLeagues worldwide conferences bring together the professional wizards and leaders who have explored all avenues to reinforce the field of life sciences and medicine technology. BioLeagues Worldwide conduct events worldwide which help in enhancing the skill set of the people from diverse industries and also forms a common platform for eminent personalities, physicians, researchers, doctors, and academicians, professionals, business figures, and many, many more. BioLeagues conference encourages better comprehension about improvements and progressions over the world through worldwide conferences with the speed of science and technology. We work with our motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development. Oral health contacts each part of our lives, however, is frequently underestimated. Our mouth is a window into the health of our body. It can show signs of nutritional deficiencies or general infection. Systemic disease, those that influence the whole body, may initially turn out to be evident on account of mouth injuries or other oral issues. Considering the importance of oral health, BioLeagues Worldwide welcomes you to participate in the third International Conference on Dentistry and Oral Health, to be held virtually live here and in Zoom from August 21 today up to August 22 tomorrow, 2021, with the theme Advances in Dental Technology and Oral Health. It will provide all participants an opportunity to exchange knowledge, share ideas, and collaborate on new researches to strengthen and develop the advancements we've achieved thus far, thereby improving oral health in the region and throughout the world. This third international conference on dentistry and oral health would like to enlighten the participants on the needs and uses of the latest technology in the field of dentistry, along with its importance for the economical growth of the society and the positive treatment ideas which are valuable for the healthcare of the society. The conference invites participants from all leading universities, clinical research institutions, and diagnostic companies to share their research experiences on all aspects of this rapidly expanding field and thereby providing a showcase of the latest dental techniques. Now, I would like to welcome all our honorable dignitaries. For conference chair, Dr. Rajesh Vasant Gandhalikar, Dean, Professor and Head of Department of Oral Pathology and Microbiology, VYWS Dental College and Hospital, Amravati, India. Our conference co-chair, Dr. Ashish Pandey, Director of the Administration,
Hello.
hello sir, good morning. Our conference co-chair, Dr. Ashish Pandey. Director, Professor, and Head, Prosthodontics Department, Daswani Dental College, Rajasthan, India. Good morning, sir. And for our welcome speech later, Mr. Rudra Banu Satpathy, CEO, Technorit Group, India. Also, Mr. Sid Kumar Chajer, Managing Director, Technorit Group. And also, I would like to welcome our guest speakers, Dr. Sunil Agrawala, Professor and Head, Department of Surgical Oncology, IMS, and SUM Hospital, Bhubaneswar, Odisha, India. And also, I would like to welcome our eminent keynote speakers, Dr. Sandra R. Colson, Orofacial Myology Therapist, Colson Institute of Orofacial Myology, Denver. Dr. Ruchi Buyan, Additional Director, Research Health Sciences, IMS, SUM Hospital, Professor at Siksha O. Anushandan, deemed to be University, India. Dr. Padmanabh Jha, Associate Professor, Department of Conservative Dentistry and Endodontics, Subarti Dental College, India. Dr. Lyubov Smagliok, Professor and Head of the Orthodontics Department, Ukrainian Medical Stomatological Academy, Europe, President of Ukrainian Orthodontic Society. Dr. Kleber Mirles, Professor, Department of Orthodontics, Institute of Prime Cursos, Brazil. Also, Professor Dr. Eduardo A. Dainesi, Scientific Director, Instituto Eduardo Dainesi, Brazil. Guest Research Professor, USP, Brazil. And also, welcome to our session chairs, Dr. Ashta Arya, Professor, Faculty of Dental Sciences, SGT University, Gurgaon, India. Dr. Anshul Arora, Associate Professor, Faculty of Dental Sciences, SGT University, Gurugram, India. Dr. Arpit Sikri, Associate Professor and PG Guide, Department of Prosthodontics and Crown and Bridge, Bojia Dental College and Hospital, India. Dr. Suresh Kambal, Principal, Maharashtra Institute of Dental Sciences and Research, Dental College, Latour, India. Dr. Bennett Aloysius Fernandez, Senior Lecturer, Faculty of Dentistry, Segi University, Malaysia. Dr. Chaya M. David, Professor and Head of Department, Dayananda Sagar Dental College, Bangalore, India. Dr. Shweta Chaudhary, Pedodontics and Preventive Dentistry, Associate Professor and Postgraduate Guide, American Heart Association Certified Instructor for BLS and ACLS courses, India. Dr. Deepak Baya, Professor and Head, Department of Pediatric and Preventive Dentistry, Hitkairini Dental College and Hospital, Jabalpur, India. Dr. Tarulatha Shayagali, Professor and Head, Department of Orthodontics and Dentofacial Orthopedics, Hitkairini Dental College and Hospital, Jabalpur, India. I welcome all our eminent honorable dignitaries for joining us even during this pandemic situation and imparting their expertise with us. I would also like this opportunity to welcome all our presenters from across the globe who have spared their valuable time in enlightening us with their latest research studies. And I would also like to welcome all of our attendees in joining us today. And my apologies if I will be pronouncing your names wrong, just correct me, all right? And now I would like to welcome our conference chair, Dr. Rajesh Vasant Gandhalikar, Dean, Professor and Head of Department, Department of Oral Pathology, VY Pathology and Microbiology, VYWS Dental College and Hospital, Amravati, India.
Thank you, ma'am. Good morning, all. I welcome you all for the third International Conference on Dentistry and Oral Health. The Vidarbha Youth Welfare Society's Dental College has a proud privilege of being the first private dental college in Maharashtra, India. Since 1989, this institute is providing excellent academic ambience to undergraduate, postgraduates, and PhD students. We are also catering to the needs of dental health to the general population of this area as well as the tribal area of Melghat. The Vidarbha Youth Welfare Society always prompts and encourages research activities in this area of Maharashtra. Hence, we feel honored to be organizing team of this conference with BioLeague, MIDSR, Apardent, and other co-hosts of this conference. I thank all the speakers who will be presenting their work and sharing their knowledge from this platform. I like to congratulate Mr. Rudra Bhanu Satpathy, CEO, Technocrat Group India, and Mr. A. Siddhakumar Chajir, Managing Director, Technocrat Group, for their dedication and determination for organizing such a wonderful conference. I am sure all the participants will definitely benefit from this gala event where each aspect of dentistry will be covered and discussed. Wish you happy learning. Thank you.
Thank you so much, sir. Now, for her welcome speech, our conference co-chair, Dr. Ashish Pandey, Director of Administration, Professor and Head, Prosthodontics Department, Daswani Dental College, Rajasthan, India. Okay. For next, a welcome speech from our very own Mr. Rudra Bhanu Satpathy, CEO Technorit Group. India.
Hello.
Morning, sir.
Sorry, Dr. Ashish Pandey speaking right now.
So please
Oh,
continue, sir.
Oh,
continue, sir. Good
thank you so
morning.
much for that. Good morning. Good morning to each and every person who is attending this conference. Myself, Dr. Ashish Pandey, Director in the Daswani Dental College and Hospital, Kota, Jaipur, Kota, Rajasthan. Sir, we look forward to welcoming you to the first ever virtual third international conference of dentistry and oral health. While we regret that the COVID pandemic prevented us from holding the conference in any city, we are excited about the opportunity of holding an innovative virtual conference. This is the first conference which will be organized virtually. It will be a great opportunity for International Conference of Dentistry and Oral Health to explore new frontiers in early intervention as well as using digital and social media during the pandemic to reach a wide audience across the world. The conference will establish scientists, clinicians, people with a lived experience in dental health problems from around the world to present innovative and culturally significant research and clinical innovation in youth oral health and early intervention. The promotion of dentistry and oral health is not just a specialist, but for everyone in the community, including the people with lived experience, clinicians, educators, scientists, and industry. Reaching new frontiers requires fresh vision and novel strategies. Producing the conference online fits perfectly with these aims as it will allow it to keep registration fees to a minimal and reach wider audience than traditional conference can possibly include. The virtual conference represent an opportunity of International Conference of Dentistry and Oral Health to inspire the world with a perspective of hope in prevention research in therapy and services organization in oral health. We are certain all of you find the conference
ये तो
stimulating, rewarding, and meaningful. We are looking forward to warmly welcome you to the third International Conference of Dentistry and Oral Health 2021 virtually. I also want to say our special thanks to Mr. Rudra Bhanu Satpathy, CEO of TechnoEdits Group, for his support and guidance to make this conference a great success. And also want to thank Mr. Sid Kumar Shajjar, MD of Technocrats Group, for his help and support. I wish all the best and good luck. Thank you.
Thank you so much, sir. My apologies earlier. Now, let us hear from our very own CEO Technorit Group India, Dr. Rudra Shanu Satpathy. Morning, sir.
Good morning. Thank you very much, Joseph, for the privilege once again to let me speak at this brilliant forum of all dental professionals who makes us smile and look good today. I wish everyone a warm welcome to our third International Conference on Dentistry and Oral Health. I express my gratitude to the Institute of Maharashtra Institute of Dental Sciences, as well as BYWS College of Dental Science. I wish my warm regards to Dr. Rajesh Vasant Gondalgar, sir, Department of Oral Pathology and Microbiology, and Dr. Ashish Pandey, Director of Head Prosthodontic Department, Daswani Dental College, Rajasthan, India, for his warm greetings and valuable words that made us energized today to serve our delegates and clients amid this pandemic duration. In fact, we feel privileged and we feel proud once again to state that since the globe has undergone the threat of COVID-19, this is 209th international conference we are organizing, and in different fields. I mean, we work on field of cancer science, neuroscience, nursing, pharmaceutics, dental science also. And we are collaborating with institutions and universities all across the globe to create an integrated global platform for life sciences and research, so that the innovative ideas of our country and innovations inculcated in different nations and different entities and different countries in globe could be integrated in a common platform, and this could be brought technically advanced and refiltered once again. So this international conference, third international conference on dentistry and oral health, is mainly a theme-based conference based on Indo-Brazilian relationship for dental research. So we have collaborated with renowned institutions from Brazil, like Prime Courses, Institute Prime Courses Brazil. We have we are privileged to get collaborated with VYWS Dental College, Amaravati, Maharashtra Institute of Dental Science and Research with Maharashtra groups of institutions and Maharashtra Institute of Technology, MIT, ADT University. We have our old connection with that management also. I think this is the fourth time we are getting associated with the university. When the university was newly established at Loni, I was invited to the university's inauguration, and I have good connection with the management also. And Asia Pacific Association of Dental and Oral Health is a unit of Technomerit Group and a BioLeaks that unites and integrates clinical practitioners, academicians, and researchers all across the globe, and take their ideas and take their innovations to global platform through our international conferences and publications. So at upcoming days, we are rendering institutional, we have a scheme called INST GAP, Global Academic Partnership. In this scheme, where we can partner with all the academic institutions and bridge them with nodes of connection through a common platform where the students and innovators and professors and researchers from these universities get a privilege, get a scope to globalize their innovation at a common platform by sharing their knowledge, and with mutual consultation. There will be definitely a research and academic revolution we are expecting in upcoming days. India being 7.8% of contributor in academic research articles since 2019 COVID pandemic. We have a statistic analysis, our survey analytics team made a survey in which in year 2019, when 21% of research articles published in life sciences were contributed from India. So even though we have underbeen the threat of COVID-19, so now also we have 7.8% of contribution toward world research articles and world research publication, which I believe is not a small number. For that, our researchers and scientists and health professionals are working hard. I greet the medical professionals from all disciplines, and at a very rapid rate, we are collaborating with institutions, and we are encouraging professionals and personals, doctors and practitioners for their career building through our platform. And we are very soon launching a common integrated platform for all researchers, where all the necessity and all the needs of academic interaction and globalization of innovation could be easily achieved with a fingertip. So we are coming up with some technology with integrated artificial intelligence and machine learning that will help us to integrate, connect, and reach, share, speak, talk, and learn a lot of things in different professions and different fields. So we have more than 11 associations, starting from diabetes, cancers, neurosciences, as I said, pharmaceutics, nursing, dental sciences, in which we are very aggressively working. And I really feel proud to state that we have more than 40,000 plus professionals members, and we are integrating them at a very rapid rate. And with the vision of getting our research paper developed and properly cited and published at global high standard journals, we are also releasing periodical publications indexed in Scopus, Web of Science, and PubMed also. And rapidly, we are providing these valuable services to different professionals, students, and researchers of publication of their articles. We are also assisting researchers for proofreading of their articles and how the articles could be developed and made of global standard. We are also connecting with institutions and other agencies, those who work on this development, to gather medical data and informations, and bridge them with better understandings and algorithms that would really help us for better trials and implementations in health sectors and industries. We greet everyone, and I express my hearty gratitude to all the valuable keynote speakers. We have a big number of keynote speakers, keynote talks lined up in this conference, and I express my hearty gratitude to all the institutional ambassadors and professional members, executive council members, and national ambassadors from different countries, those who have represented our organization in their nation to bridge this conference and make this conference reach to nook and corner of the globe. And we really feel glad to state that we have more than 300 plus presentations, scientific presentations by our doctors and deserving students. And we received more than 600 plus articles which were shortlisted, and the values were checked, because we always keep priority on the standards, and our global standards and norms are fixed, and our policies are fixed, so that we bring the pure and quality research works to our global forum. I believe this conference is being watched from different countries, different international profiles, international professionals, and it's being streamed in our social media channels and being broadcasted in our dashboard also, with all infrastructure to provide A to Z academic need, professional need of academicians, researchers, and practitioners. We are one of the largest professional organization of Asia, and I express my hearty gratitude to all the doctors, dental professionals, those who have contributed towards this conference, and my hearty thanks and my love to my beloved colleagues and my associates and partners, those who have been supporting this conference. And I hope this conference will be a valuable event, and this will add values and knowledge to your diaries, and it will be informative as well. In the upcoming days, we will be also trying to initiate more and more life sciences activities that will be definitely useful for everyone. And this pandemic time, I pray to Lord for a healthy life and safe life for all medical professionals. Still then, few words from Bhagavad Gita is reverberating in my mind. Sarve bhavantu sukhina, sarve shantu niramaya, sarve bhadrani pashyantu, ma kaschid dakha bhavet. This is the thought process of Sanatan Dharma, the thought process of religious belief of India, which prays for the welfare and well-being and good health and good mental state of mind of all and everyone all across the globe. I wish everyone all the best, and I hope this conference will be useful and valuable for everyone. Thank you very much.
Thank you so much, sir. Now I would like to welcome Mr. Sid Kumar Chajer, the Manager Director, Technorit Group, for the welcome speech.
Joseph, he will be not available, so we'll move to the next.
Okay, so let's welcome our guest speaker for today, Dr. Sunil Agrawala, Professor and Head, Department of Surgical Oncology, IMS and SUM Hospital, Bhubaneswar, Odisha, India. Good morning, sir.
Good morning. Good morning, everybody. Are you able to see my screen? I'm sharing my screen. So
yes, sir.
Okay. So I hope like I'm quite an audible one.
Yes, you are. Please proceed.
Okay. So to begin with, thank you very much. Thank you, the organizing committee, and thank you, Mr. Rudra, who has given me this opportunity to speak on behalf of this fantastic conference. This is an international conference where we get an opportunity to present our own data and our own experience on the international forum. So to begin with, I am the opening batsman of this conference. So I hope so, like I will keep that interest and keep the ball rolling so that my next colleague and speakers will be keeping up the pace and keep that interest of the conference, and people, those who are putting their time and effort in this conference, will be benefited. I've been stipulated only 15 minutes time, so I'll be finishing it up within 10 minutes so that 5 minutes will be spared for a good and healthy discussions, which is most important rather than I'm giving my inputs into this conference. So to begin with, I have chosen this topic of cancer buccal mucosa because of the two reasons. One, the maximum participant is from India. So, and this is the most common malignancy which we see. And this is the malignancy where the dental people are much more integrated. I mean, they are involved into this, starting from identification to the maxillofacial surgeon who is operating on this one, getting the principle how to operate. Then comes the reconstruction part, where the prostho and orthodontist people are also getting involved. And most important is that the BDS, those dental surgeons who are just passed out, they are seeing these patients post radiation and in rehabilitation. So that's why I've chosen this topic. So what I'm going to complete in this 10 minutes is that, so I will be covering, I will be showing some important, only the photographs, and I will be not talking much of the theoretical part. And in that photograph, I will be telling what I mean to say in my 10 minutes of presentation, that what we should do if we are getting a cancer buccal mucosa, when not to do anything on this people and on this cancer, and when operating, that what should be the margin and how we should reconstruct it. And in that, I will be covering the whole thing which I want to say. So to begin with, this is the patient who is having bilateral buccal mucosa lesion is there. And so we are doing a bilateral selective neck dissection. That's a supraomohyoid neck dissection. That's quite a simple one. And this is just, I'm showing on one side that lesion is there. And this is on the other side, the lesion is there. And this is after removing out, doing a marginal mandibulectomy and keeping the contour of the mandible and removing it. And that's the picture where we have removed and we have kept the central part and doing bilateral supraomohyoid neck dissection. And then comes the most important part of the reconstruction. So that's the facial artery which we have preserved, and we work in as a multidisciplinary team where our plastic surgeons are also getting involved into this one. And I must say that we are having a teaching institute, university institute, where we do give both from basic educations in the terms of our basic medical degree, which is called an MBBS, to an MCH course in surgical oncology. So this is the facial artery which been preserved, and the facial vein which has been preserved. And since it's a unique case of bilateral one, we have taken a bipedal radial forearm free flap. That's the two flap which we have taken for the two sides. And this is after 2 weeks of the operation, and bilateral radial forearm free flap has been given. And this is after the 4 weeks of the after operation. Now here comes our dentistry part, in the sense the rehabilitation parts, mouth opening parts, speech and swallowing therapy part. So, and the dental hygiene part, because this patient definitely going for a radiation. So that's the thing which is integrated into the oral cancer, the dental part. This is another patient on the right side, buccal mucosa lesion is there. We have done a neck dissection, and now we are going into the oral part. That's the malignancy, and see how much margin we are taking. Usually, pathologically, 0.5 to 1 centimeter margin has been sufficient, but pathologically, we don't know exactly like what is 0.5 to 1 centimeter. So on OT table, what we are taking, putting a scale, taking 2 centimeter margin, which will, after shrinking it, it will make as a 1 or 0.7, around 1 to 1.5 centimeter margin, and giving it a clear margin. That's the thing which we are taking it out. And that's a segmental mandibulectomy has been done for this patient. That's a specimen where we are making an orientation of anterior part, making a short, and the lateral part, making it as a long silk for an orientation. That's for the lower jaw. Now moving up to the another patients where this patient is having on the upper jaw lesion is there, and the upper GB sulcus. So that's the margin which we have taken, and that's the inferior maxillectomy which we have done for this patient. And And the palate we have removed. That's a specimen. Again, we are putting the suture silk margin. So what I mean to say is that during the dissection, give a clear-cut margin of adequate margin, involve the multidisciplinary team, orient the specimen correctly, and send it to the pathologist. Everyone will be happy, and in fact, the patient will be in a safe hand. So this is the central arch lesion is there, where in the labiogingival sulcus, the lesion is there. So we did a bilateral neck dissection, again, the selective neck dissection, and that's the skin has been involved. So we have taken the skin also, and that's the whole lesion is coming out. That's a marginal mandibulectomy done for this patient. And the central segment, the central skin segment is also been taken. And that's a whole specimen. Along with, we routinely remove all the infected tooth and those tooth which will cause problem during the radiation, because once the reconstruction has been done and once the radiation has been started, up to 6 months, like, we cannot do anything because of the poor healing procedures. So this is another one procedure, patient where we removed a segment of the mandible and the lesion. And now what we am showing is that we are taking a simple procedure, a PMMC flap, pectoralis major flap, and we are reconstructing that one with the pectoralis major flap. So my idea regarding the reconstruction is that select your patient correctly and do accordingly. That's after the operation. And this is an upper lip lesion. So we are moving from a free flap to a regional flap, and then to the local flap, where the lesion is there in the upper lip. We have taken quite an adequate margin into that one. That's the lesion which we are removing with an adequate margin. And that's the defect. And we did an advancement flap from the opposite side, moved the upper lip and reconstructed it. Because we cannot do a nasolabial or a slender flap, because on this side we have tied the facial nerve. As you can see, the neck dissection has been done for this patient on the same side. So every patient is not a squamous cell carcinoma. This is a soft tissue sarcoma, a patient of a 70-year-old male patient. So that's the lesion. So what we did is that we have taken an adequate margin. That's the adequate margin which we have taken. That's the margin which we have taken. And that this is after the resection. That's a defect has been created. And this is a free ALT flap which we have taken and reconstructed. And this is another patient who is having a lesion which involves the skin also. So we have resected it out and we have put a tubular flap into this patient. And that is after the reconstruction, patient is follow up on the OPD. That's the reconstruction part. And this is the final patient where a segmental, marginal mandibulectomy has been done. This is marginal mandibulectomy done for the left side, and that's a radial forearm free flap has been put for this patient. So this is another one patient, and this patient which I am going to show is the local. This is a 91-year-old male patient where putting the flap and everything will be quite a morbid procedure for this 91-year. This is a verrucous carcinoma. See how the scenario changes according to the patient's conditions and the tumor biology. This is a verrucous carcinoma. We have taken quite an adequate margin for this one. And what we did, which is quite an ancient quite a thing, this has not been advisable for all the patients, but for this patient, which we did is that we did a tongue flap, which is not an advisable one, but for a 91-year-old patient who is having this kind of disease, which is not going away from any of who is not going to tolerate any kind of regional flap, we have taken a local flap into this one, quite a big one. And this is the lesion which we have taken out. And finally, all patients are not cancer. So this lady who has presented at the labiogingival sulcus, a lesion is there. We have taken a biopsy and it came out to be a lymphoma. So what this patient is giving us a message is that take a biopsy, wait for the biopsy report, and then move accordingly. Don't go for a scrape cytology or maybe an FNA report. Based on that, don't do your surgery. And this is a patient who is having a large lesion which is going into the masticator space and the infratemporal space. And that's the infratemporal space which is going and touching the skull base, and it's quite an inoperable, quite a big nodes are there. Showing this CT scan is that all patients don't jump into the surgery, and choose your patients judiciously. That's my message to all my junior colleagues. And margin should be adequate. Reconstruction should be appropriate based on the patient's age and the condition and the disease, but don't compromise on your reconstruction part, and should involve a multidisciplinary, which involves all the three branches of surgical, medical, and radiation oncology, the dentistry part, the rehabilitation part, speech and swallowing part, and the nursing care part. So we do involve all those things and do these kind of things. So that's all from my side to all my colleagues and my junior colleagues, those who are there in quite a good number. And lastly, I really thankful to once again to the organizer for giving me this opportunity. Thank you very much, and I'm open to all the questions and suggestions.
Thank you so much, sir. Anyone, do you have any questions or feedback? All right, then let's.
I would like to ask my international guest people, those who are there, how is their experience into this one in head and neck malignancy? My colleague from Brazil, and how's their experience? Dr. Sandra, any input from your side?
You're on mute, ma'am. Okay.
I would probably do quite a bit of muscle therapy with them to get speech back and get muscle function for chewing, etc. Those are quite extreme surgeries, which are fabulous. But I would think they would need some retraining of muscle function.
Quite a nice suggestion, madam. But what has happened, like we do get a number of cases, this in very advanced stage because of the chewing tobacco habits. So yes, definitely.
Thank you so much. Indeed, together we are stronger for a cancer-free world. All right, now let us welcome our first keynote speaker. She is an innovator, a leader, an entrepreneur, an international speaker, and a compassionate therapist. Graduated from University of Northern Colorado with degrees in speech therapy and education and a master's degree in health sciences. She ventured to Washington State, where she was an itinerant speech therapist, then therapy director for a special education wing of Tacoma Public Schools. She and associates specializes in therapy for orofacial muscle dysfunction, tongue thrust, thumb and finger habits, tongue placement for specific speech, articulation disorders, and snoring. She started the Colson Institute for Orofacial Myology in 2003 in Denver, and now teaches and lectures internationally. Let us welcome Sandra Colson. Morning, madam. You're on mute. There you
Well,
go. Good morning.
thank you so very much. I'm thrilled to be here. That was fabulous. I go to surgery often, but I have to tell you, I've never seen that sort of surgery. I go to orthodontic surgery, but you did a fabulous job with those patients. So my hats off to you. I'm thrilled. May I share a screen?
Go ahead, please.
And bring this up. Are you seeing it?
Yes, I do.
Okay. Let's just start. I want to get this. My computer has been a little bit on the fritz. I want to start with this. It's covering it. Let me just move it a bit. So, slideshow. This is who I am. I'm 78 years old. I'm still practicing full time, and I lecture and teach internationally. I'll let you just look at these. You've already gotten sort of a background, but actually it's 53 years experience now. We have offices throughout Denver, but I really feel that muscle function is the missing link for so many cases in dentistry. Matter of fact, I was in Mumbai several months ago opening your very first Indian Orofacial Myology Association, for which I am thrilled and proud. It is therapy for abnormal rest postures, improper oral and facial and body posture habits. I have a big background in dance and gymnastics and figure skating, and so I'm very much into posture. So orthodontists have been aware that pressure exerted by the tongue causes changes in the face and certainly in the structures of the dentition. Only in the past 30 years has it been a subject, really, even though I've been doing it much longer, of evaluation and scientific investigation. So we're looking at orofacial myology for proper facial and tongue muscle function as it relates to dental, jaw, and speech function, as I mentioned with the case that you asked about, Doctor. We treat tongue and lip tie, tongue thrust, thumb and finger sucking, nail biting, drooling, and mouth breathing. That's one of our biggest things where I live in Colorado. We're experiencing fires right now, so everyone seems to be mouth breathing. We treat open and cross bites, Down syndrome, snoring, apnea, temporomandibular joint dysfunction, stroke, and trichotillomania. And I will show you all of these. One thing I want you to know is that orofacial myology is not speech therapy. It's a totally different entity. And that's why I got into it, because I didn't see speech therapy working. So we eliminate the habits of thumb and finger and pacifiers, establish normal rest posture for tongue, lips, jaw, and facial muscles, as well as the head and the body, creates a normal biting, chewing, and swallowing habit by developing new neural pathways. So we're looking at tongue posture, certainly, and it should rest up, but it often starts here with infants. The big motto that I use is, if there is a war between a bone and a muscle, the muscle always wins. So if we look at open mouth rest posture, which creates drooling, short philtrum along the lower lip, often severe malocclusion, difficulty chewing, and severe speech distortion. These are the cases that my practice looks at and that most orofacial myologists do. I just happen to be one of the older ones. So we look at in utero sucking going on. And actually, my oldest thumb sucking case is 62. So that was quite an experience to get her to stop sucking. Pacifiers are an issue a lot here in the States as well. They're a great babysitter for the parents, and anything put into the mouth is going to create a high arch and cause an abnormal rest posture of the tongue. But I believe that most thumb, finger, and pacifier habits relate to airway dysfunction. So looking at a pacifier habit, little girl starting here and ending here, and looking at her teeth, this is no dentistry. This is only muscle function change. It's not perfect, but it's certainly better than it was. So the longer they suck, the more damage they do. And the 62-year-old had a 9mm over jet. So pretty hard for her to speak. We do not use these. We see some, but there are huge impact in speech and proper swallowing. So we do not approve of rape, certainly. I don't. And I'd much rather do a positive therapy with children. Digit guards like this for thumb sucking tend not to work because they're quite removable. So the orofacial myofunctional approach is a positive behavior program, teaching new tongue placement, working on proper breathing, changing swallowing and speech, enhancing the facial appearance, develops better concepts of self, and changes lives quite a lot. I've worked with thousands of patients and I've trained hundreds of therapists as well. So sucking habits, as you well know, open bites, we can get them closed quite readily and ready for the orthodontist. If you've ever looked at thumbs that are sucked, the one that sucked the most is usually longest, and no one seems to think about that. But you can see the results when a child stops sucking on the first day, which is 99.7% of my practice. So we see cross bites with lips and speech patterns that are exceedingly abnormal. We get the crossbite changed, we get the lips to rest together normally. We see tongue thrust, swallows completely, and yet you can see these teeth have come down and the bite still has a crossbite ready for a good ortho to take over and just modify that bite. One of the biggest things I'm seeing now is tongue tie. My goodness, it seems to be everywhere. So if we're looking at adequate tongue frenulum length, we need this much. When we have this, what do we get? We get abnormal occlusion, we get abnormal speech patterns, difficulty swallowing, some choking. I just had a woman in yesterday, difficulty choking, and no one had ever noticed at 53 that she was tongue-tied. It is also a major cause of obstructive sleep apnea, and we see that a lot. So you can see all of the different shapes and things that tongue tie causes. I don't know if you've ever seen one of these, but if you think in terms of posterior tongue tie, this is probably the best case I've ever had, where she just folds the tongue in the center. Typically, you can see a sublingual tie with a dimple in the center of the tongue, but she was able to fold her tongue completely. So I have a video there. There's an abstract that you'll have that you can read too about eyelash length in children, that if the eyelashes are exceptionally long, they tend to show that that child has severe allergies. So this is a great product to read. How can you tell if a kiddo needs what I do? Infants 3 to 12 months don't babble or interact. They don't smile, make sounds, wave or point. They tend to mouth breathe, and they don't respond to sounds, which may indicate a hearing issue because the tonsils are typically large and the hearing also is impacted. A toddler from 1 to 3 has difficulty understanding what others say, fails to complete a sentence, only knows a very few words, difficulty talking and playing with other children, might stutter, consistently fails to follow directions, and has early signs of malocclusion. So when do you refer a child for orofacial myology? The moment you see signs of malocclusion happening, because we can make a difference in what the tongue does. Teenagers and adults, you'll see exactly what I've shown you. Anterior open bite, cross bite, short philtrum, and everted lower lip, forward head posture, poor speech, TM joint pain, facial pain, and typically snoring and sleep apnea. Then you would see open mouth posture, which creates or is created by low oral muscle tone, allergies, habit, and injury, perhaps early in life, paralysis, which often is not diagnosed until much later. And then someone finally puts it together that the child had a birth injury or a facial injury that caused paralysis, all sorts of syndromes like Down syndrome, etc. And then, of course, the frenulum issue, which helps to develop long phase syndrome. And there is indeed a genetic predisposition. So childhood obstructive sleep apnea, we all see this. I see it constantly. Look at this little puppy. Can you imagine how difficult his life is going to be unless he learns to nasal breathe? So you know what causes OSA. I'm not going to school you in that. But symptoms, certainly, kiddos being overweight, headaches, restless sleep, large tonsils, noisy breathing, a constant runny nose, frequent airway infections, and earaches. This is a great slide. I'm not going to go through it with you, but it really puts together what obstructive sleep apnea is and what it can cause. I don't want to take your time, but this shows how obstructive sleep apnea really affects and damages the brain. We see attention deficit disorder in most of these kids. I keep saying, I don't think these kiddos have a shortage of any of the drugs that they are being treated with. They just can't breathe. So one wonderful, if you don't know about this, way to determine snoring is snorelab.com. It can be used free 3 nights per week, but if you buy it, it's like US $9.95, providing a snore score that will convince people, especially those who live alone, whether or not they snore. And I pick this up on children all the time. This is a fabulous video. I won't play it for you. I don't want to take your time. But for a child that had airway dysfunction, look at his eyes with, you can just see allergic shiners. And the mom told his story. That is great. The name of the movie is Finding Connor Deegan. So I don't want to take your time to do that. I use something called a spot on the palate on the second and third rugae. And I have lots of dads who come to the practice. And once we put that dot in, what do you think the tongue does? The tongue goes right to the spot, especially with kiddos with Down syndrome or kids with, and adults with speech difficulties or airway dysfunction. The spot is placed, and when it's touched, it turns on other parts of your brain. It actually stimulates the neural receptors and helps to promote better body posture and good neurotransmitter production, such as dopamine, serotonin, acetylcholine, and norepinephrine. So it changes someone's life right away. This posture shows evidence in research for pain as well. You're going to have this, so I'm not going to take any more time. But this was a video, but I think it's not working here. This little guy was constantly doing that. And after we placed the spot, look at the difference in his face. He's a happy camper and he's functioning totally differently. So therapy results, I'll just show you a few. When you lengthen a philtrum, you get lips like this. when you work with muscles, you get lips that are closed. For cross bites, we get some, but we get anterior open bites closed, and very good. So, watching speech issues, these are major issues, results of tongue tie, results of facial change. You can see profile change, muscle function only. And what we do is help to stop snoring, change head and neck posture, allow better breathing, changes speech patterns, helps stabilize orthodontics majorly, changes facial aesthetics, and changes lives. And I thank you very much.
Thank you so much. Thank you, madam.
Thank you. Stop my screen share.
Thank you so much.
Are there any questions?
Are there any questions or feedback?
Okay.
All right.
Thank
Thank you so
you.
much. Let me go ahead and call on our next keynote speaker. He's one of the best graduate awardee from 1988 batch of GDC Nagpur, honored with scholarship from Colgate Palmolive for best student in her all the years of graduation and post-graduation. She pursued additional degree of PG diploma in aesthetic dentistry from Manipal University. Dedicated working and balancing both academics and clinical practice since last 24 years in Bhubaneswar. Actively participating and invited as speakers in national and international conference. She received a fellowship award by IAOMP 2014 and Lifetime Achievement Award by IDA National 2018. She has patents 12 number published in Indian Journal of Patents and publications 63 number Scopus PubMed journals in her credit. Now she is leading in Indian Association of Oral Pathologists as vice president after organizing a grand successful conference of IAOMP in Bhubaneswar for the first time in history of Odisha. With a special interest in social work, has organized many activities for awareness in oral cancer as a president in Lions Club, also spiritually associated with medical wing of Brahma Kumaris for social causes, mainly focusing on the addiction and early detection of oral cancer. Let us welcome Dr. Ruchi. Morning, madam.
Good morning. Am I audible?
Yes, you are.
So thank you very much, Jojo, for introducing me at very high this thing. And I must thank the BioLeague team also for giving me this platform, for sharing my experience in dentistry last 27 years. I must congratulate Sandra madam for giving us a beautiful lecture on orofacial myology, because we deal only with the smile, and before lecture was of Dr. Agrawal's, and he spoke on oral cancer, and then on orofacial myology, and then I'll be speaking on smile, now how to construct the smile. So thank you very much, Sandra madam. It was beautiful. And although in India, it is of less practice, we practice more of active, appliance therapy in discontinuing the habits. but your therapy is really good and we should also learn from you. So thank you. And I may share my screen now.
Yes, please go ahead.
Yeah. So my screen is visible?
Not yet.
Okay. Is it visible now?
Yes, it is. Please proceed, doctor.
As I was talking, that now it is the time for smile. So I usually practice the smile designing in my private practice in Bhubaneswar. So I'll be speaking more or less on current and future trends of direct laminates in smile makeover, which I'm doing last 27 years. Basically, whatever Madam Sandra has briefed us, that lot of habits have lot of discrepancies in the teeth, and we may come across many teeth problems, and especially here in India, patient report to us when they are grown up and they are basically concerned for their smile, right, and for their looks. So we come across many such type of cases, like there may be cross bites or there may be proclinated teeth. Some have this crowding of teeth. All these are habit related as well as they are dentofacial also. So I'm just briefing what type of cases are coming routinely to us, like midline diastema, which you showed us, that may be due to the tongue thrusting habit. And this is the high frenum and low frenum attachment, and it may give rise to a diastema, space in between the two anterior teeth, and there may be spacing of the teeth. There may be open bite, your cases I just saw, and there may be midline disharmony, and there may be cross bites. There may be discoloration, huge discoloration due to trauma. There may be some discoloration of the teeth due to faulty restorations. That may be discoloration due to the inside or the non-vitality of the tooth. There may be tetracycline staining, which give rise to huge discoloration. That might be fluorosis, that might be caries teeth. Some people just complain of small teeth, right? And some may complain of large teeth. So, and some short teeth and some long teeth. So different type of cases we are reporting here routinely in the practice. Some have complaint of narrow teeth, some have white teeth due to the fusion of the teeth, some have malformed teeth and irregularly placed teeth with the slightest discrepancy in the gingival line. They are it gives a lot of difference in the smile, so they complain of such small gingival asymmetry for the reproducing their smile. So I feel the perfection is universal, and wherever there is imperfection, we try to make it, carve it, and we, the dentist, take this opportunity to reproduce a natural smile for all. That's what I practice in my clinic routinely. And my basically this aesthetic dentistry and cosmetic dentistry basically depends upon what I feel personally. Many may differ here, we present here, that we should meet the mind of the patient before meeting the mouth of the patient, right? So what does a patient wants from us is more important than what we can give it to him as a best possible treatment. We might be very sure of our principles, our ethics, everything, but considering those things in mind, we should read first what does the patient want from us. So that's how I practice, and whatever cases I'll show you today, that's how I managed keeping the patient's need on the priority basis, and then organizing my management or giving the best to the patient. So this is the question always comes in picture, that what is cosmetic dentistry and what is aesthetic? Like cosmetic, so that's what I said, what is in the mind of the patient, what does the patient wants from us, and what is the best design of smile which suits that personality is the aesthetic dentistry. And what is cosmetically created, as the name suggests, also we go to the parlor and do some cosmetic thing for particular role. We might be playing some role, and then that time I need that type of cosmetics. But aesthetic is universal. It is just particularly created for that particular patient, and that's how what I practice in my this dentistry. So what is the aesthetic smile? Basically, it gives a unity as well as a variety, which is essential ingredient of all the smile design. So what I mean by this is you should create or fabricate a smile which is acceptable aesthetically and which is socially acceptable. If to a 70-year patient, you are maintaining all the principles of the smile, like canine to canine, this prominence, this thing, all there are principles of smile, and those things you're taking care in a 70-year-old patient, then that will look very artificial, and that will not suit to his personality. So you must take care of his personality in creating the smile. Whenever you are fabricating a smile for that person, that should be uniquely customized, thoroughly crafted, and belonging to that person only. So that's how the aesthetic smile goes. So how does it? But when you are creating a smile or fabricating a smile, you should not go out of the box like, yes, I'll create like this and I'll create like this. But some principles you have to keep it in mind. And what is this is that two upper central incisors are the theaters of the smile, and you should keep those and the same size and shape, and they represent the major smile. And what a variety you can do in similar sizes and shape of others like canines and lateral incisors for creating a particular smile for that person. Otherwise, if you will follow only the principles like what is given in the book, and then you will be creating a unique smile for everyone walking in the clinic. So that should not be there in the aesthetic dentistry. It should be uniquely crafted for that particular person to suit its personality, he should accept it socially, and it should be acceptable by him also. So basically this, what I am talking about is on direct laminates, the principle of which is based on adhesive dentistry. And what precautions you should take for adhesive dentistry to make the things visible, invisible. I'll be just giving you some points, what I take care in my clinic. So for the long lasting of my restorations, and this is because very sensitive material, and little care is taken in handling those materials to maintain the adhesiveness. What is adhesion? Basically, it is just a phenomena in which two different atoms of different configuration show affinity towards each other. We all know this physics. What is the use in dentistry? Because with the invention of this H bond and the cure technique in adhesive dentistry, we are working on this principle of adhesion. Basically, we all know the steps in the adhesive dentistry, like we prepare the tooth which we are going to fill or the restore by mechanical and chemical roughening. And then we prepare it keeping in the wettability and the creep and the bonding process by bonding agents. And then some photoinitiators and catalysts are also added in the composite materials to maintain the proper luster and the hue and the shining of that material as good as natural. So with the invent of many generations of composite, from micro composite to micro composite to the nano size composites, more recent one, it gives really good strength and polishing abilities that mimic the almost the natural dentine and the enamel. So the composites are now available in different these things like hybrids, micro hybrids, and nano hybrids, nano composites, which are mostly accepted by all these procedures. I'm not going in detail of these procedures. I think most of them practicing in dentistry, they know how to go for this stepwise process. But what at at the end we are expecting is this bonding should be as good as natural one of enamel with dentine. So we are putting artificial enamel, which we want to tag up with our natural dentine with the 30 to 40 megapascal, which is naturally present, that bonding is present. So as far as possible, try to get that bond. And for this, we keep some procedures which keep this bond very strong, and as well as our restorations, the long lasting. So basically, I was talking about the mechanical and the chemical roughening of the surface, which of the prepared surface. So everyone of us, we know that we etch the surface with orthophosphoric acid, 37%. But what I want to emphasize here is we should do a selective etching. It should be biologically accepted. It should not never touch the dentine. It should be restricted only to your enamel, because enamel, we all know that it has a 98% inorganic substance, and which can withstand our orthophosphoric acid, which is so acidic, and gives it. So when we etch the enamel, it gives the mechanical support to our restoration. So, but the next layer is the dentine. We all know that it is very difficult to obtain the micromechanical retention as far as dentine is concerned, because it has a many organic content, much about 65% inorganic and 45% of organic content is there, which is very difficult if for etching of the dentine. We cannot roughly put the etchant on the surface of the dentine. The tooth will become very sensitive. And also we know the anatomy of the dentine, histology of the dentine, like it has a dentinal tubules, the nerve endings, the dentinal fluid, and it is so making the dentine surface worse for our filling material. As well as when we cut the dentine, we embeds a smear layer that again blocks the dentinal tubules. So that makes our restoration worst. So all these things you have to keep it in mind. And then the inventions of the bond came. Since 1998, I'm practicing, and I have seen almost all generations of bonds and composites in my practice, and you used it also and faced the complications also, and like that I have improved my practice. So in this graph you have seen the right from first generation to seventh generation bonds have come. I may differ in my opinion with many here, but to my best knowledge, what I practice till date with my adhesive dentistry is fourth and fifth generations of bond works best. Because on the how I'll explain in this, because in fifth generation, although they have a single bottle, because the concept of two bottles and this single bottle came in picture. So they have fourth generation, they had two bottles. In fifth generation, they combined the single bottle. And in the seventh generation also, they have a universal bond or a single bottle bond. So why I emphasize on three-step technique is, first, they had given a primer. We all know that the primer is slightly acidic. It is hydrophilic. It adapts very well with the dentinal tubules and the dentinal fluid. And we need a material which goes down deep into the dentinal tubules and gets adapted to our dentinal tubule. It should not be an irritant for the dentinal tubule. So that was a primer bottle. And then that was combined with a bond bottle. That was adhesive bond. Then again, we applied a layer of bond over the primer, and that was hydrophobic. Bond is hydrophobic, is afraid of dentinal fluid, so it runs away from the fluid. And this property makes they combined these two bottles and made a single bottle. So two different liquids with the different properties are mixed in a single bottle. So I don't know how does it work. Like I'll explain here in scanning electron microscope. If you'll see, we after opening with the etching and the primer, we first place the primer. So the red thing which goes deep into the dentinal tubules are the primer. So now we know that how much our dental primer has gone inside the dentinal tubule to get the micro adhesiveness. And then we blow the extra one, and then we put the bond. The green one is the bond, which goes again slightly deeper into the dentinal tubules. Now we know that deeper inside, which is closer to the pulp, is our primer, which is hydrophilic, and the superficial portion, which is going to give a bond, is a hydrophobic material, and it gives a complete bond. So this was the 3-step technique, and to date I follow this 3-step technique, although it might take 1 or 2 seconds more in your dental practice. But now what some people have done is combine this 2nd and 3rd step, and they have given it like this. So now in this 3rd technique, we don't know till where our primer has gone, till where our bond has flown. 2 bottles were mixed, and as this thing is concerned, I said hydrophobic. So it will not mix with our dentinal tubules, and it might be irritant to the dentinal tubules sometimes. So it depends, but somehow this 3-step technique works well for me. This again, very small tip, but a very useful tip in dentistry, that when we apply our dental bond as well as our primer, we should make it or merge or completely merge with the dentinal tubules, and it should flow inside the dentinal tubule. For that, it should reduce the contact angle to reduce less than 90 degree. So if you'll place it only 90 degree, it will be on the surface. I mean, if it is just placed without no wetting, then it may not flow inside the dentinal tubule. So always merge it nicely to flow it inside the dentinal tubule to get the best mechanical bond with your bonds. As I said, there are many materials which have come, many in the composites. To start with, in 1998, I used to practice with large particles that was with macrofill. That the filler particles which are there in the composites were macrofill, and now they have come to a microfill, and now to nanoparticles also. So we should choose properly what composite we are using according to the material. Although last 5-6 years I have seen there is no change in the composite material. The best possible material is our composite, our nanoparticles mixed with the nanocomposites. That works well with strength as well as the finish. And small things, due to many here may agree with me that there is some failure of this adhesive dentistry due to curing process, because when the composite is just placed and cured, it is stable. But when it is first, after 24 hours, it goes polymerization shrinkage, and there will be slight compression. And after 48 to 72 hours, there may be water absorption and there may be decompression. So for this compression and decompression, we must keep in mind some space should be there, or our material used or composite used should have that property to withstand this compression and decompression. Otherwise, it will lead to fracture, or it may lead to some micro leakage and the restoration. So for this, what you will do is placement of your light cure machines in one cycle. From far, you should take for 13 mm, giving a one cycle complete to the tooth, then slowly taking it nearer to the 6 mm, making the 8 cycle. It should be completely cured immediately after the placing the restoration. To avoid the polymerization shrinkage, as I said, I always place the first layer of composite as flowable composite, which have high flexibility and which can compress and decompress according to the trauma and according to the polymerization shrinkage. So that works very well with any restoration, maybe class 2, class 1, or maybe in the smile designing in the laminates. Next, some principles of shade layering in the direct veneers, you should keep it in mind. Like, there are different shades at different level of the tooth, and we should place our materials accordingly. Like, we should place the tints also to give a proper hue and balance the color of the teeth and the luster of the teeth to maintain it in most natural way. So now coming to my cases, this is case one. As I said, I have always kept the patient's need in mind, and this is an old filling. You must be noticing it is so anesthetic, and as I discussed just now, this is due to the gap which you see in the filling is due to the shrinkage, and the restoration is broken and discolored also. So now first, when I cleaned the surface, removed the old restoration and made the line angles round and the angulation properly in accordance with the enamel prisms and enamel rods. You have to keep it in mind. The dental histology plays a very important role in this cosmetic dentistry. So after preparing the tooth mechanically, we go for chemical preparation of the teeth, and then stepwise we follow the application of flowable composite, and then the rest of the composites with the tin. And that's how I received the finishing of this patient with the proper margins, and there is a proper hue maintained with the line angles, and the polishing should be really very good. It should be glass polishing to avoid any discoloration of the teeth. So this is our second case, very simple case. As I said, patient just wants a small space behind the canine to be reduced, and many possible management techniques here personally they may be different, but what exactly patient wanted is to reduce the space, and that canine which was placed in the portion of lateral incisor, that was making a huge difference in the smile. So I just reduced in a single visit the canine to a lateral incisor and first premolar to canine. So that gives a huge difference in the smile. So that's what this is the advantage of this direct laminates, which is chair side, and immediately you can convince and you can make the patient happy. This is a third case. A girl, she is in some film industries, and she was with this smile, the left-hand side photo. And with the change in the smile, you can see the brightness, and with the simple, without makeup also, that makes a huge difference. So she had come with this much of open bite, and that I convinced her to go for orthodontic treatment and other things, which is possible in this case, but she somehow wanted in the same visit to change her smile. So I went for all veneers from upper and lower central and lateral incisors, and that has given a very good results. And this case is almost 25 years, and it is working very well, and no stains, no discoloration, no sensitivity. So that is why when you follow up your patient, that gives you confidence also on your practice, on your materials, that it is very well working. This is another girl. As I said, all they have reported with, they wanted as if they are walking in a beauty parlor to change their smile, and they want immediate result. She had a open bite with short laterals, with a tetracycline or the staining, some hypoplastic mark on the central incisor, and she had a tongue thrusting habit. So a lot of things can be managed, and a lot of treatment planning can be done for this case. But as I said, she was not ready for any of the management techniques, but she just wanted to change the smile, and this was the gap she had in the lateral vision. And I have worked only with the six anterior teeth, and she got her closed space, although compromised smile, but she was very happy with this smile. She even didn't prefer to go for lower anteriors, and that's how the patient need was, and that she was very much happy and very satisfied with this smile. This is another lady which has a malformed teeth, and with open bite also. And she wanted to change the smile. So even if you will go for ortho in such cases, you have to go the reformation and convert the shape of the teeth, because she had proclination, spacing, as well as the fractured teeth. So I just went all these cases in a single visit. I have done maybe 4 or 5 hours, or maybe sometimes more. But I finished the case in one visit only, with minimal of tooth reduction and minimal of, in any of the cases, no endodontics treatment has been done, and they are doing very well without sensitivity and without any pulpal injury. So this is my finished case, and you can see in the rear vision from the palatal side how the arch form is achieved in a single visit with the composite laminates. So that was her final smile, and she was really happy to get that. And even I have not touched her lower interiors, because this is more acceptable by the patients, and sometimes it is more economical also. So they go and prefer this treatment. This is her brother only. He's a young fellow of 18 years only. And following her sister, he came to me. Then I was not ready for his treatment, because from front view, you're seeing the overlapping of teeth. But from the other angle, if you'll see, he had this much of proclination of one central incisor. But he was going into, again, a film. He was in child film director or something like that. I don't remember. It's a long time. But he wanted in the single visit, and he never wanted to put braces on it. So I convinced him that it may be possible in very less time, because very minor discrepancy. But again, I managed it with the composite laminates only, and he's also doing well. All these cases report to me in 1 year or 2 years whenever they are coming back to Bhubaneswar. They're not from Bhubaneswar. So that's why I do the follow-up of these cases. This is the final smile, and it is doing very well. This is an amazing case. You must see here, 60-year-old. As I said, my clinic, they walked in as if they are walking in a parlor to change the smile. And this lady walked in for his son's marriage. And when I looked into her mouth, it was like this. But in spite of the bone loss and the gingival recession, there was no mobility of the teeth. And somehow she wanted to change the smile. Although I have not done any or endodontic treatment for this teeth, it goes well. And I just close the space with the laminates. And it is also doing very well. From this to this, she could manage her son's marriage very well. This is another case, same case of tetracyc or the hypoplastic teeth with cross bites and extremely small teeth. And she was not happy with her teeth. But other possible treatment, maybe the gingival line can be corrected in here, and with the periodontal help and gingival, the crown length can be increased. But she doesn't want it to go for any surgery or any procedure to be gone. So I have done the laminates in only 4 teeth, and upper and lower teeth. And she had this smile. This again a lady, she is orthodontic. She had taken orthodontic treatment long back, and that was relapsed. Again, she had got, because medial diastema relapsed very soon, and now she never wanted to take ortho. So I did her closure of spacing just before her marriage. And this was her finished case. Although she had a tetracycline or the hypoplastic line in other teeth, but I could not maintain that because she was in too much of hurry. And I called her later on, and this is an old photograph, and then changed the smile, changed her laminates again. So he is also a young boy in marketing. He was always very conscious about his smile of open bite. He had a missing teeth. He had missing teeth and spacing, and with open bite and slightly class 3 pattern also. but he never knew that this can be corrected because his age was almost 35, 36 years. And he said, I cannot go for orthodontic treatment now because he was in marketing. And I did laminates for him, only 4 teeth, 4 upper anterior teeth, and it makes a lot of difference in his smile. And now he's confident about his marketing strategies and always praise me with the messages. So this is again a very black tooth. If immediately you have finished your endodontic treatment, you can go for a complete laminate at the chair side for the avoiding any unaesthetic appearance of the patient immediately. I don't want any patient to go out of my clinic like this. So immediately I changed I apply the laminates over the black tooth, and you can see the result that it gives a perfectly matching teeth with the adjacent tooth. Probably this is the last case and most difficult case, because this young girl joining MBA and she wanted to change her smile, and almost it took me 3 days. She was here for 7 days, 3 days to convince her that I cannot do this case without orthodontic treatment. But somehow she was not ready to wear the braces. When I examined properly, she had peg laterals on both sides, both the canines were in crossbite, and this type of cases was difficult without orthodontic. But she was neither ready for extraction of teeth, neither ready for putting the braces. So in the first day, I didn't promised her much, but I said I can do something for you on the upper anteriors. So I placed just the 6 laminates over the upper anteriors first, and I found it is coming very well, although no endodontic procedure has been done in these cases. And she was very happy, and she wanted for the lower also. And then we did the lower. This was the first, the upper arch, and that's how we got the final finishing. With the lower canines too much in crossbite, I could manage this much only. And although compromised smile, but it was very much accepted by the patient. And it was with the minimum of tooth reduction and without endodontic procedure. So some things, and she's in continuous follow-up. It is almost 7 years I've done this case with no complaints, no discoloration, no sensitivity, and the vitality of the teeth is also quite normal. That was her picture. She sent me, she keeps on posting me now also. And that was an immediate picture, so how she came and after the smile designing. So with this case, I want to conclude that this adhesive dentistry plays an important role. And particularly, I work with the direct laminates more. And although I didn't find any drawbacks in this, apart from only the chair side time is a little bit more, and rest everything you can manage, although many good materials have come in indirect laminates techniques. But again, you have to depend on you should have a good technician for that, and good lab for maintaining the smile, and patient picture and everything you should give it to them. But here you have the patient in front of you, and you know the want of the patient, the personality of the patient, the other things, how he or she will accept the smile. So this practice is very much accepted by the patient. Immediate smile makeover by adhesive dentistry. Thank you very much. That is my center. I practice here in Bhubaneswar last 28 years. And I thank BioLeague team again for inviting me for this forum. Thank you very much.
Thank you so much. Thank you so much, Dr. Ruchi. And Dr. Ruchi, I have a question here from Ruel Bonquiso, Philippines. Congratulations, madam, for a comprehensive presentation. My question is, dental pasta is practiced here in the Philippines. How long will dental pasta stay as part of our teeth? Will you, sorry, Will you recommend for tooth implantation? Is it safe in our mouth?
I didn't get what is dental plus pasta.
Not really. I think it's filling. I think he's referring to filling, dental filling.
Yeah, dental filling. There are different materials like what I talked just now about the composite resins. And we place composite resins practiced here, although the amalgam dentistry has worked off now, most of the dental clinics because of the mercury poisoning. So now we are focusing more on the composite resins.
All right,
Yeah.
thank you so much. And another question is, how can we identify a genuine retainer, since there are fake retainers sold in the market nowadays? How does retainer helps the formation of the teeth, and how old is a person can use a retainer?
I think your retainer, you're talking about after orthodontic treatment. After orthodontic treatment, we give retainers, and that should be where it is removable also, it is fixed also. Depending upon the acceptability of the patient, you can place the retainers.
It still depends on the patient, right?
Yeah.
All right. I hope that doctor answered your question, Ruel. So thank you so much, doctor. Any other questions? All right. And thank you so much. Let's move on to our next eminent keynote speaker, who had completed his BDS form from KGMC Lucknow in the year 2004, and post-graduation in the branch of conservative dentistry and endodontics from Subharti Dental College, Meerut in the year 2008. Currently, he's an associate professor at Subharti Dental College, Meerut. He had delivered several guest lectures and presentations at national and state level conferences and continuing dental education programs. Also, he had published more than 25 articles in international and national journals. In addition to that, he have contributed as an author in 8 books. He is on the panel of examiners for BDS and MDS exams of 6 universities. In addition, he had been appointed as a subject specialist by CCS University to conduct inspections of dental colleges affiliated to it. He is an active member of Indian Endodontic Society, Indian Dental Association, Indian Association of Conservative Dentistry and Endodontics. Currently, he is the joint treasurer of IDA Meerut Kant branch. He has been actively involved in organizing international, national, and state level conferences. He has been doing specialty restorative and endodontic practice for the last 11 years, in which we have done more than 13,000 root canal treatment. He is also among the key opinion leaders for Ivoclar Vivadent India. Let us welcome Dr. Padmanabhan Jha. Morning, sir.
Thank you, ma'am, for the detailed introduction. Good morning, one and all. Hope I am audible.
Yes, you are.
Right.
Please proceed, sir.
Can I
doctor.
share the screen now?
Go ahead, doctor.
Is the screen visible? Is the slide visible? Ma'am, is the slide visible?
Yes, go ahead, doctor. It is visible.
Thank you, thank you. Greetings from Subharti Dental College, Meerut. This is my workplace. And I would like to thank the BioLeaks and the organizing committee of this conference for giving me this opportunity to share my views on a particular topic with this lovely audience. The speakers before me, they have raised the bar so high that I'm really anxious to keep up to that pace. Let's hope I can do that. Starting with my presentation, today's world has become a digital world, and social media sites like Facebook, WhatsApp, they have become an integral part of our daily life. Even now, we are interacting with each other digitally. Dentistry cannot remain untouched to this, and a new trend has started in which dentists have started sharing and learning on these social media networks. But once an operator or clinician visits these social media sites and try to know or learn about endodontic access cavities, they are bombarded with a lot of terms like traditional access, conservative access, ninja access, stars access, and so on. This leads to a state of confusion among the operators and the students as to which is the best endodontic access cavity design. So a big question arises whether one should opt for a traditional endodontic access cavity or a conservative access cavity. During my presentation today, titled Conservative or Traditional Access Cavities, a Clinician's Perspective, I will try to answer this question. Although this topic is quite vast and one could go on speaking for hours altogether, but the allotted time is less, so I will try to highlight some of the important points within the time allotted to me. Root canal therapy is performed to eradicate endodontic disease by minimizing the number of bacteria by thorough disinfection and subsequent obturation of the root canal system. And access cavity preparation is the first phase of the root canal treatment. There's an old saying that well begun is half done. So a good endodontic access is the key to successful endodontics. Now, before we go to the intricacies of different designs of access cavity preparation, let's just brush through the basics. So what is an access cavity? It is defined as the opening prepared in the tooth to gain entrance to the root canal system for the purpose of cleaning, shaping, and obturating. Now, every endodontic access should meet certain objectives of access preparation, which are all the caries or the carious lesions should be removed. Still, the maximum amount of sound tooth structure should be conserved. The roof of the pulp chamber should be completely removed so that we get a proper visibility. In addition to that, we should remove all the coronal pulp, whether it is vital or necrotic. The operator should be able to locate and negotiate all the root canal orifices. And finally, one has to achieve a straight line access to either to the apical foramen or to the first point of curvature. Now, there are different access cavity designs which have been discussed in the literature. The first of them is the traditional access cavity. This is the access cavity design which have been taught to us over the years, and this has passed from generations of dentistry. It incorporates convenience form, which means there has to be a removal of sound dentine to accommodate proper instrumentation and obturation of the root canal system. This cavity design is also based on the idea for extension for prevention, which means we have to remove some amount of sound dentine to gain a straight line access and to remove the dentinal obstructions. In addition to that, these traditional access cavities have been given some geometric pre-designed shapes, like a rounded triangular for maxillary incisors, long oval for premolars, and so on. Now, this all leads to a lot of removal of sound dentine, which in turn weakens the dental structure and reduces the fracture resistance of the tooth. Now, there have been a lot of studies which have evaluated the impact of endodontic access cavities on the fracture resistance of the teeth. And most of them have concluded that there was significant reduction in fracture resistance after access cavity preparation. The main reasons behind these is, first, the actual substance loss of the tooth structure, And second is the modification in the root canal geometry. Now, is there anything which can be done to minimize the effect of endodontic axis on the tooth? For that, we should know what is the stress distribution pattern of the teeth. A number of studies have been conducted to determine the stress distribution pattern on the teeth. And in almost all of the studies, they have determined that the stresses are concentrated mainly in the cervical area of the tooth, which is mostly composed of dentine. There is hardly any enamel or cementum in that area. So this dentine is known as the pericervical dentine, which extends around 4 mm above and 4 mm below the level of alveolar crest. This pericervical dentine is responsible for the transmission of occlusal forces to the root and hence the distribution of forces into the jaws. According to Clark et al., the safest way to avoid damaging this pericervical dentine is to preserve the part of sealing around the entire pulp chamber. This preservation of tooth structure will reduce the flexion of the cusp and hence increase the fracture resistance of the tooth. Now, most of the modern endodontic access cavity designs, they have been based on this idea. There have been a lot of talk on the social media regarding these modern endodontic conservative access cavity preparations. But right now, till now, we have still this lack of scientific evidence which supports the use of such modern endodontic access cavities in routine dental practice or for the training of undergraduate and postgraduate students. When we talk about conservative access cavity designs, there have been a lot of terms which have been used in literature. There are around 22 different terms which have been used in literature to denote the conservative access cavity preparation. Because of shortage of time and to simplify things, I'll be discussing them into 4 major types of conservative access cavity preparations. The first of which is the conservative access cavity design, which was given by Clark and Khadami. In posterior teeth, it starts in the central fossa and it extends only as far as necessary to detect the canal orifices. No further extension or no further removal of the roof of the pulp chamber is done. The walls of the access cavity are smoothly convergent. This maintains a lot of roof of the pulp chamber and hence the pericervical dentine, thus increasing the fracture resistance of the tooth. For comparison purposes, this outline have been made to compare what would have been the amount of sound tooth structure lost if the same tooth would have been done with a traditional access cavity. For anterior teeth, the point of entry of access is moved away from the cingulum towards the incisal edge. This again conserves the pulp horns and the maximum pericervical length. The next design is the ultra-conservative access cavity, which is also known as the ninja access. It starts as described in the conservative access cavity group, but with no further extension. There is no further extension given to locate the canal orifices. The canal orifices are located by varying the visual angles. This maintains a lot of sound tooth structure and hence supposedly it will increase the fracture resistance of the tooth. For anterior teeth, the axis is made on the middle of the incisal edge and it runs parallel to the long axis of the tooth. The other design, which is generally adopted by clinicians, is the thrust access cavity. It is also known as orifice directed access. The major advantage of this design is that it preserves the dentinal bridge because separate cavities are made in a multi-rooted tooth to assess the different roots of the tooth. For example, in mandibular molars, 2 individual cavities can be created to access the mesial and distal canal, thus preserving a lot of sound tooth structure if it is intact. The last one is the caries-driven or restoration-driven access cavities. This is based mainly to conserve as much of the sound tooth structure as possible. And if there are caries onto the tooth structure, the entire carious lesion is removed and the access is done from the same side. For example, if there is a proximal lesion, the caries on the proximal side would be removed and the access to the pulp chamber would be made from the proximal side itself. In a restoration-driven access cavity, the access is performed either by removing the restoration partially or completely and then gaining the access, thus preserving whatever tooth structure is left onto the tooth. Now, once we have briefly discussed the different access cavity designs or minimally invasive access cavity designs, let us see what these access cavity design or how this access cavity design influences the outcome of root canal treatment. For the purpose of simplicity, from henceforth in my presentation, I will be referring to all the kinds of minimally invasive access cavity preparation as conservative access cavity preparations. So the first effect that we should evaluate is the effect on orifice location. These conservative access cavities have an inherent difficulty that it minimizes the view to the floor of the pulp chamber because of the limited opening on the occlusal surface. So the orifice location is impaired. As you can see in the diagram or the photograph here, with the angle of the visual angle has to be changed to locate the nasal and the distal orifices, canal orifices. You cannot see all the orifices from the same angulation. Now, different studies have been done to see the effect of conservative access cavity preparations on the rate of orifice location in teeth treated with conservative access. And most of the studies, they have concluded that the rate of root canal detection was compromised in conservative access cavities if no magnification or no ultrasonic troughing was used. However, if ultrasonic troughing and magnification was used with conservative access cavity preparations, the rate of canal detection became at par to the traditional access cavities. Now, a well-prepared access is important for proper cleaning and debridement of the root canal system. There have been many studies which have evaluated the effect of conservative access cavity preparations on the effect of cleaning, which includes the percentage of untouched canal walls, the percentage of pulpal tissue remnants, the irrigation efficacy or debridement efficacy of the root canal irrigants, and so on. Out of those studies, 4 studies have evaluated the influence of access cavity design on the untouched area of canal walls after the root canal preparation. It includes studies by Krishnan et al. And Rover et al., etc. In all the studies, the findings were similar that the percentage of untouched canal walls after mechanical instrumentation of root canals was similar between traditional access cavity and conservative access cavity. As you can see in this picture, the amount of untouched canal walls, which is depicted in green, is almost similar in both traditional and conservative access cavities. However, when the effect of conservative access cavity was seen on the disinfection of the root canals, it was found that disinfection was significantly compromised in conservative access cavity teeth. Now, it's a universal fact that healing of apical periodontitis is reliant upon effective disinfection. So, excessive dentine preservation might negatively affect the treatment outcome of the infected teeth. Then, what can be the potential solution to this problem? The solution is the agitation and activation of the root canal irrigants. There are different techniques to agitate and activate the root canal irrigants in the root canal system, like sonics, ultrasonics, lasers, and so on. Any of these methods of activation or agitation can be used to increase the efficiency of root canal irrigants in teeth treated with conservative access cavities, as has been depicted in this study by Yilmaz et al. When the root canal irrigation was activated for 1 minute by XP Indo-Finisher file, the bacterial reduction, no difference was seen in the bacterial reduction in both traditional or conservative access cavities. That means the cleaning efficiency or the debridement efficiency of the root canal irrigants became similar if they were activated in either conservative or traditional access cavities. Then comes the effect on obturation, the effect of conservative access cavities on obturation. I could come across only 2 studies on this topic, and both had very contrasting results or findings. Niemi et al., they suggested that the reduced dimension of conservative access cavities hindered the proper adaptation of gutta percha cones to the root canal walls when single cone obturation was used. Plus, the efficacy of continuous wave compaction was also hampered in conservative accesses. So they concluded that the warm lateral compaction would be the better option for filling of canals or for obturation of canals in teeth with conservative access cavity preparations. On the other hand, the study done by Silva et al., they found that there was no difference in the quality of obturation between the traditional and conservative access cavities. The most probable reason for this difference would have been the type of canals that were selected for this later study. In the first study by Niemi et al., the type of canals were oval canals, that means the teeth were premolars, mandibular premolars. And in Silva, in the study by Silva et al., the type of canals had round cross sections. So the cross-sectional shape of the root canal has a definite influence on the quality of obturation in teeth treated with conservative access preparations. Then we did a study in our department to compare the effect of different access cavity preparations on the quality of obturation. The results of this study, they suggested that the quality of obturation was definitely inferior in conservative access cavity groups when compared to traditional access cavities. And when the different obturation techniques were compared in conservative access cavities, the thermoplasticized obturation technique, that is downpack and backfill, gave the better results among all the other obturation techniques tested. Finally, what is the influence of conservative access cavity on the fracture resistance of the teeth? This has been one point which has been the basis for the development of these minimally invasive or conservative access cavities. A number of studies have been done. There are numerous studies on this topic, and out of those studies, 5 studies have suggest that the fracture resistance of teeth treated with conservative accesses had fracture resistance greater than those with traditional access cavities. And this study is one of the examples by Krishnan et al. However, majority of the studies, they concluded that there was no difference in the fracture resistance of teeth treated with either conservative access cavities or traditional access cavities. And these are some of the examples of the studies, like one by Silva et al. And so the effect of conservative access cavities on the fracture resistance of the tooth is still questionable. Now, let's summarize what are the effects of these conservative access cavity preparations on the outcome of endodontic treatment. So as suggested in the previous slides, the most studies reported no scientific evidence or of real benefit of conservative access cavities for improving the fracture resistance of the tooth. At the same time, teeth treated with conservative access cavities had difficulty to locate and negotiate all the canals if magnification and ultrasonic troughing was not used. However, with the use of these devices of magnification and ultrasonics, the rate of root canal detection was almost similar to that of the traditional access cavities. Another important point is that there was no difference in between traditional and conservative access cavities regarding the percentage of untouched canal walls. So on this criteria, both the types of cavity design fared equally. However, there was greater accumulated hard tissue debris remaining in the root canals after preparation in conservative access cavities. In addition to that, teeth with conservative access cavities were associated with negative effects on irrigation efficiency. Now, this limitation could be easily overcome by use of different agitation and activation systems. For obturation, the studies, the limited studies which have been done, they suggest that there's definitely an influence of cross-sectional canal shape on the obturation quality, and conservative access cavities demonstrated inferior sealing ability in teeth with oval canals. Now, coming back to the question with which we started the presentation, that whether we should not choose the conservative access cavity design based on whatever little evidence we have in literature, it appears that there are so many disadvantages of conservative access cavity design. The answer lies in that as an operator, we have to strike a balance between the needs of the operator. That is, what is the skill level, what is the knowledge, and what is the experience of the operator, whether he or she can perform a good conservative access cavity properly or not. The needs of the tooth, like what is the pulpal status, whether it is vital or necrotic, what is the root canal anatomy and morphology of the tooth, whether it can be treated properly with the conservative access cavities, and so on. And the needs of the armamentarium that the operator have, like the type of files the operator is going to use, the type of irrigation system and the irrigation activation system the operator is going to use, and the obturation techniques that the operator prefers while doing a particular clinical case of endodontics. Now, based on these things or these points, the operator has to select a case of conservative access cavities in which the benefits definitely outweighs the risks. The other question which comes to the mind of the operators is which cases to select for conservative access cavity. Can we select these type of cases which are already grossly mutilated and have already lost a lot of sound tooth structure? The answer is no. However, on some of the social media platforms, I have seen some operators building up or restoring this tooth and then preparing a conservative access cavity. There is no point doing this. It is just over complicating endodontic treatment. Then should we select cases like this? Yes, definitely we can select cases like this, because in such cases we can preserve a lot of sound tooth structure and maintain the integrity and durability of the tooth. Finally, what are the minimum basic requirements that the operator should have to perform a good conservative endodontic access? The first is the use of magnification and illumination. Preferably, one should use an operating microscope. If that is not available, then at least a good quality loupe with 2.5 to 3.5x magnification and good illumination should be used. The use of three-dimensional radiography in the form of CVCT should give us a more clearer picture about the root canal anatomy and morphology of the tooth, and it will help the clinician decide whether to go for a conservative access cavity, whether he or she would be able to negotiate and clean all the root canals of such a tooth. Then the use of ultrasonic tips. This is a very valuable tip if we are planning to go for conservative access cavities, because it helps the operator remove strategically the dentine at specific locations to unearth the hidden canals and at the same time maintain a lot of sound tooth structure. The use of flexible files is again a must, mainly in the form of heat-treated night tie files, because these flexible files will be able to negotiate all the curvatures of the root canals even through the contracted axis. If an operator uses a stiffer files, there is bound to be iatrogenic errors during the preparation. The next is the irrigation agitation and activation systems. As has been seen in many studies, in contracted access cavities, the efficiency of irrigation decreases. And for proper debridement, we need a proper irrigation and disinfection of the root canal system. For that, we need to activate and agitate the root canal irrigants by any of the techniques like sonics, ultrasonics, lasers, even manual dynamic agitation would work, would give a better result than no agitation at all. Then when it comes to obturation, whatever limited evidence is there in the literature, it suggests that the use of thermoplastic obturation systems or techniques like downpack and backfill or warm lateral compaction is preferred over the other techniques if you are planning to go for conservative access cavity designs. And last but not the least, the operator must have sufficient skills. He should undergo training and have experience to make a good conservative endodontic access. With that, I hope I have answered the question and still maintained the timing of the conference. Thank you so much for the patient hearing. I will be more than happy if anyone wants to contact me for further explanations on this topic. They can reach me out on my email or on my cell phone. Again, I would like to thank the BioLeaks and the organizing committee of this conference for giving me this opportunity to share my limited views of my experience to the wonderful audience here. My thanks would not be complete if I do not include my family. They have been a source of constant support throughout my endeavor, and my extended family, that is my colleagues and my postgraduate students. They have been, again, a constant source of guidance and support throughout the making of this presentation. Thank you so much.
Thank you so much, Doctor. Anyone have a question or feedback? All right, thank you so much. And let's proceed with our next eminent keynote speaker is an honored doctor of Ukraine, DMSc professor, head of orthodontics department of Ukrainian Medical Stomatological Academy, president of Ukrainian Orthodontic Society, member of European Orthodontic Society, the author of more than 320 scientific works, interested in active using of modern digital technologies in orthodontic diagnostics and treatment of patients with malocclusion, clinical and biological reasoning of functional norm and code, concept in studying in features of individual, adaptive abilities of the human body as a holistic stomatognatic system due to contemporary conditions. Let us welcome Dr. Lyubov Smagliuk.
It's okay?
Yes, madam. Good morning.
My presentation is okay?
Yes, I can see it now. Proceed, please.
You can see? Dear Dr. Rajesh Basant, Ashish Pandey, colleagues, friends, and everyone who is here with us today. I'm a representative of the Ukraine Orthodontics Association, and first of all, thank you for the invitation to be a speaker at the symposium, and especially Dr. Elizabeth Manuel. It is very honorable for me. First of all, I would like to show a short video about my city where I live and work. It is Poltava, which is located in the center of Ukraine.
Не, вас не на этом, вас просто не показывают на этом. Вас призывают в этом.
Я поняла. Today is my report on the topic parafunctions of tongue, morphological, functional, therapeutics, and diagnostic aspects of their correction. Thank you, Sandra Colson, for your presentation. Our report is resonated with you. What is agents of the problem? Every year, current publication report about persistent high level of prevalence of malocclusion, which according to various authors accounted to the average from 80 to 90% of cases. Among etiological factors, only 30% are hereditary and from 75 to 85% caused by the effect of exogenous factors. As for functional disorders, parafunctional of the maxillofacial area, and from 55 to 65% are parafunction of the tongue. The second hand about the urgency of the problem, I would like to say about next. Now we observe increased in the number of patients with joint dysfunction. At the same time, if you look at the diagram, most of the symptoms of the dysfunction TMG, as for pain, displacement of the lower jaw to the side when opening the mouth, restriction of mind's opening, crunch, cling, and painful palpation are related with disorders of the oral function, among which the parafunction of the tongue occupy an important place. It is necessary to note that disorders of one of the function of the development area accounting for 38%. I mean, there at the same time, combination of functional disorders was noted at 61%. I mean, combination of functional disorders, swallowing, speeches, breathing, lip closure, and chewing. It is very important to understand that the all functions are interconnected and also their disorders occur in a complex. The urgency of the problem is also related to the problem of relapse after the orthodontic treatment. Among the such causes of the muscles disbalance by incorrect placement of the tongue has a certain place. The tongue is a massive muscular organ considered as the most effective organ of articulation. It should be noted that malocclusions which have developed due to abnormal position of the tongue during its function are characterized by a high degree of complexity in their correction and their risk for relapse. All of the above speaks of the relevance of these problems. What is the parafunction? Parafunction increased inappropriate activity, tension or spasm of the masticatory and facial muscles, as well as the muscles of the tongue. We distinguish The next, parafunctional. Parafunctional associated with the action of the masticatory muscles. Parafunctional associated with the actions of the lips, tongue, cheeks. Hypofunctional, parafunctional. Parafunction of the tongue can be chaotic movements of the tongue, periodic emphasis of the tongue on the cheek, tongue sucking. Sufficiently large passenger accounts for sucking and biting tongue from 60 to 37% of cases. Notably, that tongue habits are not always noticeable to the other. Sometimes it is quite difficult to differentiate some of them from the inappropriate functional of the tongue during incontinence and in swallowing. Some authors refer functional disorders of swallowing and pressing the tongue onto the teeth and sucking tongue one group. Publication report the functional disorders of swallowing occurs in from 32 to 61% of cases. The swallowing pattern changes from birth to adulthood. Critical periods in the formation of the swallowing function included the period of eruption of the first frontal teeth and initial periods of the mixed dentition. This creates critical condition for the formation of the mature pattern of the swallowing, and the incorrect position of the tongue can be fixed as a bad habit. The recent studies show that at the age of 8 years, the mature pattern of swallowing, which characterized by the absence of contact between the tip of the tongue and the lips, occurs in about 60% of children. 40% of children are in the transitional phase, and in 10–50% of cases, the mature pattern of swallow does not develop at all. Delay in the transition to normal swallowing can occur if the child has sucking habits. We distinguish the next etiological factors of the bad habits. Genetic factors, copying the behavioral response of adult, mechanical factors, psychological factor, neurological factors. Functional disorders of the dental velar area cause malocclusion and origination of inappropriate habits. The most common bad habits is mouth breathing, indicating its prevalence from 48 to 88% of cases. In the process of human ontogenesis, the need for breathing is the primary determining factor in the position of only the lower jaw, but also the tongue. Another functional of the tongue is speech. Phonetic speech factors is one of the most prominent in the formation, development of the human occlusion, and in the terms of evolution, speech has played a minor role in socialization Homo sapiens. Publications report that the prevalence of speech disorders varies from 2 to 25% of cases and is expressed in the indistinct pronunciation of individual sound or sound phonemes, irregular articulation of the tongue with surrounding tissue. Their intensive development of speech occur at the age from 2 to 5 years. At the age of 5 years, a child speaks using compound words and sound, thereby increasing the activity of the lingual muscles and facial muscles in the period of early mixed dentition, 6 to 9 years of age. The tip of the tongue does not meet sufficient resistance from the side of the frontal teeth due to their change and is located between the cutting surfaces. This breaks the balance between the lingual muscles on the one hand and the frontal teeth and lips on the other hand, which causes disturbance of their further eruptions, improper disposition in the dental arch. In this regard, this period can be considered critical for the formation of the speech function. Speech disturbance affects the volume of movement of the lower jaw, its lateral deviation at maximal mouth opening and articulation that can lead to TMG dysfunction then. Speech development caused by lateralization of brain, caused by strong stimulation effect of the development of the entire stomatognatic system. So, if we are talking about morphofunctional aspects of the tongue, we must understand the cybernetic system of the masticatory organ. According to this concept of the function of the masticatory organ are interconnected, related, are integral part of the whole human body and the environment. All these functions are related to the psychosomatic state of CNS of the person. In the performance of functional involved TFG, neuromuscular system, and occlusion. So, tongue is a massive muscular organ, which is one of the components of the dental jaw system. Tongue is important for chewing, swallowing, speaking, breathing, ensuring the width of the airways, posture, socialization. Functions of the tongue are provided central nervous system, respiratory system, nerve pathways, musculoskeletal system, dental jaw system. The central department of representative, Brock motor speech center, Wernicke sensor speech center, centers of chewing, sucking, swallowing. Peripheral department consists of maxilla structure, dental arch, TMG, neuromuscular system, and geoid system, geoid bone. Peripheral department of tongue important geoid bone and special attention to geoid bone. First of all, we study location geoid bone in space in relation to the third cervical vertebra, coincides with below or above the line. Then we measure the distance between the lower jaw and the geoid bone in millimeters. The normal distance approximately 15 millimeters, and the angle between the mandibular plane and geoid bone in the point of the gonion. Normal angle is equal to 25 degrees. So we can palpate the geoid bone. I will show how we do it. On this cephalogram, here the geoid bone located on all parameters within norm. There, each of these cephalograms, there is deviation from the norm. Another important indicator is the length of the tongue from its tip to the hyoid bone. Normally, it is equal to 82 millimeters. Next, very important, of the peripheral department of the tongue, functional neuromuscular system. There are such muscle, mimic, chewing muscle, muscles of the tongue, supra and infragioid muscles groups, all parapharyngeal muscles, the upper group of muscles of the larynx, respiratory muscles, diaphragm inclusive. Muscles then provide the function of the tongue. This is mimic, chewing muscles, orbicular, oris, buccinator, trigidus, lateralis, medialis, masseter, and temporalis. Muscles of the tongue and skeletal muscles of the tongue, all muscles of the tongue. Hyoglossus, genioglossus, styloglossus, and many muscles of the change form of the tongue. Muscles that provide the function of the tongue, supragioid muscle group and infragioid muscle group. We performed an AMG study of the muscles of craniomandibular systems during the sum test, such as maximum bilateral tooth compressing, forward displacement of the mandibular protrusion, swallowing water, and saliva swallowing. And we concluded that all studied muscles are involved in the functional of the mandibular and tongue. You can see EMG during maximum teeth compression. You can see AMG during protrusion and swallowing. Now, I want to speak about deformation, mandibular, maxillar structures, and dental arch due to parafunctional. Most often was observed open bite and deformation of the upper jaw, such as narrow and other deformation. The analysis of morphological data in the examined patient with functional disorders, swallowing and speech showed the such changes in the sagittal and transversal dimension of the dental arch, narrow of the maxillar dental arch in the area of the first molar, expansion of the mandibular dental arch in the area of the first molar. Consequently, in the follow-up studies, the emphasis was made an improvement of clinical aspects in the diagnosis of the state and position of the tongue during swallowing and speech. Based on our research, we have developed the algorithm for diagnosis the state and position of the tongue during swallowing and speech function. Algorithm first stage static research carried out on the basis of visual analysis, assessment of the state of the tongue, and at rest when opening the mouth, assessment of innate defects, size and position of the tongue in relation to the dentition of the mandibular, determining the shape of the tongue, assessing the relief of tongue surfaces, the state of occlusion, the shape of the dental arches and the tongue of the teeth of the upper and lower jaw. During examination of the tongue, using the suggested techniques by Smagluk and Trofimenko, we distinguished the three shapes of the tongue: narrow, oval, and square. In relation to the dentition of the mandibula, the tongue divided into three parts. The basic of the tongue coincided with the space outside the first molar. The dorsum of the tongue coincides with the area between the first molar, a group of premolar. The tip of the tongue coincides with the frontal group of the teeth. In our study, narrow tongue was detected account for 10%, oval shape was noted in 78%, and the square shape was found in 12 of cases. Assessment of the state of the bite, the shape of the dental arch, and the torque of the teeth of the upper and the lower jaw was. The second stage is dynamic research, study of the tongue of maximum extension from the oral cavity, determination of the size of the tongue, determination of the shape of the tongue, assessment of symmetry, sagittal, transversal, vertical movements of the tongue, assessment of the frenum of the tongue, determination of the tip tongue position during swallowing and speech. Assessment of the tongue frenulum, clinical and morphological parameters. It is very important, the assessment of the frenulum tongue. The length of the frenulum affects the formation of the correct phonetic structure of the sound of the upper eyes. The length of the frenulum affects the formation of the bite, affects the volume and completeness of the movements of the tongue in the oral cavity, sucking, chewing, swallowing, speeching. Assessment of the tongue position during the tongue during swallows, the clinic and paraclinic research. It is study the tongue contact with the arch of the hard palate during swallowing and speech. Photopalatography was carried out using the altering method for determining the position of the tongue during swallowing and speech by invention. We can see the view of the kappa on the color diagnostic study cast after test on tongue posture during infantile swallowing, pronunciations of the sound T, D, and N. The elimination of dental velar dysfunction is important to understand their impact on the general state of the human body and functioning as a whole. Therefore, we have identified the main direction of treatment and prevention measure for the treatment of patients with functional disorders of swallowing and speech. First of all, normalization of the general somatic condition of the patient, healthy balanced diet, general strengthening exercises to correct posture and strengthen the muscular corset of the neck and back. Normalization of dynamic balance between the outer and inner muscle circle of the maxillofacial area. Bed gymnastic exercises for muscle of the lips, cheeks, and muscles then affect the position of the lower jaw and the oid bone. controlled my gymnastics for the tongue. The main therapeutic aspects, this is general strengthening exercises to correct posture, bracing elbows, sliding hands along the wall, sliding squats. I show you. The main therapeutic aspects exercises to strengthen the muscular corset of the neck, compression of the neck, flexion and extension of the neck, turns the neck to the side, lateral flexion of the neck due to resistance. The main therapeutic aspects my gymnastics exercises for the muscles of the lips, cheeks, and muscles then moves the lower jaw forward. Exercises with button, inflating the cheeks, inflating a balloon, moving the lower jaw forward. The main therapeutic aspects for the controlled gymnastics for the tongue, we used Autor's appliance. It is consist alveolar clasp, dental alveolar clasp, fragment basis, tongue guard, tongue clicking, you hear, swallowing movement, pronouncing along words or tongue twister with an accent on frontal lingual d, t, n, and the whistling sound s, f, f, s. You can see photopalatogram patient of 70 years old after swallowing test before orthodontic treatment, like area circle, photopalatogram of the same patient after swallowing test a year after orthodontic treatment, like areas circle. I would like to show you some cases before and after treatment using our Autor's appliance. The patient 6 years, 8 years, 11 years, and when she was 11 years, we started fixed appliance, and brackets. This was 22 years, and after 1 year of the orthodontic treatment. The case report, the 2 case report, the open bite and parafunctional of the swallowing and speech, parafunctional tongue of the swallow and speech, and you can see the dynamic of the treatment. And in 28 years, patient was fixed appliance brackets, and after 1 year, 21 years, after 1 year of the treatment. Speech is really the most important function of the masticatory organ. The main task of the masticatory organ communication speech, through which we can interactive with the environment. The case report 3. This woman has a back habit, tongue lincoln palatal surface, central incisors, and as for result, protrusion of the frontal teeth. And before and after treatment, you can see show you the dynamic of the treatment. And the end of my presentation, I would like to show you some films about the health and world health child in our planet.
You're on mute, ma'am. You're still on mute.
I have a monograph about this problem, and I would like to end so. Orthodontics is a leader in ensuring the overall health of each of us. Thank you for your attention.
Thank you so much, Doctor. Anyone would like to ask any question or provide a feedback? Question?
If you do you have a question?
I think none. Thank you so much, Doctor, for that beautiful presentation. Very inspiring. Next, let me go ahead and call on our next eminent keynote speaker, who has completed his PhD in orthodontics at the age of 34 years old in 1998 at the University of Sao Paulo, Brazil, USP Bauru, and his postdoctoral degree. My apologies. No questions. Let me go ahead and call on our next keynote speaker. Has completed his PhD in orthodontics at the age of 34 years old in 1998 at the University of Sao Paulo, Brazil, USP Bauru, and his postdoctoral degree in orthodontics at the same university in 2001. Since then, he has coordinated postgraduate courses such as specialization and master's degree in orthodontics. In addition to working in private practice, currently he serves as the scientific director at Eduardo Dainese Institute Dentistry Postgraduation School, Bauru, Sao Paulo, Brazil, and as a visiting researcher professor at the University of Sao Paulo, USP Bauru. Session chair for Third International Conference in Dentistry and Oral Health 2021. Let us welcome Dr. Eduardo Alvarez Dainese.
Thank you. Thank you
Good
so
day, sir.
much. Good day. How are you?
We're good. We're good.
Let's get it started.
Please
Okay.
proceed.
Okay. Thank you. Can you see my presentation?
It's coming. There. Yep. You may
Okay.
proceed, doctor.
Okay. Thank you. Um, I'd like to thank the entire organizing committee for the 30th International Conference on Dentistry and Oral Health for the invitation. Thank you so much. I'm glad to participate in this great conference, and it's a great pleasure for me to be here today. Okay? I'd like to share. Thank you so much. I'd like to share the preparation I have prepared about OBP. What is OBP? OBP is optimized biomechanical protocol. Okay? In Portuguese, PBO. In English, OBP. That's right. And that's me, Eduardo Dainese. Okay? That's what I do in Brazil. And I would like to show you my hometown city, Bauru. It's a beautiful city, about 400,000 inhabitants, and it's a hot city. Okay? This is me and my wife. She is also a doctor in orthodontics. Images of our institute with some resident students of postgraduate courses in orthodontics. More students. And I'm very grateful to all the great orthodontists who have gone through my professional life and made me what I am now. Especially a friend of mine, Dr. Guilherme Janson. More orthodontic friends, excellent professionals. Well then, let's introduce the OBP. Biotechnological advances in the orthodontic field and all knowledge in this topic supports OBP. Technological advances exist in all fields of knowledge, and this is always due to the need for evolution. And evolution is the key to everything. So we have the evolution of the orthodontic brackets. In the past, the 90s, or 29 edgewise, conventional edgewise brackets, like this. At the present time, 2021, self-ligating brackets, like this. Future, it's a mystery. By now. So, we have also the Ashwar evolution. Past, stainless steel. Nowadays, 2021, static grade thermodynamic night eye. And you can see here how it works. Very nice. Future continues a mystery. Okay? And thus, we always have the option to perform orthodontic mechanics like that. But, or do orthodontics in a simple and a more controlled way through the OBP. That's why I prefer. Let's get straight to the point, because a comfort zone is a beautiful place, but nothing grows there. Okay? So we need to change. OBP, it's a new clinical approach based in biotechnology of orthodontic materials, scientific evidence, and clinical evidence as well. Purposes are reduction in orthodontic biological cost, chair time reduction, and more time to refine and detail the occlusion. OBP has his philosophical basis in self-elongating brackets, great thermodynamic wires, and strategically placed crimpable stops. That's OBP. And for OBP, the more crowding there is in the malocclusion, the better. Crowded is better. Okay? Principles of OBP are light forces, physiological mechanics, friction reduction system, and tooth movement optimization. We can choose how to carry out the orthodontic treatment and I think it's better the straight path with total control of orthodontic mechanics, knowing exactly where I want to go. I brought Carol's case to illustrate OBP today. Okay, this is Carol. This is Carol malocclusion, a compensated class 3, how we can see. The occlusal view of the malocclusion. And we start when she was about 12 years old. Okay? Section 1. Section 1 was installation of the orthodontic appliance in the upper arch with 12 thermodynamical night eye. And we can see here the blue arrows show the stops on the mesial of the first molars. And the green arrows indicate the direction of the movement proposed by OBP. Okay? So simple, so easy, not so complex. The occlusal view, again we can see the stops by the blue arrow and the movement of the teeth by the green arrow. Okay, just on the upper arch. Section 2. Now it is 16 by 22 GT graded thermodynamic night eye wire with stops in the same places, mesial of the first upper molars. Blue arrow showing the stops, green arrows showing the movement of the teeth. Okay? In the second section, again the occlusal view, the position of the stops, mesial of the first molars, and the green arrows, the movement proposed by the OBP. Okay? Section 3. Section 3, a 19 by 25 GT night eye, only in upper arch by now. And at this time, without the need to install stops anymore, as the arch is practically aligned and leveled. You can see no stops anymore. Section 4. Now, in section 4, we maintain the same archware in the upper arch, 19 by 25 GT night eye, and mounting the device on the lower one with a 12 thermodynamical night eye. You can see again the position of the stops in the lower arch by the blue arrows and the movement proposed by OBP with green arrows. Okay. Upper view is better to see this. The position of the stops at the lower arch in the blue arrows, and you can see the movement proposed by OBP, green arrows. Okay, movement for backward. Section 5. In section 5, we have new lower arch. Upper arch is still the same, 19 by 25 GT Naitai. And now, in lower arch, 19 by GT by 25 GT Naitai, with different position of the stops. Now this position of the stops is to increase the anterior anchorage and also align and leveling towards the posterior region of the dental arch. All the movement of the teeth goes to distal because we increase the anchorage at the front of the arch. We can see here the blue arrows showing the position of the stops and the movement proposed by OBP. The increase of the anchorage at the anterior area of the arch and the movement for distal. In section 5. In section 6, we change the Naitai wire, and now we have 19 by 25 stainless steel, upper and lower, with class 3 elastic mechanic. Okay? To finish correcting class 3 malocclusion. Section 8. In this section, we are completing the malocclusion correction. At this point, the mechanic that you can see here will be present for 4 months. Okay? 4 months, keeping the same mechanic that we see in the section 8. 19 by 25 stainless steel, upper and lower. Occlusion view, how we can see, practically ending. Section number 9, finished the treatment. We can see the final extraoral images of Carol. Beautiful girl. Here we can see the result of the orthodontic treatment performed with the OBP. I think it's a good finish. And here also we can see the fixed retainers, upper 1 by 1 and lower 4 by 4. With the addition of a removable retainer in the upper arch, under upper arch. So, 2 fixed retainers and 1 removable retainer on the upper arch. This image shows the protrusive disocclusion movement. You can see it's a good movement. Left lateral movement, working and non-working side, and right lateral movement, again, working and no working side, sorry. And now I show you a 4 years post-treatment images, a control the Carol's treatment. You can see here extraoral photos 4 years after treatment. You can observe the stability of the facial profile and the position of the lips and the skin, the chin, and her nose. This is Carol 4 years after finishing her treatment with OBP. The occlusion, very stable occlusion 4 years after the end of the orthodontic treatment with the OBP. Occlusion view, there's no need to keep the removable retainer anymore. Just fix the retainer, upper 1 by 1 and lower 4 by 4. You can see here the control X-ray images and look the relationship between the incisors, overjet and overbite, and the absence of root resorption. Very nice. Before the treatment and the transformation after the treatment, how we can see now. So, before and after, and only 9 sections of treatment. Of course, a difference between the sessions, a session by 2 months, okay? Only on the section number 8, we keep the same mechanic through 4 months. And now, that's what I have to show you today. One more time, I would like to thank the entire organizing committee for having invited me, and I'm very honored to participate in this conference.
Thank you so much, Doctor.
This is my contacts, and I'm looking forward to seeing you soon. Thank you very, very much.
It's our pleasure. Thank you so much, Doctor.
Thank you.
Anyone would like to ask any questions? All right, thank you so much. And let me go ahead and call on or welcome our last keynote speaker, who is a specialist, Mir.
Jojo, please unmute your mic.
My apologies. Thank you so much, Doctor, for that presentation. It is our pleasure. Now let's call on our last keynote speaker, a specialist in orthodontics, University of Sao Paulo, Brazil, master's degree in orthodontics, Uni Arara, Sao Paulo, Brazil. coordinating professor of the specialization program in orthodontics at Instituto Prime Bahia, Brazil, international speaker.
Okay. Hello. Hi, everyone. I'm Kleber Meirelles, professor of orthodontics in Brazil. I'm here to speak with you for this half an hour about something that I love to talk about, which is bends and loops. Actually, I'm gonna say just some things and some tips for you about bends and loops that may help you in your day-to-day practice. But first of all, I'd like to thank for the committee of the BioLeagues of the Third International Conference on Dentistry and Oral Health for inviting me for this conference. I'm glad to be here speaking with you because India is a place that I learned to love. And for you to know where I'm from Brazil, this country here, and this is where I live. This town is called Salvador. This is in northeastern Brazil. It's a very beautiful town, very beautiful city. I love to live here with a colorful people, a colorful place. Most of the year it is warm. It has this warm temperature, and here it is, our Bay Area with this beautiful place here that is called Farol da Barra. It is the Barra Lighthouse in English would be called like this. So this is the place where I live. Don't have much time about to say much about this because we have just half an hour. And for that, I'd like to start saying to you that Brazil is a very beautiful place to visit. So if you come to Brazil, you may like our, our people, our places, our cities, and most of all, we like our spirit here. So this is where I am, and this is how far we are one from each other. But nowadays, it's possible for coming together, for being closer using this kind of platform like Zoom, for example, and being present in other countries to speak of our experience in our field. My specific field is orthodontics, and this is your country. This is my wife, Manuela, and she's been to your country last year in 2020, and she loved your country, loved your culture, and all the places she visits. She took millions of photographs, and she shared with me. We had the opportunity to see many, many places in these photographs, and she really loved this beautiful trip. And when it's possible, because of the pandemic, as you all know, I'm planning on visiting your country also along with her. Okay, so let's begin with our topic today, which is bands, the use of bands and loops for refinement of occlusion. What is a band actually? What is a loop? Why does it help in our day-to-day practice? Because sometimes we need to do this kind of refinement because our practice with straight wire appliances, as you know, has its drawbacks. So sometimes you cannot align well or level well your teeth because of some particularities of your teeth, of the surface of the buccal surface of your tooth, or because of the particularities. It's very difficult for us to use just one tool to treat everyone. So for that, we use bands and loops and other devices just in order to achieve the best refinement possible. So Bends are made in order to correct the positioning of a tooth or group of teeth in 3 planes of space. They are named according to the movement they impose on their teeth. So in first order, second order, or third order, in this case, bends to be moving your teeth or just a tooth. It depends on what you are trying to correct. So night-tie wires may not be completely efficient to tackle some nuances of poor dental positions. We know that. If you are working with orthodontics for a while, you see that in some situations, for example, when you have a soft crowding, a just mild crowding on the lower arch, sometimes it's not possible to have all those tips aligned correctly, perfectly aligned, because we have some difficulties for that. So sometimes we need to use bands to achieve the best positioning of these teeth as we can, okay? So what are we going to do with bands and loops? We do bands, first bands in order to do vertical, horizontal, like rotational movements, and third order bands are those associated with the inclination of our teeth or our tooth if you want to just apply it just to one tooth, okay? So in first order bands, we do movements like in horizontal plane. If you look from upwards, we look from up to our teeth, to our occlusal aspect of our teeth. We see the movements that we do that are mainly rotational corrections like this, or insets or offset bands in order to achieve a best positioning in a horizontal view, looking from up, okay? So this is what we call first order movements, horizontal movements, horizontal bands in the arch wire to achieve the best position in this view. So second order bands, what are those? Second order bands are those bands that we do in our arch wire in order to correct angulations. For example, we want to move our root in one direction, mesial or distal direction, or we do vertical movements like intrusion or extrusion steps. And third order bands, finally, are those movements to do the correct inclination, to achieve the correct inclination of our teeth crowns. So when we have, for example, one movement to do this kind of buccal inclination of posterior teeth, sometimes we want to do the torque in order to, what we call the third order band is a torque. We do this kind of torsion in our arch wire in order to achieve the best positioning regarding to the inclination of our crowns. The posterior teeth, the anterior teeth, whatever it needs. So sometimes we do, for example, during the retraction of anterior teeth, we need to understand what we have to do in order to achieve the best positioning of this teeth, this group of teeth. Inclining those teeth buccally or palatally may have a very, very different, may have different aspects in smile, during smile. So we have to master this kind of inclination. The torque is our day-to-day practice. And you cannot just apply torque thinking just in our brackets, in our fully programmed brackets, because we know that we have the possibility of not achieving the best position, and because we have some drawbacks in this relationship between the rectangular wire and the slot that we are using. Sometimes we may not have the correct reading of the torque and the angulation embedded in those brackets, inside those brackets. So sometimes we have to do it ourselves. Most of the time, actually, I have to do this using my third order, second order bands to do the correct inclination, because sometimes you do second or third order bands to do this correction of the inclination, okay? This is what we achieve when we do the torsion of the rectangular arch wire, and we insert this rectangular arch wire with this torsion inside this slot. So the bracket slot of the tube slot. So we do this relationship, which is an active relationship between the inclination of our rectangular arch wire, the transversal section of our rectangular arch wire, and the bracket slot. So we can have either a passive relationship, doing nothing to those teeth, or an active relationship, which is going to incline those teeth in the direction we want those teeth to be inclined, okay? So this is the third order bands. But before doing bands, we need to be aware of what we can do before initiating our treatment, before doing our mechanics, in order to achieve the best result in our treatment with less time, less chair time, and less treatment time. Meaning, if we do the correct boning, for example, of the brackets, it's most probably you will not need to do many bends in your treatment to correct the bad positioning of a tooth or a group of teeth, because you did that anticipating the problems that could be generated if you do the wrong positioning of the brackets and tubes. Anticipating that problem, you try to achieve the best positioning possible. So you need to be aware of some situations that we have to pay attention before initiating our treatment plan, initiating our mechanics itself. The centralization of brackets and tubes, in most of the cases, it's very important because this is something that may apply some errors during our mechanics. The height and angulation should be carefully checked, and sometimes we change heights, sometimes we change the angulation during bonding. So change bond height in special case, is that necessary? We'll see sometimes it's necessary. Change angulation in special cases, sometimes necessary. And so this is something that sometimes we do not pay enough attention, and we may cause some problems that may need correction during our treatment, which is the excess of composite during bonding. So we do some kind of misplacing of our bracket of our tube because of leaving some kind of excess of composite in the bases of our brackets or our tubes. So the centralization, first of all, is important, mainly in the anterior segment of the arch wire, because when we do it wrong, when we commit some mistakes in positioning regarding the centralization, we may have a rotation of one tooth because we did the bad positioning. For example, in this situation here, as you can see, this bracket was positioned distally to its central position, to its central, the central position that we wanted to have. So in this case, the distal position of this bracket, it caused a rotation of this incisor, which needed to be corrected. So for that, we did this band, which is a first order Z band, to correct the positioning of this rotated tooth. So if I didn't mistake the positioning at the beginning of our treatment, it's possible that I wouldn't need to have this kind of band during our treatment. So this is what we do to save time in our treatment in orthodontics. We need to anticipate the problems. We need to do everything in our minds to anticipate the possible problems that are generated in the mechanics. And one of those problems is the wrong positioning of our brackets. So in this case, the wrong positioning of this bracket caused this rotation of the mesial part of this incisor, bringing it palatally towards palatal, and this is something that we need to correct, we need to address during our treatment. So this is something important. Try to avoid the bad positioning regarding centralization of your bracket or of your tube, okay? Another thing, as I told you before, is this. If you do not pay enough attention when you are putting your brackets in position, when we are positioning our brackets, sometimes when you look with a mirror, when you look to the mirror, to our clinical mirror, to the positioning, the occlusal view, sometimes what we see is this excess of composite in this position. And this is something that will also move the tooth, move the mesial part of the tooth, in this case, the mesial part of this tooth, palatally, and we need to correct that. So you may be asking, why don't we just rebond this bracket? This is something that I have to explain for you now, because sometimes you just may think, I just rebond brackets, I just do this when I do need to correct an angulation, when I do need to correct the height that I did this mistake during the positioning of the brackets, I just rebond the brackets and I go backwards with my aligning arches, with my arches, my arch wires, and I go back to, for example, a 014 night tie arch wire. It's good, it's possible, but we may be using some kind of possibility that will make a longer treatment, because when you do that, you have to go backwards in your arch wire sequence, and you go running again your arch wire sequence until you reach that arch wire that was already positioned. So sometimes you have to go back to, for example, 014, the 14 night tie, and then we go 16, and then we go again with around SS wires, stainless steel wires, till we reach that arch wire that was already positioned. Okay, so what we do when we do bands, for example, first order Z band, we do the correction using the same arch wire that we are using when we realize that we committed that mistake, in this case, the excess of composite. So in this case, we do a Z band, for example, a first order Z band, a vertical loops, and whatever you want to do. And then you go running forward your sequence. Again, doing another band, a more expressive band for that. So when you have this correct, you may just need to rebound, but using a stiffer arch wire. You don't need to go backwards. You don't need to go back in your sequence. So this is something that we do, walking forward, not backwards. So this is why I use to match bands and loops and everything I need in order to be to have a forward movement of my mechanics. Okay, so this is something we need to avoid. So this is something we have to pay a lot of attention, because this is going to make some trouble for you to correct during your mechanics. So be aware of that, anticipate that, and pay enough attention in order to avoid this to happen. Okay, so let's move on. Class 2 and class 3 cases. Is it possible to move our bracket during bonding forward or medially or distally in order to achieve a better outcome, a more rapid, a faster outcome of our treatment? Is it possible? Yes, sometimes it is. Sometimes we can do just positioning our bracket towards medial or towards distal in order to favor our settlement of our cusps. And this is something that I do in class 2, mainly in class 2 cases. What can I do for that? I move it mesially. I move just a little bit mesially my brackets in premolars and canines. So when I do that, I'm rotating a little bit those cusps, moving that cusp a little bit more distant. So in the upper arch wire, in the upper arch, I do that. I position just a little bit mesially. This is not something that I come with. This is something that McNamara established a long time ago. And this is something that I've been doing just for many, many years. many years of doing this kind of trick just to achieve a better settlement of my cusps in a class 2 case, okay? So when you do that, you will rotate a little bit your cusp, you will distalize a little bit your cusp, which will favor the positioning of those cusps between those two lower teeth. So this is something that may favor your mechanics. But you may ask, but if I do not do this kind of, it's okay, we'll do that with another band, we can do that with elastics. So we do that in other ways, but
in this situation, if you want to have a little bit of class 2 and you want to correct that with less effort, let's say, you may do this kind of trick. It's a little bit of a trick. You just move a little bit majorly your bracts in premolars, upper, first and second premolars, and either in canines, okay? And we do that to achieve a faster correction of our class 2 cases, and in order to have this beautiful settlement of our cusp in this position here. So this is something that may help you in your class 2 cases. In mild class 2 cases, this is something that can help you in this finishing, okay? As you can see, we're not talking about bands and loops yet. We're just talking about the possibilities of avoiding bands and loops. So a class that concerns bands and loops may address, first of all, the possibility of avoiding the use of bands and loops. That's what we are doing now. We are just thinking about possibilities of changing our this environment of putting all the braces in the same position, putting all the braces in the same angulation. So sometimes we change that in order to favor our mechanics. For example, in this situation here, you have the canine, the lower arch, for example, mainly in the lower arch, it will be very clear for you, because sometimes you have this step here when you look from up, from above, you look this step between the lateral incisor, the distal portion of the lateral incisor, and the mesial portion of the canine. The mesial of the canine is inwards, is lingually positioned because of this thing here. We centralize, as we were taught, we centralize our bracket, but this is, in most of the case, this is bad for our treatment, because this bracket here, it won't tackle all the thickness possible in this kind of canine, in this tooth, in this group, in this teeth, the canines. So sometimes the base of this bracket is not thick enough to compensate. It's not, I'm sorry, again, not thick, I'm sorry. This is not, does not have, sorry for that, this bracket does not have all the possibilities of thickness of the base to cover all the thickness of the canine itself. I know it's a little bit confusing, but let me explain better. So sometimes when we used in the past edgewise brackets, it was common for us to do this band since the beginning, because we didn't have the embedded difference between lateral incisor and canines. Thickness of the base of the lateral incisor, it's a little bit thicker. So in order to compensate the thickness of the tooth itself. In this case here, the canine is not that thick, or if the canine is very thick, sometimes we have to do these compensatory movements in the arch wire itself. In this case here, the canine was very thick comparing to its neighbor, which is the lateral incisor, and it's not compensated in the base of the bracket. It's not compensated embedded here in the base of the bracket. So it takes the canine inwards. What is the tip here? You bone the canine, you position the canine a little bit more mesial, a little bit to mesial, in order to achieve this outward positioning of the mesial portion of the canine. Let me show it to you here. In this side of the arch wire, in this side of the arch here, what we have is a mesial positioning of the bracket of the canine. So as you can see, when you do that, we go outwards with the mesial part of the canine, allowing it to be more aligned to the lateral incisor portion, the distal part of the lateral incisor. So as you can see here, we have this beautiful line connecting canine and lateral incisor. In the other part of the contralateral canine, and in the other hand, we have the opposite. We have this step in with the mesial part of the canine, the mesial portion of the canine, inwards related to the lateral incisor. So what can we do here? Just position your brackets a little bit more mesial. Look here, look upwards here, look up here, and you will see what I mean. So sometimes we can do that, but if we mistake this positioning and we already have this bad positioning here, we already have this step occurring in this position, we can fix this with a band, for example. If we do not do this in the beginning of our treatment, if we not do this mesial positioning of our bracket of the canine, and we come up with this mistake, we come up with this thing here, this step, looking from above, we see this step, we can correct this using a first order band. In this case, a first order to go outwards with this portion of the canine, as you can see here. And here's the band, here's the band, here's the canine eminence band, which is more like a curve than a marked band. It's more like a curve resembling the canine eminence itself, okay? We have it here. As you can see, it's already corrected now. So this is something, first, think forward, think again, anticipate the problem, do the correct positioning of your bone, during your bonding of your bracket. In this case, positioning it a little bit more mesial. So in this situation, you will have a finer step, a finer alignment between the lateral incisor and the canine, okay? But if you see this mistake during your treatment, if you see this outcome during your treatment, whenever you see the problem, you will correct it. So as you can see here, I just saw this problem when I put the rectangular arch wire. So if I saw this problem earlier, I would have corrected that earlier. Since the round wires, the stainless steel round wires, since they 016 or 018 round wires, I start doing my bends in order to correct, in order to go forward in my mechanics, doing the correction since this point, okay? So in this case, I really mistake the positioning of the bracket, and I just saw the problem when patient was using the rectangular arch wire. So I had to correct that, and for that I used this first order Z band, which we call eminence, canine eminence band. Let me just grab a sip of water here. So height and angulation should be very carefully checked, because when you do a bad positioning of the height of the bracket, sometimes when we do this, depending on many factors, of course, but most of the time we may have a bad outcome when we put our rectangular arch wire inside the slot. Sometimes when you do that, we generate a different moment that that we didn't want to happen. Let me show it to you. So this is the center of the clinical crown. This is the place where the bracket is meant to be, because all the calculation made for that bracket, for doing the fully programmed bracket, was meant to be in this position, okay? This is the central positioning of our bracket. This is where we aim to put our bracket in most of the cases, in most of the fully programmed brackets, fully programmed straight wire brackets. So this is where the reading of the torsion of the inclination of that crown is made. So in this case, when we use straight wire brackets, we use fully programmed brackets, we have the prescription for that bracket previously known. We know what prescription we are using. We may have 3 degrees of inclination. We may have 7 degrees, 8 degrees. It depends, of course, of the prescription that you are using. I use Andrew's prescription, which is 7 degrees, for example, for the central upper incisor. So in this case, we have it embedded inside the bracket base. So we have the torsion, which is we call torque. We have the torsion, which is not a torsion, but we have the inclination, the third key of normal occlusion, the inclination of the crown is already embedded in this bracket. Of course, as I told you before, depending on the prescription we are using, we may have more than 12 degrees. We may have 22 degrees in some situations. But all of those calculations were made for the positioning of the bracket in the center of the crown, in the center of the facial aspect of our crown, okay? So in this case, when we do the positioning, fleeing outside of the position of the center of the crown, what is going to happen to those teeth? So if we put in the right position, we will achieve, if we put a rectangular, stiff rectangular arch wire, in this case, I use a 022 or 030 bracket slot, and my last arch wire is 1925. Of course, I have a little bit of a play inside it, but the reading of the torsion is very good. And if we do the right positioning of our bracket, the reading of the inclination will be almost perfect, okay? Let's simplify the things. So in this case, we may have a good reading. Depending on your prescription, you will have more or less inclination. But what happens when we do not position in the center of the crown? What will happen, for example, let's say we have a 7-degree inclination bracket of a central incisor. When I do, it's common to do that. You know that, for example, in a anterior open bite, it's very common that many teachers say, go direct, position your bracket more apically, more far from the center, more apical, and you will have a better, a faster closure of your anterior open bite. It makes sense, of course, it does. But we may have a problem when we go in our sequence of arch wires, reaching the rectangular arch wire. Why that happens? Because of this. Because when we do this, using this higher positioning, we do not know which is going to be the inclination, the actual inclination of the slot, because we are doing this in a concave, in a convex surface, depending on the way we represent concave or convex. But it's a round surface, let's say this, to make more simple. So in this case, putting it a little bit upwards, in this case, to achieve a better closure of the anterior open bite, we may jeopardize the inclination that we want to have for those teeth. Of course, if we know how to do the torsion, we don't have to be afraid of that. We may just do this torsion and the correction, and we may do everything we need just doing the torsion of the arch wire, the rectangular arch wire, to achieve a passive relative torque. But sometimes we are not aware of that when you just put the arch wire inside our slot, and what's going to happen is we are going to change the inclination of that crown. And sometimes during this lingual inclination, palatal inclination of upper anterior teeth, you may cause a root resorption because you are throwing your root against the thick cortical plate, the buccal cortical plate. So sometimes you do this in order to achieve a easier closure of your anterior open bite, but you're also causing something bad for your tooth, for your teeth, which is throwing those roots against the surface of the buccal plate, okay? So this is something that we have to be aware of. So just in this half hour, we don't have much time to discuss all aspects involving the positioning of brackets and so on. But those things I consider are very, very important. Okay, so I'm gonna finish it here because I know we have a restrict time to do our speech, and hope it helps you in some way. So I just picked some tips for you to understand that we even though we know to do the bands, we know to do the correct position, and we know to do adjustments in our arch wire. If we think things before doing, if we just plan everything, we may prevent the problems to happen. So this is the most important thing in our lecture. So hoping everything was clear for you, and I apologize for the time, for not having enough time to go further in this explanation, but I just picked some tips for you to understand that in orthodontics, we have to plan before doing. We have to plan everything, and sometimes we just change the outcome because we planned correctly. So this is the most important thing in this life. So I thank you again for your time, and anytime you want to contact me on social media, you can be my guest, please, and ask me whatever you want, and whenever I can, I will reply for you, okay? Thank you very much again for being with me. Hope to see you soon. Bye-bye, and be safe, my friends.
Yeah, that was just a video presentation. Unfortunately, we cannot cater any questions or feedback that may arise. Now, for now, I would like to request everyone to please open their cameras. I would like to take a photo of us all for today, and give me that big smile of yours. I have 4 pages, so please smile and hold it, because I'm gonna be um, capturing 4 pages of. I cannot capture it 1 page. All right. So first page. There you go. Come on. Well, one moment. Let's wait for everyone. Let's give it a minute. All right. Let's smile. 1, 2, 3. Next page. Hold it. Third page. Smile. Hold it. Thank you. Now fourth page. Hold on. Fourth page. Hold it. Smile. All right. Thank you so much, everyone, for cooperating. Let's now, the most awaited lunch. Let's go ahead and go on lunch and be back at exactly 1:30 India time. See you later, guys. Everyone will start in 2 minutes. Again, we'll start in 2 minutes. Welcome back, everyone. Welcome back. For all the conservative dentistry, please remain in this room. This is the main room. I would like to welcome all our session chairs for our technical sessions today. Dr. Asha Arya, Professor and Faculty of Dental Sciences, SGT University, Gurgaon, India. Dr. Anshul Arora, Associate Professor, Faculty of Dental Sciences, SGT, University of Gurugram, India. Dr. Arpit Sikri, Associate Professor and PG Guide, Department of Prosthodontics in Crown and Bridge, Bojia Dental College and Hospital, India. Dr. Suresh Kamble, Principal, Maharashtra Institute of Dental Sciences and Research, Dental College, Latur, India. Dr. Binetti Aloysius Fernandez, Senior Lecturer, Faculty of Dentistry, Seji University, Malaysia. Dr. Chaya David, Professor and Head of Department, Dayananda Sagar Dental College, Bangalore, India. Dr. Shweta Chaudhary, Pedodontics and Preventive Dentistry, Associate Professor and Postgraduate Guide, American Heart Association Certified Instructor for BLS and ACLS courses, India. Dr. Deepak Baya, Professor and Head, Department of Pediatric and Preventive Dentistry, Hitkarini Dental College and Hospital, Jabalpur, India. And Dr. Tarut Lata Shayagali, Professor and Head of Department of Orthodontics and Dentofacial Orthopedics, Hitkarini Dental College and Hospital, Jabalpur, India. Welcome back, everyone. And now we will have breakout rooms. Hold on. So we have a total 5 rooms. Now for conservative dentistry and endodontics, please stay in this room. I will be your host. And for parallel session 2, which is the oral medicine and maxillofacial prosthetics. Parallel session 3, periodontics and community dentistry. Parallel session 4, general dentistry. And parallel session 5, orthodontics and pediatric dentistry. Please, for the rest of the topics, please join the breakout rooms. Just right below your Zoom meeting, you will see their breakout rooms. Click on breakout rooms and you will see there the 4 other categories. Now, for conservative dentistry and endodontics, stay in this room. If you are having problems joining breakout rooms, please shoot a message on the chat box and our technical team will move you to the breakout rooms. Again, if you are having problems joining the other breakout rooms, please shoot a message on the chat box and our technical team will move you to your conservative dentistry and endodontics. Let's start. I welcome all the participants for the technical session 1 that covers conservative dentistry and endodontics. Our session chair, Dr. Ansul Arora and Dr. Ashta Arya. Dr. Anshul Arora, for your presentation, doctor. You are now.
Yes, ma'am.
Yes, I can hear you now. Go ahead, please.
Yeah. Myself, Dr. Astha Arya, ma'am. So, should I start with my presentation?
Yes, please.
Okay. Thank you. Hello, everybody. I am Dr. Astha Arya and professor at SGT University, Gurgaon. The topic for my presentation is lasers, a novel approach for in-office bleaching. Cosmetic dentistry has become an integral part in our dental practice, and almost 1/3 of the population is not satisfied with the form or the color of their natural teeth. A smile lined with white and shimmering teeth makes a person feel more confident and attractive. So today, the topic will be on in-office vital tooth bleaching. Bleaching is a procedure which involves lightening of the color of the tooth through the application of a chemical agent to oxidize the organic pigmentation in the tooth. It is a non-invasive, conservative procedure to restore the normal color of the tooth. Different techniques for vital bleaching are: it can be done at home by using 10% carbamide peroxide, in office by using 35% hydrogen peroxide, and over the counter 5.3% hydrogen peroxide gels or strips are also available. Different energy sources that are used for activation of the bleaching agents are: it can be done by heat, by using halogen lamps, plasma arc devices, or LED lights. But with the advent of the lasers, diode and ND8 lasers are also being used for the activation of the bleaching agent. So this is the diode laser, and this is the ND8 laser that is being used for the activation of the bleaching agent. The common oxidation process associated with bleaching is the darkly pigmented carbon ring structures are converted into lightly pigmented unsaturated structures, and this is being done till we reach the saturation point. And if we reach the saturation point and still continue with the bleaching, then it will lead to breakdown of the enamel matrix, and there will be loss of the enamel matrix. And therefore, we have to assess how many sittings we need to do. We can't continue the bleaching as long as we want. Now, what is the importance of lasers in bleaching? We already have so many light activation devices, but now lasers are being used. So what is the importance? The first is there is high intrinsic overall radical yield. It reduces the number of visits. The rate at which the radicals are generated is higher than that of thermal activation. That is, zoom bleaching light is used, or even composite curing light is being used to activate the bleaching agent. But the rate at which the radicals are generated when we use this type of laser lights are used for bleaching, the rate at which the radicals are generated is more. The heating of the teeth is minimal, and therefore we can use high energies so that the overall radical yield is increased. It reduces the contact time of the bleaching gel with the tooth, and the decomposition reaction of the staining agent is more. So we can see in this animation that when the bleaching gel is used in the absence of laser energy, this is the depth of penetration. But when the gel is activated by laser irradiation, we can see how deep the action is there, and the depth of penetration is more of the bleaching of the radicals, and therefore the action is much better. But there are a few contraindications to the use of bleaching. First is hypersensitivity, exposed root surface. In these cases, we generally don't recommend, we don't go for bleaching, otherwise there will be severe sensitivity. If there is gross caries, in extensively restored tooth, in case of pitted enamel, and if the patient is allergic to chemical products like hydrogen peroxide, or even in case of pregnant women, we don't go for bleaching. Now I would like to show one clinical case where we have done bleaching using lasers. So first, oral prophylaxis was done using pumice, and then the preoperative shade was evaluated. The isolation was done using cheek retractors and cotton rolls, and gingival barrier was applied along the margin of the gingiva to protect the gums. This is the bleaching agent that is used along with the laser light. So it is part B is the liquid phase and part A is the solid phase. So both part A and part B are mixed thoroughly to achieve a homogeneous consistency. Then a thin layer like this is applied on the tooth. Approximately the layer is 2 mm thick. And then each tooth, this is the laser light. This is the handpiece that we are using to irradiate the tooth with the laser light. So each tooth is laced for 30 seconds in the same sequence as we have applied the gel, so that the laser energy is, and it is constantly moved. It is not kept directed at one place. It is constantly moved so that the laser energy is not directed at one place. So these were the settings that were used. ND8 laser was used, 200 micrometer fiber was used. The power setting was 3.75 watt. After every tooth is irradiated for 30 seconds, then we wait for 3 minutes during the, we wait for 3 minutes so that the radicals are generated. And during this time, we stir the gel on each tooth. After that, we aspirate the bleaching gel, carefully remove it with the cotton pellets, and then we rinse the tooth and dry it gently. And this process can be repeated if we find that the desired shade is not obtained. And we should take care that at the most 3 sessions can be done in one sitting, maximum 3 sessions. Otherwise, if we go for more, then the saturation point will be reached and there will be degradation of the enamel matrix. And once the session is done, the bleaching agent is removed. Fluoride gel is applied on the tooth and then irradiated for 15 seconds on each tooth. This is done to avoid the chances of post-operative sensitivity, because this fluoride will resist the acid attacks on the enamel and dentin. And after that, the patient is recalled for 10 days for the next session if it is required. And post-operative instructions are given to the patient, like to avoid too hot or too cold food for at least 3 to 4 days, and avoid tea, coffee, and some beverages, cold beverages which contain colors, coloring agents for at least 4 to 5 days. So we have seen, so here we can see the changes that we have achieved. Initially on lateral, on canine, the shade was A3.5, and after bleaching, it was A2. And on lateral incisor, the shade initially preoperatively was A3, and after bleaching, it is B1. Precautions that to be taken are the patient and the operator both have to wear the laser safety goggles to avoid any damage to the eye. So this is the laser safety goggle. This was another case that was done using laser as the activating source. So we can see how good the results have been obtained. Laser bleaching had significantly less sensitivity as compared to conventional in-office bleaching. And this has been also conveyed in the literature. The microcrystalline nature and the surface topography of the enamel that has been transformed here is not porous. So this is the advantage that we are achieving by using the activation with the lasers. So we have seen that laser can be considered as a novel modality for in vital tooth bleaching. You can't stay in business today with yesterday's thoughts. Strive to learn something new today. Thank you.
Thank you, doctor. Thank you, doctor. Anyone would like to ask a question? All right, let's go ahead and proceed. I would like to check on Dr. Anshul Arora for his presentation. Hi, doctor. You're on mute. Hold on. You're still on mute, doctor. There you go. I cannot hear you. Nothing. No. Is it only me or can you hear him? Anyone? No audio, doctor? Yes, you are not muted on our end, doctor. Can you try to unplug and plug back in your earphone? Still not audible, doctor. I think I'm going to just, yeah, I'll just go back and call you after. I will check on you later, doctor. Right, let's go and proceed to our first presentation of the day for parallel session 1, oral presentation by Dr. Vanita, Vinayaka Missions, Sankaracharya Dental College, India. Topic about biomineralization. Hi, doctor.
Thank you.
Go ahead, please.
Very good afternoon to all. Myself, Dr. Vanita, and my today's topic for presentation is based on biomineralization. Biomineralization is a dynamic, complex, constant mechanism by which living organisms manage precipitation of inorganic nanocrystals within the organic matrices to form unique hybrid biological tissues, for example, enamel, dentin, cementum, and bone. Realizing the mechanism of mineral deposition is crucial for progress of treatments for mineralization associated diseases and also for innovation. So I would like to present my study, which is titled as Evaluation of Demineralizing Potential and Microhardness of 3 different marine skeletal species, that is Rajostrea metracensis, Perna viridis, and Pineus monodon on human tooth enamel, an in vitro study. So oral cavity is a continuous battlefield between the demineralization and remineralization. Dental caries, it's a highly prevalent dental disease, and although in most developed countries, its prevalence has declined, the disease still remains a major public health problem. As you all know, the science of caries process will be, there will be a first molecular changes in the epithet crystals of the tooth, which will lead for a white spot lesion. And if it is not treated on time, it may lead for dentin involvement and cavity formations. So the progression through the stages requires a continuous imbalance between the pathological and protective factors, like dissolution of epithet crystals and net loss of calcium and phosphate and other mineral ions from the tooth surface will lead for demineralization on the surface. So coming to remineralization, Now, remineralization is defined as a process whereby calcium and phosphate ions are supplied from a source external to the tooth to promote ion deposition into the crystal wall, in demineralized enamel to produce net mineral gain. Now, coming to the requirements of these remineralizing agents, they should deliver calcium and phosphate onto the subsurface. They should not deliver any excess of calcium. They should not favor the calculus formations. They should be active in the acidic pH to promote or to stop the demineralizations. And they should be active in the xerostomia patients also. And they should boost the remineralizing properties of saliva. Now, there are many commercially available remineralizing remineralizing agents are available. For example, fluoride-based, calcium phosphate-based, that is crystalline and non-crystalline, amorphous and non-amorphous, bioactive glass and nano hydroxyapatite, etc. But each of these remineralizing agents has some drawback or the other. For example, fluoride overdosage will lead to fluorosis, and fluorides they are mainly effective in the smooth surface caries and less effective on the Pitt and Fisher AR caries. Crystalline amorphous calcium phosphate based remineralizing agents, due to the poor solubility, they are less effective. Stabilized amorphous calcium phosphate based remineralizing agents containing casein, people with allergy for milk based products, it may not be suitable for them to use it. So keeping this in mind, I thought of development of remineralizing agent from naturally available materials, which will be functionally effective as well as economical, especially for to the middle class society. So the marine skeletons are exemplary bioresources which are viable for human tissue repair and regeneration. Marine structures such as seashells, sea urchins, cuttlebone, and coral, enriched with bioactive elements, effectively used for tissue engineering. In medicine, they are used to control the wound healing since it has antimicrobial, anti-inflammatory properties. They are used as calcium oral supplement as well. For orthopedic surgeries, there are studies which have stated that the extract of this marine powder has been used in the form of implants. So they have excellent biocompatible, biodegradable, non-inflammatory and osteogenic property. Since many studies are not there in dentistry pertaining to marine skeletal species, so the aim of this study is to evaluate and compare by energy dispersive X-ray spectroscopy and Vickers micro-hardness testing machine, the remineralizing potential and micro-hardness of enamel surface lesions using 3 different marine skeletal species, that is Meretrix meretrix, Registria madracensis, and Penaeus monodon. So the objectives of the studies is to evaluate the quantum of tooth remineralizations when these 3 different species used as a remineralizing agents and to evaluate among this which one is having highest remineralizing efficiency and to compare the efficiency of atomic ions release and to also evaluate the surface micro-hardness of different marine species, what I've mentioned above. So coming to the materials, the marine skeletal species were collected from the southern western coast of India. 10 freshly extracted third molars, tricalcium phosphate, 2% methyl cellulose agent. And demineralization bath was prepared according to Ivankova, and it was containing calcium chloride, sodium biphosphate, lactic acid, fluoride, and 50% of sodium hydroxide. And coming to the equipments, the used in the studies are Vickers micro-hardness testing machine, energy dispersive X-ray spectrometry, and X-ray fluorescence spectroscopy. Now, demineralization protocol, we had kept the samples in the demineralization bath for 72 hours at 37 degrees centigrade to create subsurface demineralization, simulating an early enamel lesion. So coming to the methodology, the collected marine skeletal species were purified by removing the impurities present on the surface by dipping in the sulfuric acid. And then these shells were underwent undergone calcination process, and the extract of marine shells obtained from this process was analyzed by X-ray fluorescence spectroscopy for elemental composition percentage by weight. So this is the powder extract obtained after the calcination process, and production of the shell paste by using 1:2% by weight, that is shell powder, and 2% methyl cellulose agent and 4% acetic acid solution, and pH was tested using pH meter. Now the sample preparations, coming to the sample preparations, here the 10 freshly extracted unerupted third molars were collected, and they were decoronated at cemento-enamel junction, and they were sectioned longitudinally in a mesodistal and buccolingual direction, such that 4 enamel blocks from each tooth could obtain. This is the methodology. And then these samples, enamel samples were embedded in the acrylic blocks. This study included 40 samples, and they were uniformly divided into 10 samples in each group. That is, group 1 was shrimp extract, group 2 was a cockle extract, group 3 was oyster extract, and group 4 was a control. So these samples, after embedding in the acrylic resin, were immersed in the demineralization bath for 72 hours, and then they were washed with the distilled water and applied with the marine shell paste for 2 minutes, and then distilled, and then washed with distilled water, and then pH cycling model was adopted to simulate the changes occurring in the oral cavity. That is, after applying, again we will keep in the demineralization solution for 3 hours, and then again wash with distilled water, and then apply the marine shell paste and keep in the artificial saliva for next 18 hours. This was done until 30 days, and every the marine shell and the demineralization solution and artificial saliva was prepared freshly once in 24 hours. So the samples were evaluated for surface microhardness by Vikas microhardness testing, and atomic analysis was done by energy dispersive X-ray spectrometry. And this is the results for EDX showing the shrimp shell showing the highest atomic release and demineralization, followed by cockle, oyster, and least by the control group. And this is the microhardness test. The results showing the microhardness values were highest for the shrimp, followed by the oyster, cockle, and the control group. Now, the statistical analysis was done by one-way ANOVA and Turkey test. And the hypothesis, the null hypothesis, stated that there is no difference in the demineralizing potential and microhardness of 3 marine skeletal species, that is Casistria, Meltrix, and Phineas, on human tooth enamel. Whereas alternate hypothesis stated that the effect of remineralizing potential and microhardness of 3 marine skeletal species are different and better than the commercially available calcium phosphate-based agents. Now, coming to the discussion part. So calcium plays an active role in the remineralizing procedure or a process. So our chemical analysis of marine shell extract using X-ray fluorescence spectroscopy revealed that it contained contain means like a shrimp exhibited 98% of calcium, oyster 94%, and cockle showed 92% of calcium content present in that. So the Cleanthrow tooth cream, as claimed by the manufacturers, they say that it has better remineralizing effect in the surface and subsurface lesions. Among the groups in the study, the shrimp shell exhibited the highest remineralizing and surface microhardness comparatively to cockle, oyster, and the control group. The pH of the shrimp shell paste was 11.7, and increased pH showed increased ion action of anions such as calcium, such as phosphate and hydroxyl ions, which benefited in the remineralizing process. So I would conclude by saying that increased pH along with the rich bioavailable calcium concentration can be a potential for undergoing process. So coming to the outcome of the study is to broaden the scientific research knowledge on finding alternative natural remineralizing agents to the commercially available remineralizing powder and a paste. And these natural alternatives can also be an economical substitute to the commercially available counterparts. This is the reference. Thank you.
Thank you so much, Doctor.
Thank you.
Anyone would like to ask a question or feedback? All right, let's proceed. Next presentation, an oral presentation by Dr. Guna Madhuri, FODS, KGMU, India. The topic, a novel approach for the management of large periapical lesion case report. Please proceed.
Hello, can you hear me?
Yes, I can hear you. Go ahead, please.
Good evening, one and all. My presentation is on a novel approach for the management of large periapical lesion. So we all know that the primary objective of endodontic treatment is to prevent and intercept pulpal or periradicular pathosis and to preserve the natural dentition when affected by the pathosis. So the most common possible causes of failure in the endodontic treatment was due to leakage around the canal filling that accounts 30.4%, missed canal that account to 19.7%, underfilling accounts for 14.2%, and anatomical complexity accounts for 8.7%, and overfilling accounts for about 3%. So according to the updated guidelines by the European Society of Endodontology, the indications for apical surgery includes the radiological findings of apical periodontitis and or symptoms associated with an obstructed canal, extruded material with clinical or radiological findings of apical periodontitis and or symptoms continuing over a prolonged period, persisting or emerging disease following root canal treatment when RCT is inappropriate, perforation of the root or the floor of the pulp chamber and when it is impossible to treat from within the pulpal cavity. So coming to the case presentation, a 12-year-old female patient reported to the Department of Pediatric and Preventive Dentistry, FODS KGM Lucknow, with the chief complaint of pain and swelling with respect to upper front tooth region since past 3 months. No relevant medical history was recorded. On examination, there was a history of trauma to upper front teeth 9 months back, following which she got treatment from a dentist in the locality. So here you can see the clinical photograph. On clinical examination, we found both 1-1 and 1-2 were discolored with grade 1 mobility and were tender on percussion. And the probing depth of 7 mm was noted in relation to 1-2. And you can see the radiograph. The 1-1 and 1-2, it has a very larger periapical lesion in relation to 1-1 and 1-2. And you can note the teeth is already endodontically treated. So to relieve the pain, we reopened the canal and removed the GP cones to establish the drainage. And then the patient was sent for CBCT for further evaluation about the extent of the lesion. So as you can see in sagittal section and axial section, you can see the lesion is almost perforating the labial cortical plate. And this is the coronal section where you can see the size of the lesion is almost 9.2 into 12.7 mm. So considering the size and the extent of the lesion, the periodontal status of the teeth, and as it is already endodontically treated, we plan to do re-endo treatment with episectomy along with the periodontal regenerative surgery. So the surgical procedure was explained to the parents and the written consent form was obtained. And then the bilateral infraorbital nerve block along with the nasopalatal nerve block was given using 2% lignocaine with adrenaline. And as you can see in the diagram, the horizontal incision along the gingival sulcus from the left central incisor to the right canine was given, and 2 oblique vertical releasing incision extending into the labial vestibule was given. So full thickness flap was raised and the bony defect was exposed. There was empty cavity with the friable bone around. The window was extended to expose the apex of the central incisor, and an apical 3 mm of the root was resected and the cavity was thoroughly debrided. So during the surgical procedure, the PRF was prepared. A 10 ml of blood was withdrawn from the patient and collected in a 5 ml sterile glass tube without any anticoagulant, which was immediately centrifuged at a rate of 3000 RPM for about 10 minutes. So here in this case, we have blended the PRF with bone graft material and the mixture was placed into the defect. And along with that, GTR, that is bioresorbable membrane, was used over that in order to prevent the formation of the long junction epithelium and to increase the periodontal regeneration. So the flap was approximated to its position and interpreted sutures were given using 4O black silk suture. And as you can see, the immediate post-operative radiograph where there is increased radio opacity. This is the pre-operative and post-operative, immediate post-operative radiograph where you can compare with increased radio opacity. So after 7 days, the patient was recalled for the suture removal. After the suture removal, apical seal was achieved by orthograde filling of MTA in both 1-1 and 1-2. And after 48 hours, observation of the canal was done. And then patient was recalled on 3rd and 6th month for follow-up. You can see the clear increase in the radio opacity and formation of the bone at the periapical area. And there are no clinical signs of any abscess formation, and the probing depth was noted around 3 mm. So uniqueness of this case is the bone graft is used along with the PRF and the GTR membrane have showed reduced radiolucency in immediate post-op radiograph, and there was sustained increase in the radio opacity in the operated area, indicating the regeneration of the bone. It also helped in the enhanced healing. So coming to the conclusion, preserving the natural tooth is the main goal in clinical dentistry, and the revolutions in regenerative and biomaterials made this possible to the clinicians. We attempted to evaluate the clinical effectiveness of the combination of the PRF along with the hydroxyapatite bone graft material together with the GTR membrane. The use of autologous preparations like PRF allows the clinician to enhance the tissue remodeling, improves the wound healing and angiogenesis by the local delivery of growth factors and proteins.
Thank you.
Thank you, ma'am, for the presentation.
Anyone wants to ask a question?
Yes, ma'am.
Go ahead, please.
Yeah, very nice presentation, ma'am. I would just like to ask, like, what is the like, is there any specific reason you have gone for obturation after you have done the surgery? Because conventionally, we generally go it for before the surgery.
Yes. Yes, ma'am.
Yeah.
Actually, after resection of the root, we need to prepare the root and preparation. And for that, there are two ways actually, the conventional and by using ultrasonic tips. But as we don't have an ultrasonic tips, I have gone to the, after 7 days, I have done the orthograde filling with MTA.
Okay, thank you.
All right, thank you so much. All right, before we proceed, I would like to check on Dr. Anshul Arora. Sir? No audio. How about on your phone? Presentation on the laptop and the audio on your phone. Can't? Okay. For now, we'll go ahead and proceed. Next, an oral presentations by Dr. Akshita Rathi, VYWS Dental College and Hospital, Amravati, India. Topic about air disinfection procedures in dental office during COVID-19 pandemic. Hi, madam.
Good afternoon.
Good afternoon. Yep, I can see your screen.
A very
Please
good
proceed.
afternoon. Okay. A very good afternoon to all the respected panel members present here. Today, I'm presenting a paper on a topic which we are dealing in our day-to-day practice as air disinfection management during COVID-19 crisis in dental office. As we all know, we are dealing and suffering from this COVID-19 pandemic since 1.5 years. that is COVID-19 has generated a huge pressure on healthcare system worldwide and exposed their lack of preparation for a major health crisis. The outbreak of COVID-19 has affected health and economics worldwide. In the time of respiratory disease pandemic, members of dental profession becoming infected with severe acute respiratory syndrome, coronavirus, that is SARS-CoV-2, because dentists and dental professions are in coming contact with the patient's oral fluids, body fluids, and aerosol generating products. The aim of this paper is to collect and analyze information regarding air disinfection procedure, which could potentially be utilized in dental setting during the COVID-19 pandemic. Methods: a thorough search strategy was done. A PubMed search literature, SkyHub, Scopus, Medline, and Google Scholar search strategy was done. The keywords that were used were air disinfection, COVID-19, aerosols, dental office, COVID-19 in dental office, and their management were the keywords that were used with the mesh words and or. Mode of transmission of COVID-19, direct contact from the infected person to the another person, airborne transmission from the aerosol generating products in dental office, indirect contact through the infected person who is symptomatic or asymptomatic through the indirect contact through the doors, the keys of the hole, the handle of the doors, the switches, electric switches, tap, wash basin taps, laboratory equipments, etc. It also transmits through droplets. There are 3 types of droplets: large droplets, small droplets, and droplet nuclei. From infected person, it can directly or indirectly can contact to the susceptible person. Effect of aerosols: it causes respiratory diseases such as asthma, bronchitis, tuberculosis, pulmonary diseases such as pulmonary emphysema, pneumonia, etc., and skin diseases such as urticaria, herpes, skin rashes, etc. Risk of COVID-19 in dental office: dentistry is based on aerosol generating products like use of dental handpieces, ultrasonic scalers, air abrasion, air polishing, and air brushing devices, or 3-way syringe tool, which we use in our day-to-day practice in our dental clinics. To minimize the risk of COVID-19 during this pandemic, the following interventions should be done. To prevent the contamination of aerosols in the mouth, chlorhexidine mouthwash should be done, and ask the patient to have chlorhexidine mouthwash rinse before entering in the dental operatory. Also, we should have high efficiency particulate air, that is HEPA filters, in our dental clinics, and also to prevent contamination aerosols from escaping the mouth, rubber dam isolation and high volume evacuation system (HV system) should be installed in our dental clinics. Prevent contamination of aerosols in the mouth. All patients should be asked to have chlorhexidine mouthwash rinse 0.2% or 1.2%, as inactivated more than 99.9% of COVID virus with minimal contact of 30 to 60 seconds. Another option, that is prevent contaminated aerosols from escaping into the mouth, and it effectively reduce the spatter by 33% and reduce surface contamination with bacteria with 80 to 90% at a distance up to 1 meter. Before rubber dam isolation and excess cavity, patients should be requested to use 0.12 or 0.2% of chlorhexidine digluconate antiseptic rinse for 60 seconds. After that, the excess cavity should be performed under rubber dam isolation with high-speed handpiece with water spray, and extraoral suctions should be used immediately in the patient's mouth. HV system has shown 90.8% reduction of aerosols in a very short period of time. Ventilation and air conditioning of the dental office is very essential. Dental office should have adequate ventilation to remove infected air from the room and replace it with the fresh air. While admitting a patient who is not suspected of being infected with COVID-19, the standard ventilation rate is more than 1.5 air change per hour. Both during and after the visit should be provided to the. While admitting a patient who is suspected of being infected, the standard ventilation rate is more than 2.5 air change per hour. Both during and after the visit should be provided. And in our dental clinics, we should regularly have the air ventilation rate of more than 2.5 air change per hour, as we should think that every patient who are coming to our dental clinics is suspected of COVID-19 only. Many dental clinics have air conditioning systems. Poorly maintained ventilation and air conditioning system can be a potential source for fungal, bacterial, viral, and other microbial infections. Air conditioning procedures is very essential in our day-to-day practice. It is also essential to establish a routine of opening of the windows and exchanging the air between the patients and after the working hours of the dental office. Identifying the clinical air and determining the air exchange per hour is very essential. Increase filtration efficiency to the highest level compatible with the high ventilation air conditioning system, that is HIVEC system, should be used in the dental clinics. Ability to safely increase the percentage of outdoor air supplied through the HIVEC system is essential. Last but not the least, leave the fan running, including all exhaust fan during working hours and when feasible, up to 2 hours after the end of the working day is very essential in the dental clinics. Disinfection by fogging. Foggers are also used for disinfection. Many solutions have been used for fogging, such as aldehyde solutions, for hypochlorite solutions, and silver nitrate solutions. The aqueous form is converted into vapor or mist form for fogging. High pressure atomizing humidifiers are also used. HEPA filters. Portable room air cleaners with HEPA filters may provide added protection for indoor occupants. A regular maintenance schedule and use of appropriate personal protective equipment, that is PPEs, is very essential while changing the filters. Some HEPA filters have limited capacity less than 1,000 cubic feet. The use may negatively affect the performance of existing HIVEC system also. Ultraviolet light, a type of ultraviolet light with wavelength between 200 to 280 nanometer called UVC, is another option for air disinfection procedure. Light in the UVC wavelength can be used for water and surface disinfection as well as for air purification. Disadvantage include personnel cannot remain in the room when UVC light is being used. UVC installed in ductwork keeps the ducts and coils clean, but when airstream velocity is high, the air passes through too quickly and can be adequately treated. Ozone generators is the other procedure can be used for air disinfection. Ozone therapy has been used in both medical and dental fraternities since 18th century. Ozone can be easily produced from oxygen or air. It decomposes with the formation of oxygen, thus leaving no harmful byproducts. It has the ability to easily penetrate in all areas of room, furniture, and other objects, which is significant advantage of ozone generators. The construction of ozone generators include humidifiers and sensors that control the level of humidity and ozone concentration. They provide the possibility to set the concentration of generated ozone and the working time of the device. The optimal virucidal effect is obtained by increasing the ozone concentration to 25 ppm for 15 minutes, 30 to 35 ppm for 10 minutes, and maintaining this concentration for 10 minutes and increasing the relative humidity to 95% and leaving it additional for 5 minutes is very essential. Another is the photocatalytic disinfection. This is the newer one for air disinfection. The titanium dioxide-based photocatalyst has a great potential for inactivating pathogens. The titanium dioxide disinfection property is primarily attributed to surface production of reactive oxygen species as well as the formation of free metal ions. The surface coating with a thin layer of titanium dioxide nanoparticles can also be utilized in the dental setting where UV radiation is often used for surface disinfection nowadays. So coming on to the conclusion, dental professionals are predisposed to exposure to COVID-19 and many other infectious diseases due to aerosol generating procedures. The key strategy to ensure occupational safety during the current pandemic include frequent air change with mechanical ventilation, chlorhexidine mouth rinse before patient is entering in the dental clinic, rubber dam isolation, using of HIVEC system, HEPA filters, ozone generators, proper fogging, and also use of photocatalytic disinfection. Repeated disinfection of air conditioning system in dental office is very essential in our day-to-day practice. These are my references. Thank you. So the take-home message from this topic is whether we are dealing or not dealing with this current pandemic, we should have a proper air ventilation in our dental clinics for proper air disinfection procedure as the aerosol can also cause another diseases. So we should take care of the proper air disinfection protocol should be followed in each and every dental clinics. Thank you.
Thank you so much for that presentation. Anyone would like to ask a question? All right. Let's proceed with our next presenter, oral presentation by Twinkle Sharma, Subharti Dental College in...
Excuse me, ma'am.
Yep.
This is Dr. Jasuma. My timing was 2:10. Is it time for me to give my presentation? Mine is the 5th topic for day 1 in perio. Mine is session 3, periodontics and community dentistry.
Oh, you're on the breakout room. One moment, please. Team, can you please move Dr. Jasuma Rai to the periodontics? Your periodontics in community dentistry, right?
Periodontist, yes.
Can you please move Dr. Jasuma Rai to periodontics? Thank you. Please wait for that. Most probably they're waiting for you on the breakout room. One moment, please. Just wait for it, Dr. Rai. And let's proceed. Again, the oral presentation by Twinkle Sharma. Twinkle?
Yes, ma'am.
Hi. Yeah, go ahead, please.
Good afternoon to the esteemed judges, participants, and all the viewers present here. MS Swaminathan rightly said, if the conservation of what is natural goes wrong, nothing else will go right. With this note, I, Twinkle Sharma, and my fellow batchmate Ritika Singh would like to introduce our topic, minimally invasive endodontics, preserving what's natural. The endodontic concept emphasizes perpetual preservation of what remains rather than meticulous restoration of what is missing, which is achieved by the shift of endodontics from extension for prevention to the minimal invasion with the systematic respect of original tissue. Our goals are preservation and maintaining physiological and defensive functions and lesser removal of hard tissues, which preserves structural integrity of the tooth during the endodontic procedures. These can be achieved through minimal invasive approach, which includes correct diagnosis and decision making, minimal but decisively crafted access openings depending on anatomical challenges during access opening, minimal removal of dentine, guided endodontic access, modern bud designs, cleaning and shaping of the root canal to retain as much sound dentine as possible, 3D irrigation and disinfection, root strengthening and magnification aids like loupes and surgical operative microscope. Now let us discuss these and how to achieve them one by one. The invention of newer diagnostic instruments and materials stimulates a paradigm shift in current treatment protocols. The recent clinical research on vital pulp therapy now provides options for developing new biologically driven treatment protocols. These treatment modalities help in pulp tissue preservation, thus maintains its physiological and defensive functions, and also removes less hard tissue with less weakening of tooth. D.H. Lawrence quoted, "What the eye doesn't see, the mind doesn't know. Doesn't even exist if it does. Magnification magnifies the look in endodontics to the extent that no one sees it clearer, which has made possible to look through difficulties of root canal treatment. RCT is no longer a blind procedure with aids like loupes and surgical microscopes. The remaining structural integrity of the tooth is an important factor that determines prognosis as it relates to the post-endodontic survival rate of the tooth. Maintenance of strength and stiffness that resists structural deformation becomes the goal of all restorative procedures, mainly in endodontics, which can be achieved by preservation of pericervical dentine, 3D ferrule, and 3D soffit.
Significant amount of dentine was sacrificed in traditional access preparation to facilitate safe instrumentation. Now, there is a shift of access outline design from traditional operator centric to a dentine preservation and endodontic restorative interface centric one. Current access design include conservative endodontic access cavity, ninja endodontic access cavity, orifice directed dentine conservation access cavity, incisal access cavity, color lily enamel preparation, image guided endodontic accesses. Dynamic guidance was first introduced in endodontics by Dr. Charles M. It uses information from the patient's CBCT volume to plan an access cavity. Overhead tracking cameras relate the position of the patient's jaw and the clinician's birth in three-dimensional space. The clinician, by looking at the software interface, gets immediate feedback about the position of the burr as it relates to the position of the planned access and the tooth. Currently, clinicians advocate smaller apical preparations and continuous taper that promotes resistance from a tight apical seal and a conservative approach to creating sufficient shape for adequate disinfection, preserving root dentine. As as no apical preparation render a bacteria-free terminus structural consideration, and newer instrument designs come into play during cleaning and shaping, like Endo-E Stylos anatomic endodontic technology and XP Endophiles AT and SAP system. Activated irrigation is a potentially important method to counteract problems such as apical pepper lock, with an aim of chemically and mechanically activating irrigants to improve their antimicrobial and tissue dissolving efficacy, and to enhance their penetration into the complex root canal anatomy by displacing air bubbles with the help of sonic and ultrasonic activators, photon-induced photoacoustic streaming, and gentle wave system. Collaborative research has shown that these disinfection methods can 3D clean a canal, the lateral anatomy, and the related dentinal tubules. Biomimetics invariably involves the preservation and conservation of tooth structure, which maintains the balance between the biological, mechanical, adhesive, functional, and aesthetic parameters. Preservation of coronal tissues and avoidance of invasive endodontic procedures maintains the biomechanical balance and aids in the long-term performance of the restored tooth. Thank you.
Hello.
Thank you so much.
Yeah, ma'am.
Yep.
Can you please tell which rotary instruments would you prefer for minimally invasive endodontics?
And self-adjusting files, XP endo files, AET systems.
What is AET system? Okay, thank you so much. Thank you so much.
Thank you so much, Doctor. Right, let's proceed with.
Excuse me, ma'am. Ma'am, I have to join the oral medicine link, but I think
The what again? Oral medicine.
Yeah.
All right. Team, can you please move Dr. Apiksha Dolly to oral medicine? Hold on. I think she's moved. All right, let's proceed. Let me go ahead and call on oral presentation by Kumal Kumari. Hi, I can see you there. Swami Vivekanand Subharti University, India. All right, the topic is teledentistry, the scope of technology. Hi, good afternoon. There you go.
Good afternoon, everyone. Today I am going to present my e-poster on the topic teledentistry, scope of technology. For better understand about teledentistry, first we have to know about word telecommunication. Tele is a Greek word meaning distance and communication is a Latin word meaning social process of information exchange. Transmission of information by various types of technology over wire, radio, optical or other electromagnetic systems. And teledentistry is a combination of telecommunication and dentistry involving the exchange of clinical information and images over remote distances for dental consultation and treatment planning. Teleconsultation through teledentistry can take place in either of the following ways, like real-time consultation, store and forward, remote monitoring, and through mobile dental application. And the real-time consultation involves a live two-way interaction by video conferencing in which dental professionals and their patient at different locations may see, hear, and communicate with one another. Store and forward method involves the exchange of clinical information and static images which are later reviewed by the dental practitioner. The services and mechanism of teledentistry can be broadly classified in three groups, which are network programs, point-to-point connection, and specialty care to home connection. The network program includes connection between the dentist at the remote location available at the PHC and dental specialists at dental hospitals or lab far off. Communication can be done with the help of live video conferencing, clinical photographs, or radiographs. Oral health is a lifelong commitment, but for certain class of patients like elderly living in remote areas, those who do not have devices to access like mobile phones may find it challenging to get a dental consultation. For such class of people, ambulatory services like mobile dental van was launched. The last service is through the means of healthcare midwifery, staying with the patient and establishing contacts with the professionals when it's needed. There can be numerous applications of teledentistry. You can educate the patient such as demonstration of brushing techniques, provide teleconsultation, you can prescribe medicines, but there are certain guidelines to follow for teleprescription. Take opinion from other dental specialists, can reduce follow-up visits, and can also enhance your lab communication by providing images rather than just a selected set number. Teledentistry offers various advantages. First is better accessibility, especially for particular groups of patients like elderly and medically compromised, anxious children, and for emergency screening of the patient who are unable to visit the dentist immediately. And it also helps in reducing the waiting period of the patient. It proves convenient for both the patient and the dentist. It helps to build an emotional trust of the patient towards the dentist. It is cost effective as the various clinical expenditures such as PPEs, sterilization of the instrument, etc. is cut down. And lastly, it provides for a multidisciplinary approach. It will become more widespread, barrier will get lower, quality will improve, and increase efficiency and decrease cost. There are certain limitations like teledentistry may only be useful in preventive and diagnostic procedures. Poor internet connection affects good teleconferencing, and if any misdiagnosis or medical error occurs due to technical problems during data transmission, issues of responsibility and malpractice needs to be considered. Privacy and security are important issues in cyberspace. Thank you.
Thank you. Anyone would like to ask a question? All right, thank you so much. And let me go ahead and call on the next presenter. By the way, before I proceed, I would like to remind all the remaining presenters that you are allotted to 10 minutes for the whole presentation, including catering of questions. Thank you so much for us to stay on schedule. All right, then next, let me call on oral presentation by Isha Varshni. Subharti Dental College, India. The topic is about graphene, a future promising biomaterial in endodontics and restorative dentistry.
Yes, ma'am.
Hi. Hi, good
Hello.
afternoon, madam.
Good
Doctor,
afternoon.
go ahead, please.
Yes, please. Hold on a second, please. Hello. Yeah. Is my screen visible?
Yes, it is. Please proceed.
Yeah. Yeah. Good afternoon, everyone. My topic of paper presentation is graphene, a future promising biomaterial in endodontics and restorative dentistry, a review which was published by Bansode PV et al. In the Journal of Dental and Medical Sciences in year 2020. Since we are discussing advancements in dental technology today, let's talk about a material which has already been there from so long. Uh, we all have heard about graphite, which is present in a pencil lead. It is one of the three naturally occurring allotropes of carbon and has special characteristics of being an excellent conductor of electricity. Sorry. Special characteristics of being an excellent conductor of electricity and heat, which can withstand high temperature and is chemically inert. And that is why it has been used for a wide range of applications like pencil, batteries, and nuclear reactors. But it cannot be used as a structural material on its own because of its shear planes. And therefore, another two-planar allotrope was discovered, that was graphene, which is lighter than paper. It is the strongest material ever found, and it is the best conductor of heat and electricity. It was invented by Professor Abdurrahman and Cuesta Novoselov in year 2004, and they also got the Nobel Prize for the same in 2010. And since then, research efforts have been focused on excavating its potential applications, including various biomedical applications such as drug delivery carriers, imaging agents, biosensors, biomolecular analysis. But what makes this graphene a wonder material? Let's know why. First property is its excellent biocompatibility. But main concern in using any graphene-based nanomaterial for biomedical application is their biocompatibility. So our literature suggests that effect of graphene nanomaterials on cell viability depends on various factors like size, dose, shape, number of layers, method of synthesis, purity, etc. And to support this, an article was also published on biocompatibility of graphene oxide, which suggested that dose of more than 50 microgram per milliliter exhibits cytotoxicity, such as decreasing cell adhesion, including cell apoptosis, entering into lysosomes, mitochondria, endoplasm, and cell nucleus. Next is antibacterial effect. There are three mechanisms of antibacterial effect of graphene. First is chemical effect, which is primarily due to oxidative stress mediated with production of reactive oxygen species, which ultimately leads to gradual disintegration of cell membrane and eventually cell death. Then physical damage is induced by blade-like graphene materials piercing through cell membrane, which also eventually leads to cell death. And another theory of its mechanism is that its antibacterial activity on metal substrate involves electron transfer from membrane, which leads to cell death. To support this, an article was published on electron transfer directed antibacterial properties of graphene oxide on metals, which concluded that at graphene oxide concentration of 40 microgram per milliliter, bacterial growth of Porphyromonas gingivalis and Fusobacterium nucleatum were inhibited, while at concentration of 80 microgram per milliliter, graphene oxide absolutely killed all the Streptococcus mutans microbes. Now, coming to its applications. In restorative dentistry, it incorporates graphene derived nanomaterial into commercially available glass ionomers for reinforcements. And also, fluoride graphene, when mechanically blended with the glass ionomers, they also could produce a GICs or a fluoride graphene composite matrix, which could significantly enhance the mechanical and antibacterial properties of glass ionomers. In endodontics, one of the material that plays a key role in disinfection is non-toxic photosensor, such as indocyanine green. But its limitations, like we all know, poor stability and concentration-dependent aggregation, it also cannot be ignored. And that is why modifying indocyanine green with graphene oxide not only significantly reduced number of E. faecalis in the canals and Streptococcus mutans, but they also improved the stability and bioavailability of indocyanine green, preventing its degradation and aggregation. So finally, to conclude, graphene and its derivatives are versatile materials that present unique characteristics such as large surface area, high mechanical properties, and can be transferred into different substrates to enhance their properties. As they can be functionalized and combined with several biomolecules and biomaterials, this material has great potential to design biocomposite with improved physicochemical and mechanical properties to confer to existing biomaterials, enhanced bioactivity, and new capabilities, providing new hope in the field of dentistry. Thank you.
Thank you so much. Anyone have a question?
Yeah, ma'am.
Yes, ma'am.
Is there any studies have been done to that we can like that it is being used with GIC and whether it has got enhanced antibacterial properties?
Actually, ma'am, some studies has been conducted, but they all were in vitro. Very less in vivo studies has been conducted in relation to graphene, and that's where we are lacking. We need to conduct some studies in vivo also.
Okay. Thank you.
Yes, ma'am.
Thank you so much. And
Thank
let's
you.
proceed. Oral presentation by Dr. Sumed Shelki, VYWS Dental College and Hospital Amravati, India. Magnification in endodontics. Please proceed.
Hello, ma'am. Am I audible?
Yes, you are, and I can see your screen.
Okay. Good afternoon, everyone. Respected judges. Today I'm presenting topic on magnification in endodontics. Introduction. Envision of surgical and conventional endodontic treatment has historically been limited to two-dimension of intraoral periapical radiograph that is representative of three-dimensional system. Finding the good access is the basics in endodontics. For this, better illumination and magnification is required. Magnification. What is magnification? Magnification is the process of enlarging something only in appearance, not in physical size. This enlargement is quantified by a process of magnification. A magnifying glass uses a convex lens to make things to look bigger by allowing the user to hold them close to the eye. The integration of optical magnification instruments such as loupes, microscopes, endoscopes, etc. facilitate the endodontist to magnify specific field of treatment of interest beyond that of the naked eyes. History. In 1978, Dr. Apotheker and Dr. Jacko introduced the concept of extreme magnification in the form of operating microscope into the dentistry. In 1999, a dental operating microscope was introduced by Gary Kerr that had Galilean optics and that was ergonomically configured for dentistry with several benefits that permitted easy use of the scope for nearly all endodontic and restorative procedure. Methodology. The literature search has been carried out by using PubMed database. The keywords applied were visuals, endodontic lenses, magnification, optics, etc. As a result, a total of 732 articles were found. The title and the abstract of each article were then screened and only the relevant papers were retrieved in a full text. Then breakdown of relevant articles according to the type of magnification device, the number of mesh keywords result. The articles pertaining to loupes were 20. Then articles pertaining to operating microscope were 47. Then articles pertaining to loupes and operating microscope 22. Articles pertaining to magnification in general 10. Then articles pertaining to the others were 10. Total number of relevant articles reviewed 90. Types of magnification devices. There are 4 types. That is, first is dental loupes, dental operating microscope, oroscope, and endoscope. Dental loops, magnifying loops were invented to direct the problem of proximity, decrease depth of the field, and eye strain occasioned by moving closer to the subject. Normal range of loop magnification in dentistry is 2x to 6x. If magnification is beyond 5x, loops tend to become heavy and microscope would be better option. Loops are classified as follows: single lens loops, Galilean lens loops, Keplerian loops, then flip-up loops, then through the lens loops. Advantages of loops: it does not acquire much space as it's small in size. No formal training is required as it can be easily operated. Surgeon position is not restricted. Neither are they expensive as microscope is not. Do they need higher maintenance? Disadvantage of loops: it does not provide depth perception due to lack of stereoscopic view. With loops, magnification beyond 5x is uncomfortable on nose or head due to their large size and increased weight. For higher magnification, microscope should be considered. Head movement makes image unstable. Then illumination is less in comparison to microscope. Uses of loops. There are several uses. Those are diagnosing caries and minute crack. Then conservative access opening. It is used in retrieving silver points, separated instrument and fracture post. Then confirming canal cleanliness prior to obturation. Outlining and removing pulp stone, managing perforation and tooth resorption. The second device was dental operating microscope. The operating microscope greatly enhance clinician ability to view the thinnest detail inside a patient tooth. The dental microscope is useful in both diagnosis and treatment. The microscope not only provide better magnification for from 3x to 30x, but also better illumination. The introduction of microscope include numerous ergonomic changes, that is body position changes, then possible reduction in consequent stresses for the operator can be ensured by maintaining the traditional working position previously used without the microscope by the clinician. The range of working position is usually from the 9 o'clock to the 12 o'clock position. Advantage of dental operating microscope are: it increases visualization and hence improve the quality of precision of treatment, then enhanced ergonomics, then easy of proper digital documentation, then it contain integrated video which makes the communication skill better. Disadvantage of dental operating microscope: it is expensive, it is difficult to fit in a small operation because of its size. It takes the operator some time to get used to the equipment. It provides narrower field of vision. Oroscope. This third device is oroscope, is fiber optic endoscope, which is made up of plastic and therefore they are small, lightweighted and flexible. It has 0.8 mm tip diameter, 0 degree lenses and working portion that is 15 mm in length, and it is used for intracanal visualization. Fourth was endoscope. The term endoscopy is of Greek origin and is literally translated to endon. Endon means within and scopion to see, thus meaning to see within. With the advent of dental endoscope, the field of endoscopy has expanded further. The traditional endoscope used in medical procedure consists of rigid glass rods. It can be used in apical surgery as well as non-surgical endodontics. The recommendation for surgical endodontic visualization is a 2.7 mm lens diameter, a 70-degree angulation and 3 cm long rod lens, and for non-surgical visualization through an occlusal access opening, a 4 mm lens diameter, a 30-degree angulation and 4 cm long rod lens are recommended. Then uses of magnification in endodontic. Magnification used for diagnosis, non-surgical endodontics, role of magnification in surgical endodontics. The microscope has contributed to improve surgical treatment through the enhanced vision. The introduction of the operating microscope and the ultrasonic instrument has taken to endodontic surgery to another level of sophistication, that is the microsurgical approach. The fourth is best cosmetic outcome and tissue conservation by use of thinnest suture, threads, and flaps designed like to the papilla, base incision, which is otherwise never possible under the naked eyes. Summary for this, my topic is, nowadays, in order to progress in a quality of treatment, the endodontist has been seeking support for new technology to achieve success. However, Choosing the purchasing magnifying device involves a great number of issues, including adequacy of one present vision, the type of practice conducted, the demands one place on the quality of his or her dentistry, and the amount of time and expenses one wishes to devote becoming competent in using magnification. Thank you. Those are my references.
Thank you so much. Anyone would like to ask a question?
Yes, sir. Can you please quote some study where we can know how magnification is better than the naked eye, or which type of magnification is better?
Ma'am, operating microscope is better for magnification, and there are Mohammed et al. Studies, that is Indian studies, and then that's it.
Like how it is better as compared to?
Ma'am, because in operating microscope, we can magnify 30x up to the 30x, and it gives magnification as well as illumination, because it provide the light sources also in operating microscope. That's why it is better than loupes.
Oh, thank you.
Thank you so much. Let me go ahead. Let's proceed. Our next presenter, an oral presentation by Safia Sheikh.
Hello, ma'am. Can you hear me?
Yes, I can hear you.
Excuse me,
Pacific
ma'am.
University, India. Topic is guided endodontics. Go
Excuse
ahead.
me, ma'am. Can you give me a link to oral medicine? Dr. Apeksha Dulu.
Oh, sure. Team, can you please move Dr. Apeksha Dolly to oral medicine?
Yes, ma'am.
Okay.
Hello, everyone out there. Today, my topic, I'm going to speak on guided endodontics. It's a nice continuation of Dr. Sumed. In his last slide only, he has said that new technologies have been evolving. So even my topic is something where there has been, if the endodontist gets stuck in some of their difficult situations, they can resort to digital technology. So myself, I'm Dr. Safia Shoaib. I'm a professor in Qasim University, and at the same time, I'm a PhD scholar in Pacific University. This presentation I've done under the guidance of Dr. Prashant Nehar. He's my guide. Let us go to the introduction. Now, endodontics, as we all know, the heart and soul of endodontics is the root canal treatment. The major objective of root canal treatment is to treat and prevent apical periodontitis by properly shaping, disinfection, and obturation of the root canal. So the first step in the root canal treatment is to prepare a cavity to access the root canals. The second step is disinfection and debridement of the root canal, and a straight line access to the root canals aids in accomplishing this step. Now, very often you do not find the root canals which are very good and very ideal in structure and form. Many times what happens is pulp canal obliteration occurs due to caries, maybe because of trauma, because of orthodontic treatment, some operative procedures like pulpotomy, pulp capping, and many a times in elderly patients also you can see such pulp canal obliterations. What happens in such situations? The treatment becomes more challenging. Why challenging? Because you have to gain access to the canal orifice, and this becomes difficult. It can be easy and it can become difficult. When it becomes difficult, naturally when it becomes cumbersome and when you start searching for the canal, there is a loss of tooth structure. And as we all know, the more loss of the tooth structure, it can lead to higher risk of fracture and higher failure rate. On the other hand, the another procedure which is done is the periapical surgeries. So accessing the apical third root during periapical surgeries without damaging the surrounding structures also needs precision. In these situations, how preoperative planning is usually recommended, And 3D imaging with cone beam computed tomography, that is CBCT, is a useful tool. CBCT is widely used in oral implantology in general and specifically in guided implant placement. So accordingly with this, the concept of guided endodontics was introduced, in which the computer designed guides are used for access cavity preparation. They can be used for endodontic surgery also, and also for the removal of root post. Now, this novel concept has helped the clinicians not only in preserving the tooth structure, but also avoiding the complications, and hence both of these lead to the good prognosis. Coming to the aim of my paper, the first is I'm going to elaborate the protocol for preparation of endodontic guides. Second, describe the clinical applications of guided endodontics. Then we will look into the accuracy of guided endodontic treatment. And in the end, what are the limitations of it. Now in the protocol, the first step is we have to obtain a CBCT scan of the patient. Now this scan, usually in endodontics, it is better to take a scan with a smaller voxel size and a limited scan we have to take it. Better not to go for a full scan of the patient so as to prevent the patient exposure also. Second is we have to obtain an intraoral impression of the patient. Now this intraoral impression of the patient can be obtained by a digital scanner. There are two types of digital scanners, direct and indirect. Direct is which the scanner directly goes into the oral cavity and captures the picture, and indirectly is you have to take a scan and a lab scanner scans it. Or otherwise you can take the scan of the cast of the impression. Scan of the cast of the impression means you have to take a regular impression with a rubber base or alginate, whichever you prefer. Rubber base is always good. Then you have to prepare a cast, and this cast is kept on the CBCT machine and a scan is taken. Then the third is registration of both the scans in specialized image processing software. Now both these scans, scan number 1 and scan number 2, they are converted into DICOM and they are uploaded in image processing softwares. There are many image processing softwares available. Now registration of both the scans means you have to superimpose both the scans on one another, because the CBCT scans gives you the bony structures, and the intraoral impression, it gives intraoral scanner, it gives you the soft tissue. So naturally, when you have to prepare a guide, you need the soft tissue also. So the registration of these, this is what is the meaning of registration. Then after the registration is done, the preparation of the template or the guide is done according to the desired pathway of treatment in the software. This is usually followed on the basis of the implant placement. And then after it is prepared, the guide is first the guide is prepared in the software. Then from this software, it is transferred, and this guide can be 3D printed in a printer or milled in a CAD-COM for the treatment purposes, either way. This is a depiction of what I'm showing is, this is what is the CBCT scan has been taken. If you can see my arrow over here, this is the cast, the impression has been taken. Now in the second, you can see this tooth and you can see the green line over here. So this is the registration of the CBCT scan with the optical scan or the intraoral. And this is how it looks when it is converted into the object. This is how, this is the intraoral scanners and this is the CBCT one. Then this is the desired pathway which has come. We have taken this is present in the software itself. You have to take it, you have to see where the canal is and you put it over there. And after this, the 3D printed guide, or the guide is 3D print or milled. And here you can see the guide which is there over here, how it is put. There is a rubber dam, there is a guide put over there, and the treatment procedure which is going on. This is a guide which has been prepared for endodontic access of the canal. This is the guide. These are the screws which support it and keep the guide in position. This is the sleeve, and this is the burr or the operator which he goes directly into the canal. The second guide which is prepared is for the periapical surgeries. You can see here the guide which is present, and this window which is present over there through the CBCT and all. This is prepared very precisely. So this is where your burr has to go and you have to enter to do the periapical surgery. Then comes in the clinical applications, where all we can use this guided endodontic treatment. Now, guided endodontic treatment is a safe and dependable alternative procedure for the treatment of calcified canals. It improves the accuracy of apical surgery and helpful in specific difficult cases of dental root post removal. All articles have described guided access cavity preparation, guided surgery, and guided post removal as successful, with no reports of root perforation. So this is a very good one of the clinical applications of it. There are no root perforations because you actually know what you are performing and what you're doing. Then let us come to the accuracy. How? Okay, we can enter the canals. It is very good and very nice, no perforations, but at the same time, it should be accurate itself. So for testing the accuracy, various studies have been there in the literature. Bucharest in 2016, he reported an average deviation of 0.46 mm at the tip of the burr. Then Zender et al. In 2016, he reported a mean angle deviation of 1.81 degrees. And then he also observed the mean angle deviation in all the directions like mesial distal, buccal oral, and apical coronal. So in the mesial distal, it was 0.17. In buccal, it was 0.29. Sorry, 0.47 in buccal oral, and apical coronal, it was 0.17, which were all within the limits. Then another study which was done by Conant et al. In 2017, his deviations were a little less than that of the Zender, and also he did in all the directions. One was the mean deviation, then the mesiodistal at the tip of the burr, 0.14, buccal oral is 0.34, and apical coronal was 0.12. Now, in addition to this, both the authors, they reported no statistical differences between access cavities performed by two different operators. So that means there is good reproducibility between the different operators. So even the operators, if they change, the reproducibility is good. Now the accuracy of the guided surgeries. The accuracy of the guided surgeries has been carried out by two authors, Pinsky et al. In 2007 and Eckermann in 2019. They compared the use of the guided surgery with a freehand procedure for apical surgery. The results were significantly different to the control group in both the studies. The use of CAD-CAM guide yielded a mean distance of 0.79 mm from the apex, in contrast to the freehand osteotomies with a mean distance of 2.27 mm reported. This was reported by Pinsky et al. In 2007. Even Eckermann, he said that all the procedures done with the guide has a successful result, meaning that the end of all the drill paths were within the apical 4 mm of the teeth, which is considered to be a good method or a fairly accurate method. On the other hand, we found no studies for the accuracy of guided treatment on the removal of root posts. There have been two articles which have used this for removal of root posts, but as far as the literature was concerned, we couldn't find on the accuracy. Then the limitations. Every technique, we know every technique comes with some or the other limitations. Now, the technique of guided access cavity preparation is limited to the straight canals. The drill can only be used in the straight portion of the canal and not beyond the curvature. So it is fairly good in the anteriors, but in the posterior, especially in the molars, if you want to go, then you can access it only up to the straight canals. After that, you have to, if the canal has a curvature, then you have to go with your normal methods. In posterior teeth, limited mouth opening can be a limitation to perform this technique. Naturally, because of the guide being in place, the sleeve which is big, so a mouth opening is a limitation. Limited mouth opening is a limitation for this. And lastly, and an important one is the forces, they are generated by the tip of the burr. If the forces are more, they can generate the cracks on the tooth surface, and the excessive heat can damage the periodontal ligament and the alveolar bone. So hence, cooling is required. This is done by the irrigation. Some of the articles or some of the authors, they have even incorporated the channels for irrigating it. Now, in conclusion, Guided endodontics is safe and clinically useful method for treating compromised cases. It can be performed by both less experienced and skilled clinicians. Minimally invasive treatment can be performed, decreasing chair side time. However, larger in vitro and ex vivo population studies with longer follow-up periods are required, as well as standardized experimental studies with a similar sample size, aim, and standardized measuring methods are required. These are my references. And with this, I end my presentation.
Thank you so much. Anyone wants
Yes,
to ask a question?
Yes, ma'am, thank you for such a nice presentation. I would like to ask one thing, that are any special drills available for location of calcified canals?
Yes, ma'am. Usually usually the denser burrs are used, and whatever denser burrs you are using, you have to give the length and the diameter of the tip of the burr, so that when we prepare, the sleeve is prepared, so that length is put in the guide itself, and that hole, the sleeve, the hole which is there, it is just 1 millimeter extra to that of your tip of the denser burr. So there are no chances of deviating when you do the access openings.
So we have to provide the diameter to the lab.
Yeah, you have to provide the diameter to the lab. Diameter as well as length, ma'am. Length is also important.
Oh, thank you so much.
Welcome, ma'am.
All right, thank you so much. Let's proceed. Next oral presentation by Alina Moin, Subarti Dental College, India. Topic about biomimetic enamel regenerative technologies and recent approaches. Yep, I can now see your screen.
Ma'am, am I audible?
Yes, you are. Please
Ma'am, and
proceed.
is the screen visible?
Yes, it is. Go ahead.
Okay, okay. Good afternoon to the chairperson and my fellow colleagues. The topic for our paper presentation is Biomimetic Enamel, Regenerative Technologies and Recent Approaches. According to the global consensus, the principal approach to modern-day caries management should be to preserve the tooth structure and restore only when necessary. Modern-day dentistry clearly needs such minimally invasive remineralization measures, not just to enhance clinical outcomes, but also to improve patient experience and well-being. The first international conference on novel caries, anti-caries and remineralization agents has suggested that the broad aim of new remineralization therapies should be to facilitate caries control over a lifetime using evidence-based, clinically effective, multifactorial prevention to keep the caries process in balance. Dental caries pathophysiologically is not simply a continual cumulative loss of tooth minerals, but rather a dynamic process characterized by alternating periods of demineralization and remineralization. Remineralization can occur as a natural repair process where salivary calcium and phosphate ions are deposited into crystal voids of the demineralized tooth structure, resulting in net mineral gain. But is natural remineralization therapy alone sufficient? To support this, few longitudinal studies in literature that followed the natural progress of white spot lesions found that although some white spot lesions got smaller, the majority are largely unaffected even after 2 years. Moreover, salivary remineralization is a slow process, and fluoride-mediated salivary remineralization is also seen to be restricted to the outer 30 micrometers of the tooth. The pivotal discovery of fluoride as an agent that could prevent dental caries was one of the most important landmarks in dentistry. Fluoride remains a gold standard for arresting caries lesions, with multiple literature reviews confirming their role in preventing dental caries. These are the few traditional systems like varnishes, mouth rinse, toothpaste containing fluorides. But recently, the trend is towards a decline on the effectiveness of fluorides, which has been attributed to the fact that diets across the world are changing to include more processed and sugar-laden foods, limiting the repair potential of fluoride. Increasing dentifrice fluoride content raises the safety concerns as it is known fact that fluoride is a chemical neurotoxicant. Children that are exposed to fluoride from multiple sources potentially increases the risk of developing dental fluorosis with permanent tooth mottling and fluoride bombs or occult caries. Thus, evidently, there was a need for a new age remineralization technologies with an ability to complement fluoride system and cause a fuller consolidation of carious lesions. This paper discusses the rationale for using non-fluoride remineralization systems that have underpinned some of the technological advances in enamel remineralization therapies. The non-fluoride enamel remineralizations can be broadly categorized into first, biomimetic regenerative systems, where biomimetic stands for mimicking life. And the second category is of fluoride boosters. These newer remineralization structures either regenerate lesion of the body structure or provide ions like calcium and phosphate, favoring subsurface remineralization. Starting with the biomimetic systems, the dentine phosphoproteins, ADSS peptides, have a dual mechanism. First, they limit the dissolution of calcium and phosphate ions from the demineralized dentine. And second, they promote the capture of these ions to form a new mineral deposits on the demineralized enamel. The P11,4 fibrillomactris has a high affinity for calcium ions and act as a nucleator for de novo hydroxyapatite formation, resulting in remineralization of the lesion body. Then there were artificially synthesized amylogenins and polyamidoamine dendrimers that helped in biomimetic hierarchical regeneration of hydroxyapatite crystals on acid-edged lesions. Electrically accelerated and enhanced remineralization technology, which utilize iontophoresis to accelerate the flow of remineralization ions into the deepest part of the subsurface caries lesion. While nanohydroxyapatite acts as calcium phosphate reservoirs, maintaining a state of supersaturation with respect to enamel minerals, thereby inhibiting demineralization and enhancing remineralization. These are the few commercially available biomimetic remineralization systems. Coming on to the fluoride boosters, they can be broadly categorized into calcium phosphate systems, polyphosphate systems, and which are naturally available. Calcium phosphate systems contain casein phosphopeptides which act as a saliva biomimetic that have a great calcium stabilizing capacity. These CPP and ACP complexes are readily soluble in saliva that create a diffusion gradient that allows them to localize in supragingival plaque and during low pH, that is a keriogenic attack, releases calcium and phosphate ions. Then we have the polyphosphate systems that have salts like sodium trimetaphosphate, which strongly bind to the phosphate sites on the enamel. This leads to the formation of a protective layer on enamel surface that limits acid diffusion of ions during a keriogenic challenge. Example can be Oral-B Pro Expert toothpaste. While natural products are not commercially available, the mechanism is also not fully clear, but it is hypothesized that polyphenols present in them interact with and stabilize the organic matrix remnants, thereby blocking the ion diffusion pathways and slowing demineralization. In an article by Kim and Jim that stated that naturally available Gala chinensis significantly enhances enamel remineralization and exerted a synergistic effect with calcium. It has also shown to exert a strong bactericidal activity and inhibits acid production and changes in the microstructure of S mutans biofilm. In a systematic review and meta-analysis by Salem et al. For the treatment of early enamel lesions, non-classical remineralization using self-assembling peptides, whether used alone or in combination with fluoride, showed a positive outcome that was superior to that of the fluoride varnish. Various articles in the literature have proven that rationally designed amylogen peptides act as an effective modulators of hydroxyapatite nucleation and crystal growth processes. And cytosine biomimetic mineralization systems are another innovative, low-cost approaches to regenerate a new hydroxyapatite crystal layer possessing properties similar to those of the natural enamel. To this day, enamel tissue engineering remains a unique biotechnological challenge. Whether it is a fiction or future was correctly described by Pandya and Dexwich in 2019, where they stated that biochemistry-based approaches towards enamel regeneration might employ novel 3D bioprinting technologies. Surface biomineralization approaches will improve with advances in peptide designs and dendrimer technology. Innovations in the bioreactor technology are destined to decipher the optimum environments and conditions necessary for ameloblast cell cultures. Whole organ engineering techniques in combination with novel insights into tooth induction and maintenance signaling cascades will provide sound approaches for future de novo tooth organogenesis. To conclude, the effective non-fluoride remineralization strategies can prevent a non-cavitated lesions from being subjected to a death spiral of restorations due to secondary caries at the enamel restoration interface. Guided enamel regeneration forms a holy grail of remineralizing therapeutic approaches, and biomimetic strategies for enamel regeneration forms the future, where organized enamel apatite crystals with robust attachment to the tooth surface are grown to replace demineralized tissues. These are the list of the references. Thank you.
Thank you. Questions?
Yeah, Dr. Arina, thanks for such a nice presentation. And can you please highlight how can we diagnose the incipient carious lesion?
Incipient carious lesions are usually diagnosed in a dry condition, ma'am, because in wet conditions, due to the refractive index of the water and the enamel, we usually cannot see it. Then we can also use uh, LED, laser technologies like LEDs.
Like how can we differentiate between a hypoplastic enamel, those hypoplastic white spots, and this if it is an incipient caries white lesion, subsurface white lesion?
Ma'am, incipient carious lesion, we need a dry, like even in wet condition, we can see a hypoplastic enamel, the white spot of a hypoplastic enamel. While in cases of incipient caries, we need to dry the lesion so we can see the subsurface incipient carious lesion.
Okay, thank you.
All right, let's proceed. Next oral presentation would be by Dr. Upasana Reddy, Abseti Dental College, India. As the topic is about assessment of the effect of oil pulling with coconut.
Good evening. Is my presentation visible? I mean the slides?
Yes, it is. Please proceed, doctor.
Okay. Good evening. I'm Dr. Upasana. My presentation today is on assessment of the effect of coconut oil pulling on oral hygiene. It is a review. We start with the background on coconut oil. Basically, coconut oil is extracted from the flesh of a coconut palm, scientifically called as Cocos nucifera. It has provided us with a lot of nutrition including fat for generations, and it has been used in food from several decades. But from the last few years or last 2 or 3 decades, it's been popularized in medical and the dental industry. And there are many who promote oil pulling as a preventive form, especially for oral diseases. So what exactly is oil pulling? It is basically gargling or rinsing the oral cavity with oil especially the oil has to pass between the teeth. And the procedure that is usually advocated is by using 10 to 15 ml of virgin coconut oil, which fills the mouth half or either half full or around 2 teaspoons. So the mechanism that is usually advised is to sip, suck, and pull the oil without swallowing in between teeth with the chin slightly up, and the swishing of the oil is ideally to be maintained at 8 to 10 minutes or up to 30 minutes depending upon the comfort level of the patient or the person doing it. And at the end of the procedure, it was advocated that the oil which is spat out should be whitish in color. So why oil pulling? The major advantages of pulling over the other available mouthwashes in the market are: the biggest drawback with other mouthwashes is staining. So in oil, we don't have that problem. There is no aftertaste. It is easily accepted to patients, like compared to any other rinse, because it is easily available. And so far, there are no known allergic reactions which have been reported by using oil. And it is cost effective compared to other commercially available mouthwashes, and easy availability. And if we go back to Ayurvedic medicine from several years back, it has been used for treating even other systemic conditions, and it is used much more in the Indian subcontinent and other tropical countries, and only recently it's gaining a global presence. Coming to systemic effects, if we have to see, so oil pulling has been used to treat diabetes, asthma, thrombosis, bronchitis, several skin diseases, to name a few. And if we go to look at coconut oil in dentistry, the main use for using this edible oil is because of a high saponification value. And Hysoflor and Cabara were the first one to promote its antimicrobial properties in dentistry, which is 26%. The main reason for this is the saponification activity which the oil has. And there are many studies which have shown antimicrobial activity against gram-positive and gram-negative organisms, including Staphylococcus aureus, mutants, and Candida albicans, which are the most important from conservative dentistry or caries point of view. Coming to the composition and the mechanism of action of the oil, coconut oil has 45 to 50% of lauric acid, which has a long chain monosaturated fatty acid. So as I said, the mechanism that we use this oil, it has a swishing action which promotes the emulsification on the surface area of the tooth. This thereby reduces the plaque adhesion, and it breaks down the bacterial coaggregation. The other possible mechanism might be that the saponification process through alkaline hydrolysis of oil happens by the bicarbonates present in the saliva. And yeah. So the lauric acid in the oil reacts with the sodium hydroxide of saliva and forms sodium laurate, and it is responsible for the cleansing action which inhibits any accumulation, the first layer being the biofilm of plaque. It is claimed that the swishing activates enzymes and it draws these toxins out of the saliva or the blood. Now, oil pulling therapy should be done ideally before toothbrushing on an empty stomach in the morning, so that there is no other involvement of any other substance that is consumed by the person. And 10 to 15 minutes is ideal, but theory has shown even up to 30 minutes the procedure can be performed. So if I have to conclude this study, coconut oil pulling or gargling is as effective as using a chlorhexidine or any other mouthwash. The combined effect of the emulsification, saponification, and the antimicrobial effects of these triglycerides are the reason for the reduction of S mutans, Staphylococcus, which is the cause of caries. Coconut oil pulling shows a significant reduction of gingival, microbial, and plaque spores. Hence, it can be used as a preventive home therapy to maintain oral hygiene, especially in developing countries for the prevention of dental diseases. Thank you.
Thank you so much. Questions?
Yeah, ma'am. Can you please explain why it has to be done before brushing in the morning?
Ma'am, the simple reason for that being, before the person who is performing the oil pulling consumes any other food, or if they, even the toothpaste sometimes can what do you call in like stop the mechanism of action, like as in the action of oil may not be good if it is the teeth are already coated by another layer of fluoride or something else. So ideally, as soon as they wake up in the morning, before they eat anything or take any other medication, in theory, that's why we promote it before on an empty stomach and before as soon as they wake up.
Okay, thank you, ma'am.
Thank you.
Thank you so much. And let's proceed. Oral presentation by Abhishek Bhargava, Subharti Dental College, India. Topic is about stem cells, beginning of the new era.
Good afternoon, ma'am. Is the slide visible?
Yes, it is. Proceed.
Okay.
Jai Hind and a very good afternoon to all the dignitaries present here. I, Dr. Abhishek Bhargav,
and I, Dr. Rohit Ahuja,
from the Department of Conservative Dentistry and Endodontics, Subharti Dental College. As rightly said by Sir John B. Gordon, life is not a one-way journey. Life there and back again.
With that note, we are going to present a poster on the topic, stem cells, the beginning of the new era.
Dolly was the world's first mammal to be cloned from the adult stem cell. So, what exactly a stem cell? According to Cohen, stem cells is defined as a distinct subpopulation of undifferentiated cell with self-renewable and differentiation potential.
Stem cells can be classified as embryonic stem cells, adult stem cells. Adult stem cells are further classified as the adipose-derived, hematopoietic stem cells, mesenchymal stem cells. Mesenchymals are further classified as the dental pulse stem cells from the apical papilla, stem cells from the human exfoliated deciduous tooth, stem cells from the periodontal ligament, and so on. They can also be totipotent, pluripotent, multipotent, oligopotent, unipotent, and so on. And stem cells can be autologous, allogenic, and xenogenic. Stem cells serve as a repair system for the body. They are unspecialized, so they cannot do specific function in the body. They have a potential to become specialized cells such as muscle cell, blood cell, brain cell, and nerve.
Stem cells originate from two main sources, adult body tissue and embryo. Scientists are also working on the way to develop stem cells from other cells using genetic reprogramming techniques such as somatic cell nuclear transfer and induced pluripotent stem cells. A person's body contains stem cells throughout their life, and the body can use these stem cells whenever it needs them. Stem cells are present inside different type of tissues like brain, bone marrow, blood vessels, nerves, umbilical cord, skin, skeletal muscles, liver, as well as nerves and blood vessels of pulp.
The stem cells can be used to grow new cells in laboratory to replace the damaged organ or tissue. It can be used to correct the parts of organ that don't work properly. It is used in research how diseases occur and why certain cells develop into cancer cells and test new drugs for the safety and effectiveness. They can also be used for the treatment of various diseases such as Parkinson's disease, Alzheimer's, spinal cord injury, osteoarthritis, rheumatoid arthritis, etc. Now let's see what are the scope of stem cells in general dentistry and endodontics.
In general dentistry, stem cells are used to recreate the missing or extracted teeth. For regeneration of bone and other facial tissues in cleft patient or in other congenital disorders. It can also be used in treating skeletal discrepancies and for distraction osteogenesis. Complete regeneration of dentine, cementum, as well as periodontium can be done using stem cells technique.
Whereas in endodontics, stem cells are used to regain the vitality of tooth, to regenerate the pulp-like tissues, ideally the pulp-dentine complex. It can also be used to regenerate damage coronal dentine, and resorb root. Stem cells can also be used for the management of immature permanent teeth. Finally, to conclude,
We want to say that
we should learn from our past,
watch our present,
and apply it to create the future. Thank you.
thank you.
Hello. Yes, can you please tell that whether the stem cells, what is the advancement that has been done in the stem cells as far as to recreate the missing teeth?
Ma'am, nowadays, ma'am, scientists are using, ma'am, the recombination technique, uh, which they are using, ma'am, somatic cell nuclear transfer or induced pluripotent stem cells for regeneration of the missing teeth.
So, what have we achieved till now?
Uh, not exactly to regain the missing tooth, but we have gone through an article in which it was written that the stem cell therapy has gained about 45% success rate in general. Not exactly we are talking about the missing
Like,
tooth.
have been able to regenerate enamel, dentine using stem cells?
Yes, ma'am. There are various articles related to that.
Okay, thank you.
All right, thank you so much. And let's go ahead and proceed to our next presenter. Oral presentation by Dr. Darshana Divadiga, Abshetty Dental College, India. Topic is about the assessment of biomodification of dentine surface by application of remineralizing agents and laser.
Hello, good afternoon.
Yes, good afternoon, doctor. I can see your screen. Please proceed.
Yes, good afternoon, everybody. I'm Dr. Darshana Devadiga. My topic of presentation is assessment of biomodification of dentine surface by application of remineralizing agents and lasers. As we know, oral cavity is a battlefield of activities of two different processes happening simultaneously or one after the other. First one is the demineralization and followed by remineralization. The ratio between the two processes is crucial in determining the hardness and strength of the tooth structure. Demineralization generally refers to loss of minerals, mainly calcium and phosphate, which could occur because of either carious or non-carious assaults on mineralized tissues of the tooth, which become porous, permeable, allowing fluids, ions, and microorganisms. If followed by destruction of the organic material and subsequent invasion by microorganisms, this could lead to caries and eventual pulpal involvement. On the other hand, remineralization refers to the process whereby calcium and phosphate ions are supplied from a source external to the tooth to promote ion deposition into crystal voids in demineralized enamel or dentine to produce net mineral gain. It requires the presence of partially demineralized crystals that can grow to their original size when they are exposed to fluid that is supersaturated with respect to the hydroxyapatite minerals. On the screen, we can see the various mechanisms that are influential in promoting either remineralization and demineralization, and each of them could twist or swing the favor in towards remineralization and demineralization depending on the patient's genetic, lifestyle, habits, and oral hygiene maintenance. Now, why do we require any kind of intervention? The need for surface protection and reinforcement is usually the method of choice for management of non-carious lesions such as attrition, abrasion, and erosion, where we see a loss of enamel due to the exposure of the coronal dentine. And the gingival recession and cervical abrasion, in addition to cementum loss, can also expose the reticular dentine. And this could be seen in several signs of indications where drug abuse, lifestyle management, anorexia, bulimia, gastric regurgitation, hypoplasias, all kinds of intrinsic or extrinsic reasons that could contribute towards the loss of the enamel surface, which is the outer protective layer, and exposure of the underlying dentine, which is the last barrier left towards the pulpal involvement. Now, remineralizing agents generally can be classified in several ways, but the simplest one would be the fluoride based and the non-fluoride based. And the non-fluoride based generally are popularly divided on calcium phosphate based versions, the silver diamine fluoride, the sugar substitutes, and the plant derived ones. The remineralization strategies basically are targeting the inorganic minerals. The traditional remineralizing agents like fluoride-based materials mainly replace the lost inorganic mineral components only. However, newer strategies designed later are now being called as biomodification strategies, which target both the inorganic mineral as well as the organic collagen matrix, which comprehensively enhance and reinforce, or rather what we call it as fortify, both the mineralized and organic substrate by locally altering the biochemistry and biomechanical properties with the help of biotherapeutic agents, which are referred to as biomodifiers. These are the photographs of commercial products which are already available in the market for various kinds of interventions and management protocols for caries and non-caries prevention strategies of minimal invasive dentistry. But coming to biomodification, what is biomodification? Biomodification is a word made up of bio plus modification, where the process of modifying a biological organism by either genetic or mechanical means, a material by biological or enzymatic or genetic means. It means basically the categorization of certain products, either physical or chemical, natural or synthetic. Now, the modification as given by Anna Bertrand Rousseau, 2014, is physical methods of photooxidative method, chemical resources or agents which include synthetic or natural and renewable resources. And main among them, which is worth mentioning, is a grapeseed extract, which has an active ingredient of proanthocyanidine. The clinical applications of dentine biomodification basically involves tooth biomaterial interfaces, including clinical applications improving the resin-dentine bond longevity, improving tissue biomechanics, prevention of biodegradation and inhibition of proteases, and of course, our favorite, the dental caries prevention and remineralization protocols. The grapeseed extract is one of the most popularly tested and evaluated products in recent times amongst biomodifiers which are available in the market. It is known to inhibit demineralization and promote remineralization of root caries lesions. The combined use of GSC, that is the proanthocyanidine, along with CPP-based GC tooth mousse has been shown to have a synergistic effect on root caries remineralization by enhancing mineral gain and increasing the hardness of root caries, as listed by Passage, an Australian dental journal in 2014. Another product is a silver diamine fluoride, which is fast gaining acceptance in pediatrics as well as preventive dentistry. It's 38% silver diamine fluoride, which has a high concentration of silver fluoride ions. And mostly in root surface caries, it's known to have the inhibition action on the growth of multi-species karyogenic biofilms, reducing the demineralization process by minimizing the loss of minerals and slowing down collagen destruction. Its main indication so far has been the popular usage of it in prevention of root caries as the recommended best choice. The primary agent, 38% STF solution, is professionally applied and recommended annually. The secondary agent, in addition, could be a synergistic action using 22,500 ppm of sodium fluoride varnish professionally applied every 3 months. Now, in addition to that, there is another protocol which has been attempted, that is laser irradiation and treatment of dental surface, where the alteration of dentine surface has been attempted to manage dentine sensitivity by sealing tubules, increasing the resistance to acidic solution by altering the critical pH and therefore providing protection against dental caries and erosion. It also helps in inadvertently as an indirect effect to increase the surface hardness, which relatively improves its abrasion resistance to mechanical wear, which is usually seen in case of abrasive brushing, attrition, abrasion, and abfraction. So when you combine laser irradiation in combination with topical fluoride treatment, it could possibly give greater resistance to caries as well as non-carious loss of tooth structure. Several mechanisms have been used to explain the improvement of caries resistance following laser and fluoride application of enamel. Some studies have also reported that laser irradiated enamel can retain fluoride longer than unlaced enamel. How does this work? When you combine the two treatments, the heating provided by the laser enables the incorporation of fluoride into the melted layers of enamel surface and induces the transformation of hydroxyapatite to fluorapatite. And since the 1960s, they have demonstrated that lasers can significantly alter the permeability, the crystallinity, and acid solubility of enamel, promoting an increase in its resistance to demineralization. The most promissory effect amongst all the lasers tested has been erbium chromium YSGGG laser for caries prevention, which is known to have enhancement of calcium fluoride-like material formation and retention on enamel after APF application. This could possibly maintain the karyostatic effect of APF gel for a longer period of time, even with a single application. A study which was done just to evaluate the morphological changes of root dentine was assessed with varying output power of diode laser. With a continuous mode of delivery, we observed that root dentine, when subjected to SEM analysis, showed occlusion of dentinal tubule openings on the root canal walls, which were scored using a 4-grade scale by 3 examiners and independently, and showed that the group 4 with the highest power wattage of 4 watts showed significantly higher scores of morphological changes. The conclusion from this study was that ultrastructural morphological changes, which intensified with increase in the wattage power of laser, some areas showed characteristic fused representations like lava-like areas too. And this actually corroborates the effect of improving the dentine permeability by reducing the permeation of ions and microorganisms deeper into the pulpal tissue. Another study where it was a combination of biomodification of dentine and remineralization potential of natural remineralizing agents versus synthetic remineralizing agents, where three products tested were rapeseed extract, silver diamine fluoride, calcium sucrose orthophosphate complex. The samples were subjected to pH cycling and evaluation using SEM ADAX. The demineralization resulted in statistically significant mineral loss compared to the intact dentine. However, when the products tested between natural and synthetic agents were all found to be effective in remineralizing in the following order, which is the calcium sucrose orthophosphate complex, followed by SDF and GSE, that is the grapeseed extract. In moving from a surgical to a medical model in dentistry, rather than repairing incipient lesions mechanically, restoring the equilibrium of ion exchange can provide a longer lasting solution. Restorations will need continual replacement, remineralized tooth structure, whereas could last a lifetime. The search for a biotherapeutic surface protective agent or a treatment modality for protection and fortification of mineralized dental tissues continues. One which will fulfill the following requirements: simple to use, safe to use, non-invasive, painless, cost-effective, and of course, one which will give you a long-term effect. Thank you.
Questions?
Yes, ma'am. In one of the slide, you have mentioned that these biomineralizing agents would like it would increase the strength between bond between dentine and resin.
Yes.
So, can you please highlight it?
Yeah, basically, when we talk about bonding to enamel, we have a lot of literature which says that is one of the best mechanisms of hybrid layer formation because of its higher inorganic content. But when we talk about dentine, the hybrid layer is a little tricky because of its hydrophilic nature. The collagen usually collapses, and it is not a very good agent to combine with the inorganic component of the resin. So if you can maintain the structure of collagen, that is avoid its loss of integrity, and you maintain its structure by providing some kind of collagen stabilizing agents, which will not allow the matrix metallon MMPs, the enzymes which will usually degrade the hybrid layer by attacking the collagen. So if you can provide some collagen stabilizing agents that will reinforce and maintain the collagen structure, it will help in providing an enamel-like resin tag or a hybrid layer integrity for a longer period of time. And that is basically the logic or the hypothesis that says if you provide collagen stabilizing agents, it will help in maintaining the integrity of the hybrid layer for a lot longer than what is available right now.
Okay, thank you so much, ma'am.
Yeah.
Thank you so much. And let's proceed.
Thank you.
Our next presenter, an oral presentation by Rudra Kool, Subharti University, Meerut, India. Topic is about the intracanal medicaments, shining stars of endodontic treatment.
A very good afternoon to one and all. Today, I, Dr. Rudra Kaul, is going to present a review article on the topic novel intracanal medicaments. Disinfection is an important step during and after cleaning and shaping. However, complete elimination of microorganisms may not be achieved by chemomechanical preparation alone. Therefore, the use of intracanal medicaments have been advocated to further reduce the number of microorganisms. Intracanal medicaments have traditionally gone hand in glove with the endodontics. Intracanal medicaments are defined as temporary placement of medicaments into root canals for the purpose of inhibiting invasion of bacteria. The properties of an ideal intracanal medicaments are: it should be antimicrobial, it should be non-irritating, it should have prolonged antimicrobial effect, it should be active in the presence of blood and serum, it should have non-staining effect and not induce a cell-mediated immune response. Various indications of an intracanal medicament are: it is indicated in weeping canals for the elimination of microbes in the pulp space, neutralizing tissue debris and barrier against leakage. According to DCNA, intracanal medicaments can be classified as follows: phenolics compounds consisting of eugenol, CMCP, thymol, cresol, etc. Aldehydes consisting of leuteraldehyde and formocresol. Halides consisting of sodium hypochlorite and iodine. Steroids, antibiotics, and their combinations like lead-mix. Others are chlorhexidine, and lastly, the calcium hydroxide. Calcium hydroxide-based intracanal medicaments are the gold standard. They dissolve organic remnants and heal periapical inflammation. Its antimicrobial action is related to its high pH, which results in the inactivation of bacterial membrane enzymes. In spite of various advantages and indications of calcium hydroxide, it do have some limitations, like its removal is difficult, not totally effective against Enterococcus faecalis and Candida. Furthermore, calcium hydroxide causes weakening of root dentine. In a systematic review and meta-analysis which was published in the International Endodontic Journal in the year 2006, it was concluded that calcium hydroxide has limited effectiveness in eliminating bacteria from the root canal. Calcium hydroxide has been the prototype of any intracanal medicament used nowadays, but with advancement in the field of endodontics, newer material have evolved. Triple antibiotic paste. It is a combination of three antibiotics, namely minocycline, ciprofloxacin, and metronidazole. Metronidazole is particularly toxic to anaerobes. Minocycline is bacteriostatic and show activity against gram-positive bacteria and gram-negative bacteria. Moreover, ciprofloxacin exhibits high antimicrobial activity against gram-negative bacteria. If the tap has to be used, it should be mixed equally in the ratio of 1:1:1 to final concentration of 0.1 to 1 milligram per ml. Minocycline has been discarded from triple antibiotic paste because of its discoloration effect. Cefaclor has been included instead and is described as a modified triple antibiotic paste. Kim et al. In the year 2014 reported that triple antibiotic paste showed a larger inhibition zone against E. faecalis than the calcium hydroxide. Nisin. It is a natural occurring antimicrobial peptide obtained from Streptococcus lactis subspecies. It has antimicrobial activity against a wide range of gram-positive bacteria, even against the E. faecalis. Mahendra M. et al. In the year 2016 conducted a study to assess the efficacy of nisin, neem, propolis, calcium hydroxide, and PRP when used as intracanal medicament against E. faecalis. The results showed that nisin produced better results than other tested agents. Somnath et al. In the year 2015 concluded that nisin was found to be the most effective in reducing the bacterial count of enterophycalis in a week. Its action was found to be comparable with that of the chlorhexidine. Bioactive glass. It is a valuable adjunct as it has antimicrobial property and chemical composition similar to that of dentine and bone. Its antimicrobial property is because it raises the pH almost equivalent to that of the calcium hydroxide. A study done by Kritika Datta et al. Showed that bioactive glass S53P4 can be used as intracanal medicament, and it was concluded that it is less effective than 2% chlorhexidine but more effective than calcium hydroxide. In a study done by Goel et al. In the year 2016, it was demonstrated that bioactive glass has superior antibacterial properties as compared to chlorhexidine 1% gel. In an article on iron release and pH of calcium hydroxide, chlorhexidine, and BAG-based endodontic medicaments, it was seen that more sodium and phosphate ions are released by BAG and presented an alkaline pH immediately and after 30 days. Nowadays, there has been an increasing trend to seek herbal alternatives for endodontic treatment. This way of use herbals for curing various diseases is known as phytotherapy or phytomedicine. In endodontics, plants and their extracts can be used as intracanal medicament as to prevent the potential side effects caused by the conventional chemical agent. Propolis is a natural antibiotic resins material obtained by honeybees. It exhibits varying degree of anti-inflammatory and antibacterial properties. The main biological active components present in this are flavonoids and cinnamic acid derivatives. ONCAG in the year 2016 evaluated efficacy of propolis as an intracanal medicament against E. faecalis and concluded that propolis can be effectively used along with the calcium hydroxide as a dressing for elimination of E. faecalis. Curcumin is the main bioactive component of turmeric and has been shown to have wide spectrum of biological actions, including antimicrobial, anti-inflammatory. A study done by Neil Cunton on the effectiveness of curcumin against E. faecalis, it showed that curcumin was able to demonstrate complete eradication of E. faecalis. Prabhakar et al. In the year 2013 conducted an in vitro study and compared the antibacterial efficacy of calcium hydroxide paste, 2% chlorhexidine gel, and turmeric extract as an intracanal medicament and their effect on the microhardness of root dentin. And they concluded that curcumin does not affect the microhardness of the root dentin and is a potential intracanal medicament. Coming to the aloe vera. The two main active components of aloe vera are aloin and aloe-emotin. It is effective against Streptococcus pyogenes and E. faecalis due to the presence of anthrax quinine, which inhibits the formation of these two bacteria. In a study, it was found aloe vera, in contrast to calcium hydroxide, eliminated 4th and 6th week biofilms and showed remarkable antibacterial properties against E. faecalis biofilm. Continuing with the mushroom, it has both low and high molecular weight active compounds. It possesses medicinal properties like anti-inflammatory and antimicrobial properties. The low molecular weight components present in mushroom are pleclastin and grifolin and neugrelin, which imparts capacity to penetrate deep into dentinal tissues. It has highest efficacy against gram-negative bacteria. Hurain et al. In the year 2016 conducted a study on the efficacy of calcium hydroxide, mushroom, and aloe vera as an intracanal medicament against E. faecalis, which was an in vitro study, and found that mushroom can be as potent as intracanal medicament against E. faecalis. Lemon solution has a pH of 2.21 with a lower acidity. It is effective in clearing the smear layer and therefore acts also as a chelating agent. Fresh lemon juice solution has antibacterial property. Abu Ziad et al. Done a study in which fresh lemon solution was shown to have wide antibacterial efficiency against E. faecalis and hence can be used as an intracanal medicament. The active constituent of woodrock adds sequestraprine, lactones, and carbohydrates inulin. The antimicrobial properties of Actrium lapa were studied. From that, it was concluded that constituents of Actrium lapa showed a great effect against E. faecalis and Candida albicans. Gentil et al. In the year 2006 conducted an in vitro study and evaluated the antibacterial effect activity of Actrium lapa and concluded that it can be used as an intracanal medicament. Coming to the castor, it is rich in castor acid or rhinolinic acid. In an in vitro study conducted by Valera et al. In the year 2013, it was found that castor was able to destroy Candida albicans and E. faecalis. In other studies done by Gracia et al., it was observed that calcium hydroxide and castor oil paste had better activity than calcium hydroxide and propylene glycol paste against other microorganisms commonly found in endodontic infections. These are some other natural or the herbal intracanal medicaments which can be used. For example, guava, green tea, cranberry, papain, Caesaria sylvestris, rose plant, glyceria, and eucalyptus. Today's takeaway message for home is, when the root canal is extensively infected and intra-appointment time periods are long, there is a merit in using an intracanal medicament. Intracanal medicaments play a secondary role and should not be used as an alternative to the thorough cleaning of the root canal. Every case should be judged on the advantage and disadvantage of using an intracanal medicament. Single visit endodontics, where intracanal medicaments are not used, is nowadays indicated. And various reports have shown that clinical outcomes between single and multiple visit endodontics are almost similar. If multiple visit endodontics is chosen, an intracanal medicament is strongly recommended. Therefore, intracanal medicaments, which were the earlier the shining stars of endodontic treatment protocol, seem to have been retired from the front line, but still retain some significance. These are the list of my references. Thank you.
Thank you so much.
Hello. Yes.
Yes, ma'am.
What is your opinion whether the endodontics should be done in a single visit or intracanal medicaments, they play a major role and hence multiple visit endodontics is recommended?
Good afternoon, ma'am.
Yes.
Ma'am, according to me, if single visit endodontics is indicated in some case, then if we go for a good disinfection, there is no need of intracanal medicament. For example, if we use good amount of hypochlorite, EDTA along with ultrasonic and sonic activation, it can be done without the use of an intracanal medicament. But in cases like weeping canals, in cases with apical periodontitis or large periapical lesion, where the patient is symptomatic also, we should go for intracanal medicaments because they can't be done in a single visit, and there is some significance of intracanal medicament as it has been shown in many studies that they prevent the ingrowth of bacteria into the root canal.
Okay, thank you.
Okay, ma'am, thank you.
Thank you so much. And let's proceed with our next oral presentation by Ambavalavanan. Sri Ramakrishna Dental College and Hospital, India. Topic is about efficacy of proanthocyanidin pre-treatment on push-out bond strength between the glass fiber post and root dentin and in vitro study. Hello? All right, let me call on oral presentation by Dr. Julie B. Gawande. VYWS Dental College and Hospital, India. Electromagnetic interference of communication devices and apex locators, an in vitro study there.
Yeah, is the slide available?
Yes, it is, and I can hear you. Please proceed, doctor.
Okay. A very good afternoon to the chairperson. Myself, Dr. Zuili Gamanti, will like to enlighten you upon electromagnetic interference of communication devices on apex locator, an in vitro study. With the growing awareness and concern of a population towards their dentition, root canal therapy has now become an integral part of dental practice. The secret of healing of an endodontic lesion depends on various factors, among which correct working length estimation remains the crucial step. Working length is a distance from coronal reference point to a point at which a canal preparation and obturation should terminate. Several approaches have been proposed, among which radiographic method is the most popular one. Eventually, this method was not found to be a reliable method as it is a two-dimensional image of a three-dimensional object. To overcome this, electronic apex locators were introduced. Various literatures were published suggesting accuracy of electronic apex locator. But one of the major concerns regarding electronic apex locator is the possibility of inaccurate or incorrect readings as a consequence of electromagnetic interference provided by different electronic devices, including mobile phones. The effect of electromagnetic interference is an inherent property of a radio waves occurring when an electromagnetic wave radiates from a smartphone near a medical device. In this situation, there is a possibility that the electric field produced in the space may exceed the immunity of the medical device. Results from a simulation study have shown that the field strength emitted from a mobile phone may meet the recommended electromagnetic interference immunity level of 3 volt per meter set by the International Electrotechnical Commission for Medical Equipment, keeping a separation distance of more than 1 meter from mobile phones. So the aim of the study was to determine the effect of electromagnetic interference of radiation from mobile phones on determination of working length by electronic apex locators. For this study, 10 natural single-rooted maxillary and mandibular anterior teeth with single canal were chosen. Mobile phone has become an integral part of human life. For this study, a second-generation phone or a digital uses the global system for mobile communication with 2 frequencies. The other phone which was used was the third generation, which is a new generation of mobile network technology with multimedia approach based on code division multiple access technology. The 2 apex locators which were used in this study was Root ZX Mini by J. Morita and Apex ID by Sabron and Root. But the manufacturer of these apex locators claims that the electronic wave interference could cause this device to operate in an abnormal, random, and possibly dangerous manner. So, a study model was prepared in which a container filled with normal saline was used, in which a single rooted teeth were embedded. 10 number K file was introduced in the canal, which was held with the file holder of an apex locator, and a lip clip was inserted in the normal saline to complete a circuit. All the 10 samples were examined with the help of Root ZX Mini as well as with the help of Apex ID. The groups were divided as the group 1 contained Root ZX Mini in close proximity of 3G smartphone when Bluetooth and Wi-Fi is activated, while group 2 contains Root ZX Mini in physical contact with 2G phone. Group 3 was Apex ID in close proximity of 3G smartphone when Bluetooth and Wi-Fi is activated, while Group 4 is Apex ID in physical contact with 2G phone. These were the values obtained from the study. When the 3 readings were taken for each tooth, an average of the readings were tabulated and compared for a mean and standard deviation under different conditions. It was found that in a closed room, among the different apex locator, there is no significant change in measurement of reading when compared with mobile phones in different conditions. According to a worldwide survey in 2015, about 4.9 billion people own a mobile phone, which is representing more than half of the world's population. Various electroconductive materials were used in the previous study to simulate periodontal ligament, but because of the feasibility of the material, normal saline was chosen for this study. The two apex locators which were used was Root ZX Mini by J. Moore, which is a third generation apex locator, which measures the impedance of two different frequencies and provide apex location based on resulting quotient. While Apex ID is the sixth generation apex locator based on dual frequencies that are sent from and returned to the unit after traveling along with the electric circuit. Electromagnetic interference is broadly defined as an unwanted electromagnetic energy that causes undesirable response, degraded performance, or failure in an electronic equipment. During the initial development of digital cellular phones, 2G was the first technology developed for voice and data communication. As far as cellular phones are concerned, 2G cellular phones emit high and variable amount of peak power. The clear distinction between 2G and 3G cellular phone is the peak power emitted by 3G cellular phone is much lower when compared to the corresponding value issued by 2G phones. The distance between two electronic devices can influence electromagnetic interference. Therefore, different distances between the cellular phone and the electronic apex locator were tested in this study. Because the ideal distance between a dental operator and a patient is similar to that of reading a book, a distance of 40 centimeters between apex locators and the cellular phone was used in this study. So the null hypothesis that the use of the communication device will not affect the working length of electronic apex locators was proved to be correct. Therefore, within the limitation of this study, it can be concluded that the reliability and stability of the electronic apex locator were not influenced when placed in direct contact with smartphone or a GSM phone. Patients or dentists can keep their cell phones in a treatment room during an endodontic therapy without disturbing electronic working length determination. These are my references. Thank you.
Thank you so much. Any questions?
No, ma'am, no question.
All right, let's proceed then. An oral presentation by Ambalavanan, Sri Ramakrishnan Dental College and Hospital, India. The topic is about efficacy of anthocyanidin pre-treatment on push-out bond strength between a glass fiber post and root dentin and in vitro study.
Yeah, am I audible?
Yes, you are. Please proceed.
Yeah, good evening, everybody. I'm going to present my in vitro study, that is the efficacy of proanthocyanidin pre-treatment on push-out bond strength.
Excuse me, doctor. My apologies. Please have your presentation on presentation mode.
Sorry, I couldn't get you.
I mean your screen. We are only seeing your desktop.
Yeah, sorry. 1 minute.
Okay.
I'm not able to get it. Yeah, am I visible now? Hello?
Yes, doctor, you are visible, but your presentation is not visible. Can you stop sharing screen? Then share your screen again and make sure to choose your presentation screen before you click share. You will see there, once you click on share screen, you will see there many windows.
Yeah, yeah.
Click. Yeah. Thank you.
Is it visible now? My
Yes,
presentation?
there you go. Thank you.
Thank you, ma'am. Thank you so much. So I'm going to present my in vitro study, which is the efficacy of proanthocyanidin pre-treatment on push-out bond strength between a glass fiber post and root dentin. This is an in vitro study which was conducted in our college, Sri Ramakrishna Dental College and Hospital, Coimbatore. So the aim of this study was to assess the influence of the proanthocyanidin application on the bond strength of glass fiber post root canal dentin using a self-etch adhesive luting system. We all know that endodontically treated teeth are weaker and are known to present a higher risk of biomechanical failure than its vital counterparts. So when this endodontically treated teeth has lost its coronal tooth structure more than 50%, we struggle to reinforce and retain such a particular coronal tooth structure. So in order to reinforce and retention of the coronal tooth structure, we generally utilize something called as a pose. It is basically to reinforce and restore the coronal structure. So previously, prefabricated poses were used, which were traditionally made of metal. Now, newer tooth-colored poses have improved the aesthetics of teeth, which has a modulus of elasticity similar to that of dentin. And among them, the glass fiber poses are very commonly used, especially the unidirectional glass fiber poses, which are embedded in a resin matrix, are easily moldable and very conveniently placed inside the root canal. So the advantages of these glass fiber poses is basically they distribute the stress over a broad surface area. And the fiber reinforced poses are also reported to reduce the risk of tooth fractures and display high survival rates than the teeth restored with rigid posts. So the glass fiber post, the glass is made up of many types. So one among them is an electrical glass. What is the use or the advantage of electrical glass? It is an excellent insulator. It is made up of a mixture of silicon dioxide, calcium dioxide, and aluminum oxide, and some other oxides of alkali metals. The product which we have used in our particular study is Everstick, which is made of interpolymerizing network of polymethyl methacrylate. This basically improves the addition to the luting resin cement and thus increases the flexural strength and fatigue strength through the reduction of crack initiation. So what can be the potential problem when we are going to lute a particular post to the dentin? We all know that the dentin has an inherent collagen network that is wet always, and that it poses an inherent bonding problem to any kind of post. So that is the durability of the bonding between the post and the dentin has always been questionable. So this, if there is a non-durability of this bonding, that leads to fracture of bond, that in turn may lead to many consequences. So basically, what causes this bonding lysis? One important concept here is matrix metalloproteinases. These matrix metalloproteinases are responsible for the collagen lysis and the destability of the bonding between the dentin and the luting agent. So proanthocyanidin, which is a biological molecule, has overcome many of these drawbacks of this matrix metalloproteinases. They basically inhibit these matrix metalloproteinases and thereby stabilize the collagen and thereby increasing the degradation resistance of the bond between the bonding agent or the luting agent and the dentin. So proanthocyanidin consists of highly hydroxylated structures that are capable of forming insoluble complexes with carbohydrates and proteins. So the materials and methods. We have used 40 single-rooted mandibular premolars that were stored in 0.1% thymol solution. Each tooth was decoronated, and then endodontic axis cavity was refined with number 2 endo-access burr. The post paste was prepared by using piezo size 3 reamer, and the canals were irrigated with 5 ml of 3% sodium hypochlorite and 17% EDTA, and finally with 0.9% normal saline. The teeth were then divided into 2 groups. Group 1, where the teeth was pre-treated with proanthocyanidin for 1 minute, and the group 2, where the teeth weren't treated with proanthocyanidin. Both the groups were then luted with the fiber post using Relax U200 self-etch adhesive system. Teeth were then stored in distilled water for 3 months at 37 degrees Celsius. After that, 1 mm slices were obtained with rotary microtome. Then the push-out bond strength testing was done with the universal testing machine. And after the fracture, the failure patterns were assessed under the stereo microscope of 20x magnification. The failure patterns were assessed basically under 5 criteria. The first one being the adhesive between the fiber post and the resin cement. Then a mixed failure pattern where the resin cement was covering from 0 to 50% of the post circumference. The third one being the mixed again, but the resin cement covering 50 to 100% of the post surface, the adhesives between resin cement and the root canal, and finally the dentine failure or the cohesive dentine failure. So these were the failure patterns that were assessed under 20x magnification. The results, as you can see in this particular table, between the group 1 and group 2, there was a standard deviation of bond strength between group 1 and group 2. When it was compared with independent t-test, we got a p-value significantly greater than, indicating that the group 1 had significant high bond strength than the group 2, which was not treated or pre-treated with proanthocyanidin. So these are some of the pictures from our study. Discussion. Fiber posts are more often used for their advantages, as I was mentioning in my introduction, like ease in handling, reduced chair side time, and for being less technique sensitive in compared to the cast metal post. So there are innumerable number of bonding reasons for bonding failures, and the main one being the collagen degradation. So basically, these matrix metalloproteases, they degrade the collagen and then they cause the bonding failure. The results of this study showed that a highly significant difference existed between the mean bond strength values between the experimental group, that is group 1, where the pre-treatment was done with proanthocyanidin, and the control group where there was no pre-treatment. The application of mildly acidic self-etch adhesive activates the MMPs, actually resulting in progressive proteolytic degradation of exposed collagen fibrils within the hybrid layer, and thus resin-dentin bond failure over time, which could have possibly led to the lower bond strength values in group 2. So what are the advantages of the proanthocyanidins? They are basically they form insoluble complex hydrates or hydroxylates with the collagen, and that helps in the cross-linking of the collagen. And they are also an anti-proteolytic agent, which basically inhibits this matrix metalloproteinases. So on application of this proanthocyanidin, basically reduces the destabilization of the collagen by inhibiting the matrix metalloproteinases, and thus we got a higher bond strength with respect to the group 1 than the group 2. In case of group 1, under stereo microscope, the failure pattern was under mode 3 or mode 4, which was predominant, which was basically where the post or the luting cement was detached from the entire dentin. And failure pattern 1 is adhesive resin and post, between the adhesive resin post. Further long-term clinical studies are basically required to probe into the advantages of using proanthocyanidin. Success and failures of post-endodontic restorations after the use of proanthocyanidin over a long clinical period will help us analyze the durability of this biological cross-linking agent. So thank you all.
Thank you so much.
Hello. Yes, sir. Hello.
Yes, go ahead, ma'am.
Yeah. Can you please describe how the pre-treatment was done with proanthocyanidin?
Ma'am, proanthocyanidin, we got the grape extract seed powder, ma'am, 96%. It was then diluted according to the almost 95 ml of water we had added, and then we diluted the percentage of the grape seed extract. The grape seed extract was obtained from Chennai, ma'am, from a biochemistry lab in a particular institute, and then it was basically diluted and it was applied inside the root canal dentin.
For how long it was applied?
And for 1 minute, ma'am. Basically, the studies are there for 10 minutes, 5 minutes, 3 minutes, and 1 minute. The 10 minutes, why we didn't choose, because when we come to the clinical practice or the practical purpose, the 10 minutes usage cannot be applied, ma'am, because we cannot make sure, we cannot make a patient wait for 10 minutes on the chair and then we cannot do it. So we wanted to check for the minimum amount of time. So what was like 1 minute or 3 minutes? And there are many studies which have proved that for 3 minutes and 1 minute, it's more than enough if you're going to use higher concentration of proanthocyanidin. So, but the 3 minutes we are still under investigation. We have another study where we have applied for 3 minutes and 6 months storage period. Here we have just stored the tooth only for 3 months. Another study we are conducting where we are storing the entire teeth for 6 month duration and 3 minutes of proanthocyanidin.
Okay, thank you so much.
Thank you.
Thank you. Now, the next presentation is an oral presentation by Dr. Shika Jaiswal. So, Bharti Dental College and Hospital, Meerut, India. Holistic dentistry, a step beyond conventional realms.
Am I audible?
Yes, you are. Please proceed.
Is my screen visible?
Yes, it is. Please proceed.
Well, a very good afternoon to all. Looking at this picture, who would have imagined a world like this? The COVID-19 situation has turned our lives upside down. But if there's one positive thing which it has taught us, it is to go back to our very roots and start reliving our lives holistically, be it in the form of clean eating, nutritious diet, or by incorporation of kadas and golden milk in a daily diet, by following yoga or exercise as a part and parcel of a daily routine. Even our Prime Minister Narendra Modi, he did not even follow these holistic principles himself, but he made sure that it is incorporated in every sphere of life. Even the National Education Policy 2020, which focuses on holistic and integrated learning. Then why has dentistry remained untouched? There is a need for sensitization and a need to take a step beyond the conventional realms. Holistic dentistry has been known by various synonyms like alternative, natural, or biocompatible dentistry. But what exactly is it? Well, the term holism was coined by Christian Smuts in 1962, but this concept is deep-rooted in India by the very system of Ayurveda, which is one of the most holistic system of medicine. The beliefs, concepts, and the science which we had discovered ages and centuries ago, the world is discovering now. Take, for example, intermittent fasting. This age-old custom and belief in India, which we had been following so religiously, got its recognition when Yoshinori Oshumi won a Nobel Prize for his work on autophagy and said that yes, fasting can even prevent the growth of cancerous cells by the mechanism of autophagy. This was the year 2017, and after that, this trend, this particular word got so many Google searches. Literature is filled with evidences that poor oral health is related to occurrence of systemic diseases, even that of cardiovascular, Alzheimer's, or rheumatic disease. That is why the holistic principle believes in a whole body approach and lays prominence to oral health in relation to individuals' physical, emotional, and spiritual health as well. So how do we practice holistic dentistry? By amalgamating traditional with modern dentistry, using more natural and safer alternative methods, paying attention to the patient's physical and mental health, taking care of anxiety, stress, fear, paying a keen attention to nutrition, focusing on preventive care, using the maximum non-toxic and biocompatible materials, and all this with due consideration to society and environment as a whole. So what do we do when a patient with caries, with gingivitis, or any other dental problem comes to us? We usually give symptomatic treatment. As a holistic dentist, we need to go to the root cause and eliminate the root cause rather than just treat the symptom itself. We need to see whether it is because of poor systemic health, whether the condition is because patient's apathy towards oral hygiene, maybe he's stressed, he has poor mental health. How many times as a dentist we refer a patient to a psychotherapist or a nutritionist for counseling? This is what we have to look into. We can also adopt many natural and alternative methods. Just for example, Ayurveda. 5,000, more than 5,000 varieties of medicinal plants are there in India, like turmeric, neem, and these have very active constituents like curcumin, nimbin. All of them, they have antiviral, antifungal, antibacterial, and immunomodulatory properties. And that's why they're so helpful in treating oral diseases like oral ulcers, which can be managed by ashwagandha. Or for pre-malignant lesions, we can use aloe and curcumin. And the whole literature is abundant with controlled trials and with studies like for that of Kadian and Mohammad et al. And they have established the efficacy of these Ayurvedic alternatives which are almost similar to that of the conventional counterpart. Just for example, Triphala mouthwash, a 6% Triphala mouthwash is almost equally effective to that of 0.2% chlorhexidine. Along with that, it has hardly any side effects. Similarly, allium cetium oil, very good alternative for omeprazole if you're using for pulpotomy of the primary teeth. Then there's curcumin, which can be used as an intracanal medicament, neem as an irrigant, and these natural alternatives, they have very good efficacy against the microbial species which are resistant, like Enterococcus faecalis. And a very simple preventive protocol, oil therapy, which one of our colleagues, Dr. Upasna, had just discussed. Such a simple preventive therapy, but how many times do we advise a patient for it? Apart from Ayurveda, homeopathic remedies are also there. Now, usually considered by most, it is considered like a placebo therapy by many. But there are trials which have shown that these homeopathic remedies like calc phosphoricum, merc solubilis, and natrum phosphoricum, they are really helpful in treating more than 80% of dental conditions like delayed tooth eruption, lichen planus, and gingivitis. Definitely, if the patient believes in it, and we can definitely go ahead in certain conditions which are not very much they do not have a they do not respond to conventional therapies like that of lichen planus. Then there's acupuncture. This natural alternative, it reduces the perception of pain signals by release of natural painkillers. And even WHO in its Geneva Convention of 2019 has recommended and suggested acupuncture in treatment of many oral conditions, oral diseases like the trigeminal neuralgia, TMJ conditions, xerostomia, paresthesia. And the studies have shown that they're really helpful in these conditions. Then there's hypnosis. Many link it with swinging pendulums or magic. It's actually a science, a form of psychotherapy, which induces trance-like state in patients and is really helpful in treating some conditions like inducing analgesia or in bruxism or in intense gag reflex, or patients who have dental phobia. And they're very useful in periodontic patients. There's certain training also which we can undergo for practicing hypnosis. In fact, there are many studies like by Karaskoe et al. They have shown that hypnosis, when it is combined with conventional behavior management, it helps to reduce the heart rate, pain, and anxiety. So many yoga poses like Halasana, Sarvangasana, Setubandhasana, they help in maintenance of oral health and prevention of oral diseases. How? Many studies have shown that yoga reduces stress, improves immune system, improves the lifestyle, is more natural, and thus helps in the prevention of dental diseases. Prevention of dental diseases can also be done by following good nutrition. We all know that a balanced diet goes a long way in preventing conditions, dental diseases like caries is there, and deficiency diseases like hypoplasia. We know that nutritional intake and oral health of mother directly affects the nutrition and oral health of fetus. Why don't we as oral health professionals develop some referral protocol to nutritionists who can educate women who are planning pregnancies, or who can tailor dietary counseling or conduct dietary assessment? It is said that an educated mother means an educated nation. So if we educate the mother about the relevance of oral maintenance of oral hygiene, the whole generation will be educated. There are articles by Olson et al. Which show clear relation between oral health, gut health, and systemic health. In fact, it has been seen in many studies that increase in Porphyromonas gingivalis is directly linked to occurrence of metabolic disorders like inflammatory bowel disease and even colon cancer. What can we do about that? Well, the microbiota of oral cavity as well as gut can be taken care of together by use of probiotics. Prescribing the latest probiotic containing toothpaste or the lozenges which have lactobacillus and bifidobacterium species in them. They're very promising agents for maintenance of oral health, and they're very effective against biofilm dependent diseases like caries, halitosis, and candidiasis. The new adage is probiotics per day does keep a doctor away. Then there are essential oils like lavender oil is there, orange peel oil is there. They all help in aromatherapy. And there are trials by Venkataraman and Soni and many other studies which have shown that inhalational aromatherapy, it does have positive effect in reducing anxiety, blood pressure, oxygen saturation, and even the pulse rate if administered before surgery or a child's dental visit. How can advances be included to practice holistic dentistry well? Every advancement in a dental material or in the technology which reduces the harmful impact or hazardous impact on the patient's health is a step towards practicing holistic dentistry. Take, for example, diagnostic imaging. Following the principle of ALARA, choosing digital imaging over conventional imaging, choosing CBCT over CT. Go a little ahead. Choosing small FOV CBCT or large FOV CBCT. What are we doing? We are reducing the patient's X-ray exposure. So we are reducing the hazardous effect of these X-rays on the patient's health. So we are following a holistic approach. Then there are so many virtual reality headsets very popular in US. They can be used so as to divert the patient's attention to more cartoons or beautiful pictures or sceneries. And studies are there which show, like by Valverde et al., they have shown that virtual reality does help a lot in the management of anxiety and pain in dental treatment, especially in the case of children. Then we can also take help of novel devices for anesthesia, like the VibraJet is there, computer control local anesthesia delivery system, jet injectors. All of them, they help in administering painless anesthesia. They help in reducing the stress, managing phobic patients, patients with dental anxiety, and they just make the treatment comfortable and reduce the impact of the dental treatment on the patient's stress level and health. Holistic dentists, we should be very careful in choosing the materials. Choose the most non-toxic and biocompatible materials. By practicing a mercury-free dentistry, by choosing zirconia crowns over all metal crowns, what we are doing, we are not only making sure that we reduce the hazardous impact of these materials on the patient's health, but also on the environment. We can go for a zirconia implant as compared to that of metal implant, which are zirconia, they're zero grade cytotoxic metal implants. They have a reduced biocompatibility. If you're going for surgeries, why don't you choose the latest bioresorbable plate system, the most biocompatible plate system which is available? Then if we have to put grafts in surgery, try to choose autogenous grafts which are most biocompatible. And in case you do not want to harvest from the patient's bone, you can take heed of the latest smart dentin grinder which can harvest these grafts from the extracted tooth of the patient. Now, as responsible citizens, we also need to make sure that we lessen the impact of dental practice on the environment. How can we do that? Again, taking help of the latest digital technologies, going paperless, using the newer biodegradable products like the suction tips, which are there made up of from bamboo, then using reusable materials and products in a practice as compared to disposable materials. What we are doing, we are following an eco-friendly dentistry. So we can make these small changes and just uplift the practice. So you can just go on and on this topic. It is a never-ending topic. In this particular session only, we have, I think, 4 papers which have been discussed on the natural alternatives. But in short, if you really want to upgrade your practice to the next level, holistic dentistry is the way ahead. Thank you.
Questions?
Thank you, Dr. Shikha, for the tips on holistic dentistry. And it is really nice presentation. Thank you.
Dr. Asta, thank you so much.
All right, let's move to the next oral presentation by Dr. Deepashri Tikam, VYWS Dental College and Hospital, Amravati, India. topic is about advanced nanomaterials emerging as boon for dental tissue regeneration. Dr. Tikam?
Yes, ma'am, I'm sharing.
Okay.
Can you see the screen, ma'am?
Yes, I do. Please proceed.
Good afternoon to everyone. My topic of presentation is advanced nanomaterial emerging as a boon for dental tissue regeneration. As we know, nanomaterial technologies can be used to fabricate high performance biomaterial tailored with physical, chemical, and biological properties. They are therefore an area of interest for emerging biomedical technologies such as scaffolding, tissue regeneration, and controlled drug delivery. Nanomaterials in tissue engineering explores the fabrication of a variety of nanomaterials and the use of these materials across a range of tissue engineering applications. Now, what options are there for the production of these smart materials? Number one is material synthesis. In this, we produce a synthetic material matching the morphological properties to the natural dental tissue. Number two is a biomimetic approach. In this, we replace the lost dental tissue followed by the nature principle and producing a biomaterial resembling their properties very close to the replacing tissue. And the third one is tissue engineering. In this, we use a regenerative medicine and tissue engineering approaches for replacing the lost dental tissue by regeneration. Now, for this, there are two key approaches. Number one is the top down approach. Number two is a bottom up approach. Now, in a top down approach, to simplify, we are breaking down a bulk material into a nanosite structure in which we have nano composites, glass ionomer cements, or nano impression materials. In a bottom-up approach, it is like building up a material from atom to atom, molecular to molecule, and a cluster to cluster. We are building a material. Basically, bottom-up approach is used for all the regenerative procedures in nanotechnology. Now, this nanostructured materials, how they are used for tissue engineering. Number one, we can use their chemical component and their bioactivity. Number two, we can use it as a drug or signaling molecule agent. Number three, we can use them to build a scaffold for tissue regeneration. Now we will see one by one. First, we will use their chemical component for bioactivity. Now, what we mean by using chemical component, that is, we use this properties of calcific phosphatic particles or the hydroxyapatite particles, we incorporate them into a hydrogel based scaffold and we put them to the healing site wherever we want, whether we want in a bone or whether we want it in a any surgical area, whatever. The property of this calcific phosphatic material, they have various properties like they help in gene therapy, they have antibiotic property, they have anti-inflammatory property, they are growth factors. So we are utilizing these advantages and incorporating it into developing the regenerating the tissue. The second is by drug delivery. Now, what is drug delivery? It incorporates a molecule once released will enhance the regenerative capabilities of the tissue. In this, we use nanospheres, nanotubes, or nanocapsules. Now, these materials encapsulate a polymer matrices which show a slow and prolonged release of signaling molecules or drugs. Because of its low molecular weight, it forms micropores and microspheres and release the drug slowly. They also enhance the therapeutic activity by prolonging its drug's half-life. It improves its solubility because of the hydrophobic drugs. It reduces the potential of immunogenicity, and there is a sustainable release of this drug, thus reducing the toxic side effect of the drugs, as well as we can also control the administration frequency of that drug. In addition, it can passively accumulate in specific tissue to enhance its permeability and retention. Thus, it is quoted as a smart drug delivery system, a next generation to go. Then coming to the scaffolds. Now, for making a nanostructural scaffold, there are three techniques. Number one is electrospinning. Now, for an electrospinning system, we require a setup of syringe, blunt end needle.
Hello.
Yes, ma'am. Hello. Hello.
Yes.
Ma'am, what happened? You said something.
No, I did not. For those who are not presenting, please make sure that you have your mic muted. Thank you.
Okay.
Please proceed.
Okay. For the electrospinning system, we require a electrospinning setup which is composed of a syringe with a blunted needle. Then we have a ground electrode as a collector, and a high voltage is applied. And we can see at a low current, we can see this nano spinning area. These are the nanofibers delivered, and this is how it will look. Now, what happens? This nanofiber have increased surface area to volume ratio, which increases its interconnectivity with the tissue. It supports cell adhesion, proliferation, and differentiation. And exactly it mimics the extracellular matrix present in our body. So, along with it, it is biocompatible and biodegradable. Then the second approach is self-assembly approach. Now, in this, there is a spontaneous interaction between the two components to produce a single larger functional structure. Now, this enhances or decreases the structural integrity of nanofibers depending upon its use. And also, when they come in contact with the hydroxyapatite or calcium phosphate, it will help in formation of bone or the tooth structure which we require. The alignment formed by this material will be similar to that of the bone crystals present in our natural jaw. The third is the phase separation. For the phase separation process, we have a single homogeneous solution which is made thermodynamically unstable, and then we will have a phase separation of polymer rich phase and a solvent rich phase. Now, this polymer rich phase is used as a scaffold, and it can be about to a diameter of 150 nanometer. And this three-dimensional scaffold with a well-defined spores can be fabricated as per our needs, because they have higher surface area and they have a greater mechanical strength, biocompatibility, and mechanical stability. So, for the clinical application of these scaffolds, hydrogel-based scaffolds are being used on a most commonly used, or basically they are used. So, for this, we have hyaluronic acid-based hydrogel. These hydrogel are biocompatible and they are safe for human dental cell therapy. We have hyaluronic acid, which can be in which we can incorporate platelets. This will help in deposition of mineral matrix near the human dental pulp stem cells. Also, we have recombinant human collagen, which is available as Pura matrix, which will help to form new tubular dentin after a 21 days follow-up. Then we have fibrin and chitosan-based hydrogels, which are biocompatible. And because of chitosan, it is having its antibacterial effect, and it also stimulates type 1 and type 3 collagen fiber production. We have enzyme clean hydrogel. It will also help in production of a soft tissue, which is similar to that of dental pulp. Then we have chitosan-based hydrogel. This will, it was a case where they reported that chitosan-based hydrogel improve the regeneration of enamel in cases of dental erosion. So, from this, we can conclude that the impact of nanotechnology on drug delivery has helped to improve the efficacy of available therapeutics and will likely to enable the creation of entirely new therapeutic entities. For tissue engineering, nanotechnology has also opened the door to new approaches that could stimulate the reconstruction of complex tissue architectures. These are my references. Thank you.
Thank you. Questions?
No questions, ma'am.
Thank you.
All right, great. Next, let's proceed to the next presenter. Oral presentation by Dr. Tina Shithal Joza, AB Shetty Dental College, India. Topic is nano silver, the silver lining for calcium silicate-based cement, rather. Good afternoon, ma'am. Good evening, ma'am.
Good evening. Am I audible?
Yes, you are. Yes, please proceed.
Good evening, respected chairpersons and my fellow colleagues. The topic of my presentation is nano silver, the silver lining for calcium silicate based cement. As we all know, nano silver or silver nanoparticles, which ranges between the size 10 to 100 nanometer, is one of the most commonly used antimicrobial agent. Its small size and large surface area makes it a potent antibacterial agent whose effects are seen even at a low filler level.
So its incorporation into calcium silicate-based cements have been reported in previous literatures. Calcium silicate-based cements have been mainly developed as root and filling materials, mainly because they are hydraulic, that is, it can set even in the presence of moisture or blood. But even though it has got good properties, there are some inherent drawbacks, which include high costs, a longer setting time, like the commercially available MTA, which has a longer setting time of 2 hours 45 minutes. And also an important aspect here is a limited antibacterial activity. Therefore, a lot of antimicrobial agents like silver nanoparticles and some few accelerants to accelerate the setting time has been incorporated into calcium silicate-based cements. Nonetheless, limited studies still exist in the literature that reveal any adverse changes in the chemical properties of calcium silicate-based cements when these accelerants or nanoparticles are added. One characteristic whose change would be of concern is the dimensional stability, because it is likely related to its ability to seal the root end. Another attribute would be the alkalinity, because any changes in the pH would be related to the change in the antibacterial action and also the release of calcium ions. And we all know calcium ions is very much required for hard tissue formation. So neither of the clinical, neither scenario would be clinically acceptable here. Therefore, the purpose of my study was to evaluate the influence of adding calcium chloride and silver nanoparticles in terms of pH, calcium ion release, and dimensional stability on a low temperature production based experimental calcium silicate based cement. Here, calcium chloride was added to decrease the setting time, and silver nanoparticles have been added for antimicrobial activity. Coming on to the materials and method, a series of experiments were initially performed to determine the most appropriate concentrations of the ingredients of Portland cement to produce the calcium silicate component, and for which silver nanoparticles were incorporated, and all of these components were sintered at 100 degrees Celsius, and the liquid here used was calcium chloride. Elemental analysis and powder microstructure was performed using a field emission scanning electron microscope to confirm the presence of oxides and silver nanoparticles in the final powder. So the groups were group 1, which was the experimental cement, and group 2, and in group 2, commercially available MTA, that is pro-root MTA, was used. So the accelerated setting of the cement was confirmed by using Gilmore needle apparatus, which confirmed a short setting time of around 6 to 7 minutes. For the pH measurement, the powder and the liquid were mixed to get a putty consistency, as shown in the picture here. And the material then was placed in polyethylene tubes, which measured 3 millimeter in diameter and 1 millimeter in length, after which a digital pH meter was used to determine the initial pH as well as the pH at 24 hours, 48 hours, and 7 days. Calcium ion release analysis was done using atomic absorption spectrophotometer, which equipped with a hollow calcium cathode lamp, and was evaluated. The calcium ion release was evaluated at 24 hours as well as 7 days. Dimensional stability was tested according to the ISO standard. After mixing, the samples were transferred to the molds measuring 6 millimeter height and width of 3 millimeter. The initial length and the length at 30 days were measured using a digital caliper. After 30 days, the dimensional stability was measured as the change in length after 30 days by original length. And in accordance to ISO and ADA standard, the results must not exceed 1% of contraction or 0.1% of expansion. The results were as follows. Under the field emission scanning electron microscope, there were peaks for the powder microstructure showed a coarse and irregular photograph. And in case of pH analysis between the groups, both the groups remained alkaline throughout the study period. However, at 30 minutes, the pH of the experimental cement was more alkaline than MTA. Subsequent readings at 24 hours, 48 hours, 7 days, there was a significant increase in the pH of MTA when compared to the experimental group. Comparing the calcium ion release at 24 hours and 7 days, there was good amount of calcium release between the in both the groups, but the experimental group showed a significant increase in calcium ion release at 24 hours, whereas at 7 days both were similar. The dimensional stability of the groups at 30 days showed that in group 1, there was slight contraction, but it did not exceed 1% of the contraction of the results, which is specified according to the ISO standard, whereas the MTA showed a slight expansion, which was also within the limits of the ISO standard. Coming on to the discussion, addition of calcium chloride and silver nanoparticles to the experimental calcium silicate-based cement showed favorable results, though the pH was reduced, but alkaline pH was maintained throughout the study period. This was in accordance to Garcia et al., who evaluated the pH of Portland cement incorporated with silver nanoparticles, and they concluded that adding silver nanoparticles to Portland cement maintained the pH and did not alter the pH. Fridlin et al. Reported that the usually reported pH of 12 to 13 of calcium silicate-based cements may slightly decrease over time. That means it will not remain at 12 to 13, it can decrease. Therefore, the advantage of having an alkaline pH to maintain a bacteria-free environment would be reduced. Therefore, in this case, we have incorporated silver nanoparticles so as to maintain a bacteria-free environment. The additional calcium via the calcium chloride liquid boosted the calcium ion release. As in literature, it's been said that calcium chloride has a low pH of 4.4, and this did alter the pH of experimental cement, but it did not alter significantly the calcium ion release of the cement. This was in accordance with the Bortolizzi et al., where in a study he revealed that the addition of calcium chloride improved the calcium release properties of commercially available MTA cements. The dimensional stability of both the cements was favorable, and this was in accordance with the ISO and ADS standard, which says that the results must not exceed 1% of contraction or 0.1% of expansion. And our experimental cement did not exceed 1% of contraction, but MTA showed slight expansion, which was also acceptable. Therefore, to conclude, I would say that every cloud has a silver lining. Here, I would refer I would say the cloud would be referred to the calcium silicate-based cement, and the unpleasant features of calcium silicate-based cement would be a decreased an increased setting time and limited antimicrobial activity. With this experiment, I would say that incorporating silver nanoparticles had already improved the antimicrobial activity. It also shortened the setting time. It contributed to favorable pH and calcium ion release, and also contributed to favorable dimensional stability. I would say silver nanoparticles are definitely the magic bullets for calcium silicate-based cements in endodontics. These are my references. Thank you.
Thank you,
Questions?
ma'am. No questions, ma'am. Thank you.
All right, let's proceed with the next oral presentation. Chiranjeevi Jayam, India. Topic is about the linear enamel hypoplasia, a case report. Yep, I can see your screen. Please proceed. Hello? Sir, we cannot hear you. Doctor? Hello? No audio? Hello? Doctor, I'm sorry, but we cannot hear you. I'll get back to you, doctor. Please try to fix the audio. Right, for now, we will call Dr. Jayam after. Next, a presenter, oral presentation by Apur Sharma, Subharti University, Middle India.
Yes, ma'am. Ma'am, am I audible?
Yes, you are audible. Please go ahead and share your screen.
Yes, ma'am.
Right, perfect. Now I can see your screen. Please proceed.
Ma'am, please may I start?
Go ahead.
Jai Hind and a very good afternoon to respected judges. Today I, Apur Sharma, and my fellow batchmate Vandana Singh will be presenting our paper on the topic immediate dentine sealing. Management of the dental tissues between the preparation and the restorative treatment plays a pivotal role in the success of adhesive restorations. Tooth preparation results in the removal of a layer of enamel, thus generating significant exposure of dentinal tubules, making the tooth susceptible to post-operative sensitivity, bacterial infiltration through the passage of microorganisms through the tubules, and create a potential for subsequent irritation of the pulp. An effective way to overcome these problems and protecting this pulp-dentine interface is through stabilizing the exposed dentine tissue that can be achieved by a novel approach of immediate dentine sealing. Let's understand what is immediate dentine sealing. It is sealing of the dentinal tubules just after tooth preparation and prior to impression making. So, how it's done? After the tooth preparation is completed, we immediately apply the dentine bonding agent to the exposed dentinal tubules, followed by light curing, and then the impression is made. What's the purpose of doing IDS? We all know that freshly cut dentine is an ideal substrate for bonding as it is non-contaminated, and immediate sealing of dentinal tubules decreases the sensitivity and prevent microbial leakage by occluding the dentinal tubules. It also significantly improves the bond strength with the luting cement. Numerous studies have been published evaluating the bond strength post-immediate dentine sealing and have found that immediate dentine sealing increases the bond strength 3 to 5 times when compared to delayed dentine sealing. So which adhesive system should be used? Pascal Magne in his studies have showed that conventional 3-step total edge dentine bonding agent is the most reliable long-term option and is recommended for IDS. But there are other studies which have found that 3-step etch and rinse system and 2-step self-etch system are superior to single-step system with regard to durability, aging, and bond strength. Single-step self-etching adhesives have been accused of being susceptible to degradation if water stored and because of the increased hydrophilicity of their interface. Urate and Sahin et al. In their recent studies have suggested that total etch and self-etch adhesives have a significant effect on immediate dentine sealing. The ideas showed significantly higher microtensile bond strength than delayed dentine sealing in 3-step total etch and 2-step self-etch adhesives.
Now, an important question which may arise is whether these dentine bonding agents interact with the impression materials used. The answer to this question is yes. Various studies have shown that the presence of superficial oxygen inhibition layer on the surface of dentine bonding agent can interfere with the polymerization of elastomeric impression material, leading to defective impression. So what can be done? Various methods such as additional polymerization of the dentin bonding agent with glycerin jelly, that is called as air blocking, and pumicing of the surface gently with a rubber profit cup using a slow speed handpiece have been suggested for the removal of oxygen inhibition layer. Bruzy et al. Have suggested that covering the immediate dentin sealed layer with a liner that is flowable composite resolves the issue of interaction with the impression materials. Whereas Gigi et al. Have suggested the use of cotton pellet soaked in alcohol to prevent the interaction with the impression material. Now, answering the question, what provisional materials can be used over the ideal sealed surface? Studies have shown that the direct bisacral-based provisional materials and resin-based interim cements bond strongly to the immediate dentin sealed substrate, hence should not be used, as removal of the provisional material proves to be demanding and sometimes has to be cut off the tooth, which jeopardizes the integrity of the tooth preparation. There are studies which have demonstrated that if immediate dentin sealant is applied, regardless of the use of eugenol containing or eugenol-free provisional luting agents, interim materials do not influence the adhesion quality of the resin cements. A contaminant-free substrate is a necessity for optimum bonding. Therefore, selection of appropriate conditioning method is of utmost importance. Meghna et al. Have suggested that before placing permanent restoration, conditioning of the dentin with airborne particle abrasion should be employed. Dillenberg et al., on the other hand, have suggested additional etching with phosphoric acid had a positive impact on the conditioning of sealed dentin, whereas Falkenheimer et al. Have suggested the combination of pumicing and airborne particle abrasion to be an efficient conditioning procedure. Immediate dentin sealing is indicated in cases of short clinical crown height and high angle of convergence. Immediate dentin sealing provides efficient retention with both resin cement and glass ionomer cements. A study by Durate et al. Have shown that immediate dentin sealing increases the bond strength of self-adhesive resin cement. Apart from increased bond strength, one major advantage that immediate dentin sealing provides is the reduced tooth sensitivity. Numerous studies have shown that early sealing of the dentinal tubules provided by the immediate dentin sealing technique reduces sensitivity during the provisional phase and after cementation. This is a promising strategy for enhancing comfort and treatment satisfaction. The various advantages offered by immediate dentin sealing are: it is an easy chairside procedure. There is no need for additional equipment. It enhances the clinical performance, and it can be easily incorporated in day-to-day practice. So finally, to conclude, immediate dentin sealing is a novel approach to increase the bond strength, decrease the post-operative sensitivity, increase retention of short clinical crowns, and prevent bacterial infiltration, and should be routinely and can be effectively used in day-to-day clinical practice. Thank you.
Questions?
Yes, ma'am, how can the immediate dentinal sealing increase the retention in case of short clinical crowns?
Ma'am, actually, there were many studies, one by Pascal Magne and other by Durati, which have found that there is 5 times increase in strength as compared to delayed dentine sealing. And this is increase in strength as responsible for the increased retention of short clinical crowns, because up to 3 to 5 times increase in strength, microtensile bond strength have been obtained. And it has been published and ma'am present in the literature.
And what would you recommend generally for immediate dentin sealing?
Ma'am, recommend in the type of adhesive system.
But yeah.
Ma'am, though earlier Pascal Magne said that 3-step etch and rinse was more effective as compared to 2-step or single step, but recent studies have suggested that 3-step and 2-step techniques both are equally effective, but single in all-in-one should not be used. Because it has got a lower value, lower results as compared to the other.
Okay, thank you so much.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you so much. And let's proceed with the next presenter. Poster presentation by Dr. Sneha Patil, VYWS Dental College and Hospital, Amravati, India. Topic is cryotherapy in endodontics. Dr. Sneha Patil.
Yes, ma'am.
Oh, hi.
Hi.
You can go ahead and share your screen, please.
Yes, ma'am. Ma'am, shall I start?
Yeah, go ahead, please.
Good evening, respected teachers and one and all present here. Myself, Dr. Sneha Ramakan Patel from VYWS Dental College and Hospital, Amravati, India. Topic for my poster presentation is cryotherapy in endodontics, renewing hopes in painless dentistry. As we know, one of the most common reasons for which patients seek dental treatment is pain. And cryotherapy has gained popularity in recent time to reduce pain in various fields of dentistry. In endodontics, we are using cryotherapy for pulp vitality testing by various measures like carbon dioxide ice and ethyl chloride spray, etc. But now, according to the recent advances, cryotherapy is used to reduce post-endodontic pain, to reduce inflammation and hemorrhage in vital pulp therapy. It is also used in the process of manufacturing process of endodontic files. Now, we'll see the above three applications one by one. The first one is root canal treatment. During root canal treatment, final rinse with 2.5 degrees Celsius of cold saline reduces the external root surface temperature by 10 degrees Celsius. This will affect the peripheral nerve endings by reducing the activation threshold, which further lowers the conduction velocity of pain. In case of vital pulp therapy, shaved sterile ice of 0 degrees Celsius is placed over the exposed pulp tissues along with entire tooth surface. After approximately 60 seconds, this ice will melt and then it should be removed with high-speed suction followed by proper restoration. In such procedure, cryotherapy will help in reduction of the adherence of leukocytes to capillary wall, reducing the number of migrating cells to the injured tissues, which will decrease the endothelial dysfunction and it will help in the reduction of the inflammation. Now, this cryotherapy also causes vasoconstriction, which also helps in limiting the inflammatory changes. The third application is endodontic instruments. Now, this cryotherapy is also used in manufacture process of NITA endodontic files. In this procedure, liquid nitrogen at minus 185 degrees Celsius to minus 196 degrees Celsius can be used. Now, there are further two types of these cryogenic procedures. One is shallow cryogenic procedure, and other is deep cryogenic procedure. Amongst them, dry deep cryogenic treatment is most commonly preferred, and it gradually decreases the temperature in order to avoid thermal shock. As a result of this cryogenic treatment, nitrogen atom it deposits in the interstitial spaces within the atomic lattice, which will increase the lattice strain. Now, there is also complete transformation of austenitic phase to martensitic phase, which decreases the internal stresses within the alloys. Thus, it will help to increase the cyclic fatigue resistance of the files. It will increase the strength, micro hardness, as well as it will also increase the wear resistance of endodontic NITAF files. Thus, finally, I would like to conclude that cryotherapy is a simple and cheap supplementary method for minimizing post-operative pain in root canal treatment, for controlling hemorrhage as well as inflammation in the vital pulp therapy. It can also be used in the manufacturing process of the endodontic files to improve its physical properties. Thank you.
Yeah, thank you, Sneha.
Thank you, ma'am.
Thank you. Next, let me call on our last presenter for today. Purva. Title about advancements in pediatric and adolescent dentistry. Dr. Apurva?
Yes, ma'am. I can hear you.
Yep. You can go ahead and share your screen, please.
Yes, ma'am. Sure. Okay. It's right here.
Am I visible?
Yes, it is. Please proceed.
Yeah, just a minute. Ma'am, okay. Shall I start?
Go ahead.
Advancements in pediatric and adolescent dentistry. COVID-19 marked a significant age from several perspectives. For all the dentists there, it is the need for revising protocols was done, since the personnels are is always in close proximity to the patients and are more prone to COVID-19 exposure through saliva and aerosols. Such revisions are expected to increase the safety of the patients and the dentists. One additional factors uh, for the pedodontists and the orthodontics have to deal with the psychology of the patient and their parents. Few measures taken by us are child-friendly PPE kits, washing of hands and forearms, pre-visital behavior guidance, that is making sure that the children is made aware of the dentist appearance and what they should expect to reduce anxiety, spaced waiting areas, fuming of and sanitization, etc. Regarding this, I would like to shed some light on three advancements in pediatric and orthodontic dentistry which caught my eye. One is the glutathione reducing SDF discoloration, teledentistry, and nanorobotics. Silver diamond fluoride discoloration substance that is glutathione. As we all know that SDF is one of the methods for caries management. It is directly applied to the cavities of the teeth, which instantly stops the process of the decay with discoloration. Although stained, treated teeth are no longer susceptible to pain, discomfort, or sensitivity or typically associated with well-established cavities. Still, it would be better if there is least discoloration. SDF is considered as an efficient, cost-effective material that can be used on deciduous teeth and permanent teeth. It is non-invasive and will reduce the aerosol formation compared to other invasive techniques, reducing the risk of COVID transmission. An alternative method has been developed which may decrease the staining from SDF from potassium iodide is glutathione. It is considered one of the most common intracellular non-protein thiols that acts as reducing agent in mammalian cells. It is an antioxidant that can act as a metal chelator and radical quencher. It was proven in the literature by spectrometric measurement of the color changes that SDF plus GSF was effective in decreasing the color changes, especially on the enamel and to a lesser extent on the dentine than any other substance used before. Hence, it makes SDF more acceptable to the parents and children, reducing the risk for COVID-19 as well. Now, teledentistry. Till now, we all know what teledentistry is. It is the combination of telecommunication and dentistry involving the exchange of clinical information, images for dental consultation and treatment planning. The Occupational Safety Health Society has placed dental healthcare professionals in a very high exposure risk category, stating that dentists working in COVID-19 for the dentist to manage dental emergencies during lockdown period. Now, can we use teledentistry in pediatric and orthodontic consultation? Yes, we can. First, teledentistry was used by NASA to have the dental treatments of the astronauts, and later it was used by US military. The technological innovations in high-speed internet networks can be applied in the fields of medicine and dentistry. In this pandemic, teledentistry can prove to be of great help for the patients with dental emergencies. In the times of the COVID-19 lockdown, minimizing patients' visit to the dental clinic, therefore this technique became popular. It can happen in two forms: real-time consultation, which include dentist to internet and directly to the patient, and other is store and form, that is dentist to internet to a specialist consultation. Now, the advantages of teledentistry. Apart from the usual, it can also be used to reduce the anxiety of the patient and their parents by giving them a pre-behavior video and preparing them for the visit. It has the ability to improve the access and delivery, the lower cost of the oral health, eliminating the I'm sorry, am I audible? Hello?
Yes, ma'am, you're audible.
Okay. So it helps people to receive specialized health care measures in the remote parts of the world due to advancement in the field of the telecommunication. Next is the nanorobotics. Nanorobots are theoretical microscopic devices measured on the scale of nanometers. When fully released from the hypothetical stage, they would work as an anatomic, molecular, cellular level to perform tasks in both medical and industrial fields. The goal of the nanorobotics is to incorporate robot functions, that is sensing, processing of the information, some form of the action, and possibly communication at the scale that is much smaller than a single cell or microprocessor. Nanodental techniques involve genetic engineering, tissue generation procedures for major tooth repair. Power source for these nanorobots will come from the metabolizing local glucose oxygen and externally subacoustic energy. Reconstructive dental nanorobots selectively and precisely occlude specific dentinal tubules within a minute using native biologic materials, offering the patient a quick and permanent cure from hypersensitivity. It can also be used in multiple nanorobots can be used in a unison for cavity preparation and restoration of the teeth. The cavity preparation is very precisely restricted to the demineralized enamel and dentine, thus providing maximum conservation of the sound tooth structure. Use of excessive orthodontic force might have caused loss of anchorage and root resorption. In a study published by Katz, a reduction in the friction has been reported by coating the orthodontic wire with inorganic fluorine-like tungsten disulfide nanoparticles, which are known for excellent dry lubrication properties. Orthodontic nanorobots could directly manipulate the periodontal tissues, allowing rapid and painless tooth straightening, rotating, and vertical repositioning within minutes. A colloidal suspension containing millions of active analgesic micro-sized dental robots will be instilled into the patient's gingiva for inducing anesthesia, and the dentist will be able to control the amount, duration, and comfort of the anesthesia without needles. These are my references. Thank you.
Dr. Apurva, can you please tell me whether this nanorobotics is in practice or is it future?
Ma'am, actually, nanorobotics, they have started using in the medical field, but in the dentistry, it is a hypothetical situation. Like the work and the research is still going on, but right now it is a hypothetical situation.
Okay, thank you.
Thank you. And next, let us call on Janhavi. Topic is about a virtual reality in dentistry to learn and to teach Janhavi Manipal College of Dental Sciences, Manipal. Calling on the topic virtual reality in dentistry to learn and to teach. Okay. Okay. Calling back again the oral presentation of Cheranjevi Jayam, linear enamel hypoplasia. A case report.
Hello, am I audible?
Yes, you are now audible. Go ahead and share your
Just a
screen,
second.
please.
Just a second. Hello.
Doctor? Yep.
Hello.
Yes, sir.
Hello.
Yes, sir. Am I audible?
Yes, you are audible. Is my screen on?
No.
Just a second, please. 1 second. One second, please. I'm not able to load this. 1 second. Hello.
Yes, sir.
Hello.
Yes, sir.
I think there's some glitch. I'm sorry. I'm really sorry. I'm not able to load the presentation again. I'm really sorry.
No, it's no problem. Don't worries. I'll make sure to take note of your presentation and I will call you tomorrow then.
Yeah, thank you.
All right,
Thank you
no
for the
problem.
assistance.
Thank you so much, everyone, for your participation, especially to our chairs and to our guest speaker earlier, and to all the presenters today. Congratulations. And I would like to request everyone to please be here tomorrow for the continuation of our conference. And yeah, I would like to congratulate all the presenters today from all the technical sessions. And I think that will conclude our conference for today, and we will continue again tomorrow. See you guys tomorrow.
Okay, bye. See you, Jojo. Thank you so much.
Thank you so much, Doctor, for staying with us.
Bye. See you.